then cut me off. I got my hopes too high, learned how to read the signs. I knew you were gone before you left. I'll sleep alone tonight, dream till you're off my mind. I know how it ends, won't fall again. like you would never fear losing something more than my time. Forever looks like you whenever you're with me. It's easy like Sunday morning before we get to the morning. There's so much more than I am in LA. With a view of downtown and the skyline. I only do that just seeing those Now your taste is unfamiliar, but I feel like I know you. Hallelujah these days. Never felt like praising no one. I don't believe in God as much as the look in your hallelujah. Before you was just an angel of the city. You got me looking up like there's someone I can't trust. I give you every second, and I can't help but treat you like a lady. I give you every second, and I can't help but worship this angel. There's so much more than I am in LA. With a view of downtown and the skyline. I only do that just seeing those Now your taste is unfamiliar, but I feel like I know you. Hallelujah these days.
Good morning, everybody. I see some people still coming in, but we're going to get started so that we can keep our good timeline. A very, very special welcome to our speakers this morning and also our chair, guest chair, Aniki. And I'll give them formal introductions in a little bit. But first of all, some general housekeeping rules. If you weren't here yesterday, the password is Generali for the Wi-Fi. That's lowercase Generali. And also the breakfast was sponsored by BAF Insurance, and we'd like to give them a big round of applause and thank you for that healthy breakfast. Welcome to Lizette Yearwood, CEO of CIHSA, and to the various board members who were present yesterday and hopefully today. To the CIHSA staff, can we see a show of hands from our HSA people? Excellent. And what about, do we have any Health City Cayman Islands in the house? Show of hands from them. Excellent. And finally, our other large hospital, Doctors Hospital. Good stuff. All right. Well, welcome back. I am so excited because today, unfurled in front of us, is a whole day of a meeting of minds, of coming together with innovative ideas for the healthcare industry in the Cayman Islands. And we have an awful lot to talk about, some things to wrap up from yesterday, and I'm just going to go over a few things that are going to happen this afternoon, which is a little different. We have workshops this afternoon. They take place from 3:15 to 5:15 in the Grand Cayman room next door. There are two different sessions, and they're meant to be very interactive, a lot of dialogue with the delegates and the presenters. The two topics are living with invisible illnesses and One Health, which of course, I believe the Cayman Islands has now had 3 years of a One Health symposium, which is very important for this region. We've had visiting speakers as well. We really want a lot of participation in that new session, and everyone's opinion is valuable. We really welcome everyone to attend that. I also want to thank our Premium Plus sponsor, some of the members of whom are sitting in the front, Ironshore Pharmaceuticals, thank you very much. Our cocktail reception sponsor last night, Health City Cayman Islands, that was a lovely reception and delicious food, thank you. And our premium sponsors, the Cayman Islands Health Services Authority, Cleveland Clinic, Kelly Holding, and the Ministry of Education, Youth, Sports, Agriculture and Lands, of course, under which, with agriculture, we have the One Health. Thanks to Generali Worldwide for being our Wi-Fi sponsor, and Annika Brown is here to represent them. So as mentioned yesterday, we have so many sponsors and exhibitors. Please go around to all the booths, even though you think this might not apply to you. It may be something that someone in your family may need, something new that you haven't heard about. I've learned so much just in the last 24 hours. Make sure that you stop at their booths. Many exhibitors, many giveaways, many goodies. And there are also, at the very back of the room, there will be evaluation forms. We really want to make sure as this conference grows, and now that we've hit our 10th year, which is a massive achievement, we want to make sure that we keep everybody's opinions online and that we look at what we can do to make things better all the time. And finally, CME certificates are available to collect from the registration desk. So before I introduce the morning's chair, I just want to note a couple of things that struck me. First of all, about the Ironshore Pharmaceuticals, where Dr. Warrington is representing the company. I was really inspired by Ms. McDonough, the representative's talk yesterday about how we're always looking at ways to diversify the economy and the healthcare economy, and of course Health City came in with the medical tourism, and others have expanded as well, and how the pharmaceutical world can be one spoke in that wheel, and there's so much to learn with that and so much more we can do. So thanks again, Ironshore. Also, I would like to note as regards robotics, and we're welcoming back our other speaker, Dr. Gatcliffe, who's actually, I was talking to him this morning, he's been here at this conference 2 years and to Cayman 9 years in a row. So thanks, Dr. Gatcliffe. He's going to be talking about robotics, and I have a personal reflection to share on that. It was a long time ago, 17 years ago. My husband and I handed over our 6-week-old son to a team of surgeons in the US, at a hospital in the US, because he was diagnosed, the second baby in Cayman ever to have Hirschsprung's disease. And basically, it's a motility disorder, and he had E. coli and was very close to passing away. And thanks to fledgling years of robotics, but not quite as advanced as we are 17 years later, but the keyhole surgery and all of that, I now have a strapping 17-year-old who got his learner's license yesterday. So again, I'm so pleased to hear how far we've come, and that instead of, big scars on tiny infants or, delicate surgeries and big scars, what we can do with robotics, and I'm really excited to hear this presentation. So Miss Annika is the country manager, Annika Brown, country manager, generally and chair of the Health Insurance Standing Committee of the Cayman Islands. She began her career as a Cayman Islands attorney who moved into the insurance industry when she was offered an in-house position by one of her former clients. She is now the country manager and legal counsel of Generali Utmost Portfolio, running the office of their general agent in the Cayman Islands. Annika is the newly appointed chair of the Health Insurance Standing Committee of the Cayman Islands Insurance Association, representing the health insurance industry in the national discourse in relation to health in the Cayman Islands. I would like to turn over to Ms. Annika Brown.
Thank you, Nancy. Good morning, everyone. We're in for a very exciting morning, but first of all, I would love to introduce you to our first speaker, which is Dr. Lewis Warrington. He will be addressing us on a decade of advancements and innovation in the treatment of psychiatric conditions and how far we have come. Dr. Lewis Warrington, MD, is a child psychiatrist with extensive experience in CNS medical affairs, having worked for multiple pharmaceutical companies in his career, specifically in the disease areas of ADHD, schizophrenia, bipolar disorder, major depression, multiple sclerosis, amyotrophic lateral sclerosis, and insomnia, a mouthful. Lewis is currently the VP of Medical Affairs for Ironshore Pharmaceuticals, with specific responsibility for all medical affairs aspects of the ADHD products, including Journey PM, which we've heard about a bit already in this conference. He came to Ironshore Pharmaceuticals from Merck, where he had primary responsibility for medical strategy for insomnia products. And prior to that, Lewis worked for Novartis, where he was responsible for a CNS team consisting of medical directors and a field medical team covering multiple CNS products. Prior to Novartis, he was Senior Medical Director and CNS Therapeutic Area Head for the U.S. Medical Affairs at Sanofi Aventis, having responsibility for medical strategic planning, execution, and life cycle management for all CNS products in the U.S. affiliate, including insomnia, major depression, and multiple sclerosis. He also led medical evaluation for all U.S. CNS business development opportunities. Prior to Sanofi Aventis, Lewis served as medical director in U.S. Medical Affairs on an atypical antipsychotic medical team at Pfizer, where in addition to his commercial support responsibilities, he led the project team to seek an additional bipolar indication. Dr. Lewis graduated with a Bachelor of Science from East Carolina University, majoring in biology with a concentration in molecular genetics. He then worked as a bench organic chemist at Burroughs Wellcome, developing novel molecules for pharmacologic use. Lewis returned to East Carolina University to obtain his medical degree and continued on to receive training in general adult psychiatry from the University of Virginia and child and adolescent psychiatry training from the University of Florida. He then completed a postdoctoral fellowship in neuropsychopharmacology at the Mayo Clinic, primarily comparing neurotransmitter profiles between neurotensin analogs and standard atypical antipsychotics, utilizing neuropharmacologic techniques, including receptor binding and microdialysis. Thank you so much for being with us.
Thank you so much for that warm introduction, and good morning, everyone. I'd like to thank the conference for inviting me to speak to you today. And over the process of learning more about Cayman healthcare, I'm extremely impressed, and especially with the comments that were made last night. There's a lot going on here, and I think it's only going to grow from what I'm hearing. I'd also like to thank the conference for not only their devotion to overall healthcare, but also to including mental health care, which obviously would be important to me. And it's something that I think, unfortunately, is not as well regarded as it could be. So as I go through this presentation today, where we look at the advancements and innovations in the treatment of psychiatric conditions, I'd like for you to think about the people around you, the people you know, family members, friends, people like that, and ask yourself, would you like for them to be treated, identified, diagnosed, and treated if they had a psychiatric condition? Or would you rather that just be hidden and not talked about and felt embarrassed about? So as I go through this presentation today, think about that. Think about the stigma that's related to healthcare, mental health care today, and focus on ways that you can think that organizationally or maybe even personally we can combat that stigma. And I'll talk a little bit more about that as I move forward. So first, just a quick note about Ironshore. I've been with Ironshore since January, and one thing that I'm impressed with Ironshore about is their emphasis on the patient-centric approach. and a high science approach. And I think that's exemplified very nicely in the Lexus novel drug technology that we have. I'll talk more about that as we get to that point in the presentation, but essentially it contains two functional film layer coatings that allow this bead of methylphenidate to make its way through and arrive in the colon just at the time that morning is occurring to be able to treat early morning functioning. I'll speak a bit more about that. Ironshore received FDA approval for that in August of 2018. So here's the agenda for what I want to talk about today. An introduction to mental health with a focus on depression, anxiety, and ADHD. I would love to talk about all medical conditions, but we have limited time, as I can see the clock ticking off, and Anika is my timekeeper. But we'll be focusing on those three. We'll talk about the advancements in innovation in the treatment of psychiatric conditions related to those three. And then we'll talk briefly about raising awareness and destigmatizing mental health and the current and future state of mental health in Cayman Islands. So here's the description of a mental disorder, and I think people inherently know what a mental disorder is, but if you were to describe it, you would say that it's a constellation of symptoms that leads to a diagnosis. And later in the presentation, I'm going to talk about another effort that's going on in psychiatry is the DSM-5 to categorize illnesses so that they can receive better identification and treatment. But that's essentially what a mental disorder is a constellation of symptoms that leads to ultimately a disorder. It's important at every stage of life, all the way from the time one is born all the way until old age. And you can have mental disorders that are predominant in one stage or the other, but there are those that run all the way across the lifespan as well. Here's an approximation of, in 2018, of the prevalence of mental disorders in the U.S. 1 in 5 adults and 1 in 6 of children aged 6 to 17 experienced a mental illness. But I think the more important point is the next slide, which shows that only 43% of the adults and 51% of the youth receive treatment. Now that's unacceptable in my way of thinking, and this leads back to the idea I was talking about with stigma earlier. That's one barrier. There are other barriers, but that's one barrier that I think we can certainly address. Risk factors for mental illness include stress, genetics, adverse life events, biological factors, other kinds of things. And there are currently over 200 classified types of mental illness, depression, anxiety, and ADHD being three of the more common ones. One of the things I wanted to say as I was looking at these slides is this might be a good representation of what we need to get to is when people are talking together, thinking together about mental illness. And that's the point I wanted the takeaway I think that you could walk away with. So let's talk about the depressive disorders first. And depressive disorders are really an umbrella term that sits over a group of disorders that are depressive in nature. And they really focus on sadness, crying, the things that you typically think of when you think of depression. But there can be different manifestations of them as well when you get to the different types. Major depressive disorder listed first there is probably one of the most common. But disruptive mood dysregulation disorder is another one that you may not be familiar with, which is also in the depressive spectrum. You can have these associated with certain other body manifestations like menses, for instance, and premenstrual disorder is one of those that's linked to the cycle. And then you can also have depressive disorders that are due to another medical condition. And the example I think of right away is hypothyroidism. So whenever someone comes in to see a psychiatrist who has depressive symptoms, you're always going to want to think of these biological causes, and one of the main ones is hypothyroidism you should be checking for. So the prevalence in the U.S. for major depressive disorder, not all depressive disorders, but major depressive disorder, about 3.2% of children 3 to 17 and 7.1% of adults 18 and older. And then the risk factors, as I've alluded to, biochemistry, you're going to hear me talk a great deal about neurotransmitters. And so for whatever reason, be it genetic or be it some other kind of disorder, the biochemistry of the brain. You're going to see neurotransmitter differences, a reduction in neurotransmitters, an excess of those, and that's one risk factor for the development of not only depression but also anxiety and ADHD. So when we talk about treating depressive disorders and think about medications, you're going to hear me use a lot of acronyms, and I apologize if I use the acronym and don't define it for you. I will try to, and it'll either be done on the slide. But the medications, selective serotonin reuptake inhibitors, have probably come to be the first choice for most psychiatrists, most of those who treat disorders. And what that only means is that a neuron releases serotonin, and then it takes back up the excess. But if there's not enough to start with, then if you can block that reuptake, you can have more serotonin in the neuron gap where you need it, in the synaptic cleft. And so that's what reuptake means, and you'll see that listed as norepinephrine as well. It's the same process, basically. Serotonin and norepinephrine reuptake inhibitors, SNRIs, are also used. The tricyclic antidepressants are older antidepressants, but still effective. I'll touch on those a little bit more. And monoamine oxidase inhibitors, also MAOIs, are also utilized from older times, but are still useful. Psychotherapy is also utilized in the treatment of depression. Cognitive behavioral therapy is probably the one most people are familiar with. Interpersonal therapy is one that's mostly directed to depression because it deals with interpersonal relationships. The thinking there is that if I can improve interpersonal relationships, I can have a less depressive or less dysthymic kind of approach to life. That's the overall underpinning. Problem-solving therapy is another one. When you get to the point where medications don't work or psychotherapy is not making the inroads you think you need, brain stimulation may come to the fore. And electroconvulsive therapy is one older method that unfortunately has gotten a bit of a bad rap through movies and other media depicting people having seizures and uncontrollably. It's really not like that. And we should be very thankful that we have ECT should you need it, way down the line, third, fourth line when nothing else works. I'll talk a bit more about transcranial magnetic stimulation, which is another method that would be used after medication didn't necessarily work. And then the interesting thing about all of the disorders I'm going to talk about today is that treatment with a combination of medication and psychotherapy appears to work better, has been shown in research, to work better than either one alone. And you'll see that as a theme as I go through. Anxiety disorders, I think everybody knows what anxiety is, related to fear and anxiety. And it can interfere with daily work, as can obviously depression. And so here are the types of anxiety here. Generalized anxiety disorder is probably the one that's the most known, and it's the one that most of the SSRIs carry as an indication. But some of the others you'll notice, like specific phobias, like claustrophobia and that sort of thing. And you can see how that would play into how you choose your job, because if you're claustrophobic, you're not going to be able to be in a confined space. Or if you're, live in a very small apartment or whatever, it's going to affect you. So that's the way it works in one's life function. And then there are a number of other disorders there that are listed. There's a lot that are under the anxiety umbrella. The prevalence, anxiety is quite common. 7.1% of children aged 3 to 17 and 19.1% of adults aged 18. As a child psychiatrist, when I see a child come in, I always entertain the idea of anxiety. It's a major factor, especially when changes occur with school, moving, family situations, that sort of thing. And we'll talk a little bit more about that when we talk about ADHD. The risk factors are genetic and environmental. So what are the medications that you use? The SSRIs, as I mentioned, almost all of them carry an indication for a generalized anxiety disorder. The SNRIs as well, those that act on serotonin and norepinephrine. The old tricyclics were fairly well regarded for, certainly for depression, but also for anxiety. And by the way, depression and anxiety oftentimes run together. Sometimes it's hard to tease them apart. Sometimes it's very clear. But if someone comes in uncontrollably crying, the first thing most people might think of is depression. there's a lot of anxiety and panic disorder and that sort of thing that occurs in people who cry quite a bit. So you always have to be looking for that. But they do run together. Luckily, they can be co-treated. The benzodiazepines like diazepam, which is Valium, and alprazolam, which is Xanax, are probably most well known for the treatment of anxiety. They certainly work. The problem is control of them, because many times the patient can become addicted, and then you have to deal with that scenario. Psychotherapy can also be useful in anxiety disorders. Cognitive behavioral therapy is probably the one that's the most often used. Brain stimulation, much less used. There's been a lot of work in vagus nerve stimulation, and there's still situations where people can use that, but it's not as well used as medication or psychotherapy. And then cranioelectrotherapy stimulation is just a method of trying to stimulate the prefrontal cortex, which is the front portion of the brain, the most superficial portion of the brain, which does have some neurotransmitter effects, but it's not as well regarded as medication or psychotherapy. And of course, as with the others, treatment with a combination of medication and psychotherapy appears to be the best. So let's move to ADHD. ADHD is a sort of a cognitive or cortical dysregulation that occurs in a patient. It's neurodevelopmental in its approach, or in one's approach to it, and it manifests itself in inattention, hyperactivity, impulsivity. As a matter of fact, the categorizations that we use are just that in terms of ADHD. You can be inattentive, you can be hyperactive and impulsive, or you can be combined type. And just ask yourself now, and then I'll give you the answer, but ask yourself now, which one of those three do you think would be the one that the diagnosis or the problem that flies under the radar most often in children? It's inattentive, because you're not causing problems for the teacher. And I hate to put it that way, but I mean, that's a lot of times it comes to the attention of adults by hyperactivity and impulsivity, and then lo and behold, they have inattention as well. Inattentive children tend to be just sitting still quietly, but they're not really doing well, and the assumption may be that they're just not a good student, and so that's the unfortunate part of that. But I think headway is being made into the world of identifying inattentive as well. The prevalence in the U.S., 9.4% of children aged 2 to 17, and it is a longitudinal disorder. Currently, the statistics are about 60% of children with ADHD will persist into adulthood. I think that number is going to rise. I think it's going to continue to be known that it is a lifelong illness, and that maybe coping mechanisms and other things come into play that for some people that maybe not for others. But I think it certainly is a longitudinal disorder. In terms of risk factors for those, genes, in utero effects can also be caused, low birth weight, brain injuries, those kinds of things. So the medications are usually stimulants or non-stimulants, and I'll go over those later. The non-stimulants or the stimulants are methylphenidate and amphetamine. Psychotherapy is also used. Cognitive behavioral therapy is used. Family and marital therapy. And one of the things I'll just go ahead and put up for the other is coaching, education, and training. You'll notice that, and I'm focusing on the children now, you'll notice that there's a lot of parents involved in the training of the children, because the parents are reflective of what's going on in the child. As a matter of fact, to a child psychiatrist, a patient that's brought in, a 6-year-old, it's a lot of times you look at that 6-year-old as a sentinel issue of a family dysfunction. And so one of the things you want to do is look at the entire family, because the 6-year-old, in this case, is an integral part of that family and is sometimes symptomatic of what's going on in the family. So what I'm saying is, if you have a patient, a 6-year-old, who has ADHD, and they wind up interacting adversely with their parents, that will come to your attention, or at school. And that's where all these, you see on the right-hand side of that slide, parenting skills training, stress management techniques, are very useful in families where ADHD children are. Now, imagine magnifying that to say not just one child in a family, but a sibling with ADHD, because there is a genetic component, and then magnify that with a parent or parents, and everybody has ADHD. So you imagine what those mornings are like when people are trying to get organized. So think about what you had to do to get here today. You had to get up, you had to be organized enough to bring everything with you. I don't know if anybody forgot anything, but I'll bet we have less than 1% of this entire room who forgot anything. But if this was a whole room of ADHD patients, there would be a lot higher percentage of people who forgot things, because the disorganization is a problem, and we have a way to address that. And then, as I mentioned earlier, treatment with a combination of medication and psychotherapy has been proved to be the most effective. So let's talk about the advancements. And before I talk about the individual advancements, I want to talk about the diagnostic, well, this is an advancement, the Diagnostic and Statistical Manual. Have people heard of the DSM before? Raise a hand. Yeah, not many. So the DSM stands for Diagnostic and Statistical Manual, and what that is it's a guideline for clinicians who diagnose and ultimately treat psychiatric illness. And the reason why it's statistical is because every time that a new revision goes into effect, statistical aspects of the particular symptoms that make up a disorder are taken into effect. And you can see on the right-hand side of the slide the rather Herculean efforts that are going on every time that a DSM is being revised. We're currently on DSM-5, and a lot of revisions. This actually took nearly a decade of preparation to get there, if that tells you anything, and a lot of work, as you can see on the right-hand side of the slide, to arrive at that. The point is that more and more advancement is being made in refining these disorders. And I can just tell you, in my relatively short career, a lot of refinement has been made on how we look at particular disorders based on the revisions of the DSM. So let me just take you on a very quick tour, so to speak, of where we've come from, because we have to figure out where we've come from to figure out where we're going. And so back in the 1950s, you've already heard me mention the MAOIs. Perfectly good antidepressant. Tranylcypromine is one of them, for instance. It has dietary restrictions, though, and so you have to be really careful that you don't drink wine or eat cheese. So, don't live in France if you're going to be in the MAOI. The tricyclic amines I've already mentioned, so named because the molecular structure has three sort of tricyclic benzene rings in the middle. Old antidepressants, perfectly good antidepressants, but they had a fair amount of adverse events, and it's also not safe in overdose. And that's something that psychiatrists have to take into account, unfortunately, is if you take a large load of tricyclic antidepressant, you have to go in the hospital and be cardiac, and you have to be monitored. 10 minutes, really? You sure? It says 24. Okay. I'm going to speed this up. The SSRIs in the 1990s was a really big. So Prozac, which is fluoxetine, everybody will probably recognize. And then as we move to the 2000s, the SNRIs like Effexor, venlafaxine are probably the most popular ones. There's a lot of unmet need for depression and anxiety prior to the past decade. Partial responsiveness, treatment-resistant depression was a big one, and we do have advancements in those arenas. In addition to that, there was also in drug development, there's also challenges as well, and you see some of them listed here: the changing landscape of disorder definitions, pathophysiology changes or changes in understanding, especially neurotransmitter chemistry, rising costs and increased regulatory processes. But having said that, there are a number of improvements that have been made, and I'm not going to go through these exhaustively, certainly not now that I've been given the 10 minutes. But you'll see the trend as we go through. So Vibrid, for instance, is an SSRI for the treatment of major depressive disorder. This appeared to have some advancements in the treatment of anxiety, so coexisting anxiety was their claim. And also, less adverse sexual effects. The initial SSRIs like Prozac and Zoloft had a lot of sexual dysfunction associated with them, up to, say, 15-20%. And so that was obviously an adverse event that has to be contended with. When you move to, I just mentioned treatment-resistant depression was an unmet need. You can see on the slide here, aripiprazole, which is a partial agonist at dopamine receptor. A number of the atypical antipsychotics, of which aripiprazole is one, are used now for adjunctive treatment of treatment-resistant depression. And so you'll already be on an antidepressant, you add in an antipsychotic. So that was an advancement as well, and that's just a representation of one of those. Fetzima is an SNRI. This also carried an indication for pain. Early on, the tricyclic antidepressants were actually used for pain, especially back pain. And so this is sort of coming full circle now to where antidepressants are actually looking for pain indications as well. Trintellix, an SSRI that was approved in 2013. This one is put in here because in addition to the reuptake inhibition that I also mentioned, they're also targeting specific serotonin receptors. So 5-HT1A just stands for 5-hydroxytryptamine, which is serotonin. So that is a subtype receptor that they're targeting. And you can see they can get increased measures of executive function, attention, speed of processing, and memory improvement, which is important because in depression, you often have concentration problems, especially in elderly. So this was a bit of an advancement there. The one that I wanted to focus on has probably been the one that's been watched for the longest is Spravato, which is esketamine. And you probably recognize the ketamine part, an old drug that was used as an anesthetic, was developed as an anesthetic, had a lot of problems with dissociative properties, adverse events. It made people feel like they weren't associated with their bodies, so to speak, detached from reality. So it was not a good anesthetic. People did not like it. Now, some people have abused the agent, so apparently some people do like it. But what this was noticed to be, though, was that it had effects on depression, and especially treatment-resistant depression, and especially faster than most other agents, which, the fight is on to beat the 6 to 8 week period of treatment for depression. And this made a breakthrough, at least in that arena. It also helped in people who were suicidal. And this is incredibly important to a psychiatrist, because if you present to me and you tell me I'm depressed and I see that you're crying, you don't have any pleasure in things that you're doing anymore, and you're suicidal, and you have a plan, what am I going to do with you? I can do nothing but hospitalize you for a period of time until that abates. At least agents like esketamine are moving towards trying to get us to the point where we can resolve suicidal thoughts more rapidly. So I see that as a major advancement. And then I mentioned on the previous slide when we were talking about unmet needs, the fact that there was nothing for postpartum depression. Now, postpartum depression is not only affecting one person, it's affecting two, and maybe even families. Thank you. 5 minutes now. Thank you. So the race was on to try and treat postpartum depression because the stakes were high, and that's an important feature. Zulresso is an attempt to do that. This is a neurosteroid that has to be administered over 2.5 days IV. And so it's under a REMS program, which is a risk evaluation and mitigation strategy. Only certain centers can do it. Spravato is as well for these agents that are tackling the harder to treat conditions. But that's a major advancement as well. So let me just take you through the psychopharmacology evolution for the treatment of ADHD in the past decade. And so you can see starting back even in the 1930s was the first ADHD medication, Benzedrine. But since that time, it's been really mostly focused on the delivery systems, immediate release, intermediate release, extended release, trying to move the time that they were treated from just in school to other times. But unfortunately, the morning, as you can see in the upper right-hand corner of this graphic, the early morning functioning was still not there, and was still a very large unmet need, as I mentioned earlier, how difficult the day is. The morning is the start of the day, and very difficult. I now have 30 minutes. You should take a vote and see if they want 30 minutes.
I need a new clock.
Okay. I thought that was short, but thank you.
Time expands in Cayman.
It does, doesn't it? It does, doesn't it? And this is encouraging for you. Now you can additional time. So now, okay, so I can slow a little bit. So there were limited non-stimulant options in the prior to the past decade. The duration of action, as I mentioned earlier, was not just during the time of school. That was an important time. But ADHD stretches into the morning, stretches into the late afternoon because kids have after-school things, they have homework, and into the evening they have sports and other things like that extend the day, and even into the night. We know ADHD does have effects on a patient's sleep. So ADHD affects a child around the clock, and the unmet need was that early morning functioning was not addressed as well as it could be, and then onset of effect is a related topic to that. So in a similar manner, what I want to do is just go through these agents that have occurred that have been approved for us in the last decade. Not to go in depth in them, but just to point out trends as I move through these. In 2012, Quilivrant XR, which is a liquid methylphenidate, was approved. And you can see that one of the things that's interesting, you just heard me talk about delivery technology. So this is methylphenidate, so well-known drug. But you can see that they have a combination of 20% immediate release and 80% extended release. So this is a combination of, and that's one approach to drug technology to try to improve the time. So you get an immediate period, and then you get an extended period, which would, work towards trying to cover the day. However, notice that the onset of effect is 45 minutes, and the duration is still 12 to 13. Quilachew ER came out, which is a chewable methylphenidate, obviously an advancement, obviously an improvement, because we all know there are some kids who just don't want to swallow pills whole. But still, yet again, a 30% IR and 70% ER methylphenidate combination, and onset of action is still 45 minutes. So the point I'm trying to make about onset of action is that when you get up in the morning, you have to, as a parent, you have to determine, how am I going to treat my child? Do you start as soon as they wake up? Do you show up at the bedside with the pill and with the liquid? And then that's going to take a period of time. Well, then how am I going to get out of the house? What time? Do I allow for that? Do I have to get up earlier? That's just a consideration that I wanted to make as we go through these. Adzenys came out with an ODT as an orally disintegrating tablet. Yet again, a good method for children to use, but yet again, 50% IR, 50% ER, and now the onset of effect is 1 hour. Vyvanse came out with a chewable in 2017. Once again, onset of action is 1.5 hours. Duration of effect is 13 hours. Adzenys, yet again, came out with an ER. This is a liquid amphetamine for patients who cannot swallow pills. 50-50 ratio again of IR and DR. Onset of effect is 1 hour. And Mydayis came out with a number of beaded processes that contained an IR and DR layers. But yet again, now the onset of effect is 2 to 4 hours. I'm not really sure how effective that's going to be for even getting a child to their first class in time to be able to have an effect. But then we come to the medication that was made in your own neighborhood, Jornay, which impressed me quite a bit when I joined the company, because the company described this early morning and said, unacceptable. It doesn't make sense that a child has to go through that period of time where they don't have coverage for the morning. And so the technology Delexis was made the only medication that's dosed at night, the only formulation that's dosed at night. And that bead that I described that you can see in the inset there in the lower right is made of a delayed release, extended release, and a drug core that's designed to get the drug through the small bowel down to the terminal ileum, at which point the DR layer is effectively taken off. The ER layer then forms pores as it moves into the colon. This is actually absorbed in the colon, whereas the other agents are absorbed in the small intestine. It also creates a little bit of a different PK profile as well. But what it results in is the next morning when the child awakens, they are medicated with methylphenidate. And so they wake up able to go about the day. And so that's a real advancement that I think you should all be proud of, since the company is located right here in Cayman, an advancement that you can boast about with your other country friends. And the last is Adhancia. I'll just mention yet again is a 20%, 80% combination, and the effect is within 1 hour. So none of them coming close to trying to treat in the morning. I mentioned the non-stimulants, and I've got those listed here. The first one is guanfacine, which is an alpha-2 agonist, and this is these medications, the non-stimulants, the two I'm going to show you primarily, are used as adjunctive treatment when you're not getting all that you can get from your stimulant medication, or if the patient winds up not being able to tolerate the dose that you need to give them to get an effect. The next medication I'll mention is Capvey, which is clonidine. Clonidine was a very good antihypertensive, an alpha-2 agent. The only problem is that it had sedation. But the alpha-2 effects appear to have some good effect in children. It's been around for a while. It's hard to dose, but it's a good option to have when you want adjunctive control. So let's just turn now to talk about brain stimulation, and I'm mostly going to talk about transcranial magnetic stimulation. That's the main one that I like to focus on. ECT I've already mentioned. I'll put a plug in for that. And I'll tell you a very rapid anecdote. I had a patient when I was in residency who was an elderly woman, about 68 or 70 years old, had depression, had very fretful depression, the kind of depression where you sit in a jerry chair and you reach out to people and you moan and wail as you're holding on to them, and crying, a lot of crying, very sad situation. We hit her with as much antidepressant and adjunctive treatment as we could over a period of 2 weeks, and made no dent in her depression whatsoever. She was also suicidal. Her husband came, she was a former Miss West Virginia, by the way. Her husband, very much in love with her, came with her, and I had to break the news to him that we had, the treatment team was talking about ECT. And he had heard about the bad press. He had heard about seeing the movies and that sort of stuff. I explained to him it's not done that way anymore. You're inducing a seizure, but the patient doesn't experience a seizure. And she underwent 6 treatments and was back to her old self. She had no adverse events, although you can get some adverse events of memory loss and that sort of thing, especially if you have multiple treatments. She only had 6, which is toward the lower end. And his comment to me was, I have my wife back. And that is why I say we should be very thankful that we have ECT if we need it. I will show you, though, that 10 minutes now. I will show you, though, thank you. I will show you, though, now there is an advancement in the treatment of depression and also other disorders, OCD in this particular case, but they're also investigating others. But you've probably seen this before. It's the transcranial magnetic stimulation. And the idea here is to use magnetic pulses over the cortex of the brain in various forms, and I'll show you there's different mechanisms with which to do that by different companies. But the idea is that you stimulate the local neurons to release neurotransmitters, and those local neurons then stimulate deeper neurons, and you finally get to the areas, the limbic areas of the brain where depression is housed, and so you can get improvement in those over the course of a period of time. The adverse events appear to be fairly low. Right now, this appears to be being utilized second line, though. I guess one could choose. I don't see it listed as second line, but it's being used, I think, as second line behind medication and behind psychotherapy, which I consider both of those to be first line. Brain's Way came out with their version, and they had they call theirs deep TMS, or deep stimulation, because they feel like they're getting a deeper penetration. They also have two different helmets that you use, one for depression and one for OCD. They're indicated for OCD also. And then there's a final one, the Horizon mechanism does not appear to be significantly different from the NeuroStar one, although if you go on their website, they make a lot of noise about it being cost effective. So that's, if that's what you're looking for, that's what you would go to. There has been one innovation in brain stimulation in the treatment of ADHD. I don't think it's well utilized. It's by a company called NeuroSigma, and this is called the Monarch External Trigeminal Nerve Stimulation System. And so what you're doing is stimulating the branches of the trigeminal nerve through a relatively handheld device that you can see there, that then stimulates the frontal cortex through a patch, the trigeminal nerve through a patch that's attached to the forehead. This is done during periods of sleep each night. They have neuroimaging studies that do show the brain regions that are affected appear to be favorably affected, but I don't see much movement in the use of this. It still appears to be overwhelmingly in the majority of the stimulant medication and the adjunctive treatments if needed, and the psychotherapy that goes along with it. So let me turn to psychotherapy, because we've seen how important it is when combined with medication for depression, anxiety, and ADHD can enhance the effect of any one alone. So you see the walk that went through there, basically deriving different versions of psychotherapy to try and get closer and closer to a particular patient's circumstance. And I want to point out two that have come to the fore in the past decade. The first is called eye movement desensitization and reprocessing. The idea here is that one takes traumatic events that you may have experienced in the past, and as you think about those, you are prompted by the therapist to move your eyes in certain directions repetitively. And when you do that, the thinking is that you restructure the memory of the traumatic injury and put it back into its proper place where it should go, instead of being in a different place. And you can think about this for yourself. I know in the United States and maybe even here in Cayman, everybody knows where they were when they heard about the 9/11 events. And so, or if you go back further in history, when Kennedy was shot, everybody knows that's called a limbic memory. And so the traumatic events can live in there. This is a method to try to reprocess that. There's another type of psychotherapy that's come to the fore recently that's called dialectical behavioral therapy. This was a form of cognitive behavioral therapy that was used in the treatment of certain personality disorders that did not have quite the effect it was thought was needed. And so you can see the different modules there that you're targeting: mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. So somewhat similar to some of the other therapies, but targeted directly. So I'm going to talk about advancements in the pharmacogenetics and pharmacogenomics, and I wanted to use this example of cytochrome P450 enzyme. So cytochrome P450 enzyme system lives in the liver. It's what you use to metabolize substances, I'll put it that way, but a drug is a substance, and so that metabolism of drugs occurs through these pathways, and they're named CYP. And here I'm looking at CYP2D6 and C19. The point of putting these up is that a lot of work has been done in trying to effectively understand if there are certain deficiencies that occur in these CYP enzymes such that you can't metabolize drugs. On the right-hand side of the slide, you can see the different drugs that go through these pathways. And so if I had difficulty with my 2D6 pathway, fluoxetine may not be the drug that I would want. And you might want to think of a different choice for that particular thing. More and more work has been done in this regard to try and understand the different makeup that people have. Another area that we've already talked about, telemedicine, but in this particular case, telepsychiatry is coming to the fore as well. particularly suited, I think, for psychiatric patients because a lot of them don't want to leave the house, they don't want to have interactions and that sort of thing. And this is a way to try and get them to interact, whereas they would not. If they were tasked with having to get out of the house and go to see someone, go into a building and interact with people, they may not do it. Telepsychiatry, they may be more likely to do. Online therapy, obviously, is another method through which people can connect and receive help, user-friendly, reduced cost as well. Internet support groups is a way for people with common disorders to get together and understand, I'm not the only one, commiserate, if you will. It's another important area to move to. And mobile applications are just now coming. There's an app for everything. And so we're even exploring the idea of getting a text to help with compliance, as are a lot of other people. But there's a number of mobile applications that are being developed now. So let me just talk about the destigmatization that I mentioned earlier, increasing awareness. I just want you to focus on the consequences right here of stigma. And ask yourself again, go back to that question that I asked you before. Ask yourself again, would you want a family member, yourself, a coworker, to suffer any of this? Reluctance to seek treatment, lack of understanding, fewer opportunities for work, school, social activities. There's no reason for it. And some of it is pure stigma and only stigma. So how do we reduce that? Raising awareness is one way. Obviously, there are plenty of organizations. The World Health Organization has organized the Mental Health Day. There are a lot of depression screenings that go on at different times where people are encouraged to screen themselves for depression. Literacy, understanding what these particular psychiatric disorders are, understanding how it could, I just showed you the statistics. Those are not statistics from someone else. Those are statistics from us. That comes from all of us. And so it could happen to you. Protest, the depiction of psychiatrically ill patients, the comments about, don't be crazy and those kinds of things are disparaging terms. So protest would be, don't use those words. Those are not acceptable words. Advocacy is obviously advocating for the patient in the case of psychiatric, and social contact is an important feature as well. So there are a lot of nonprofits that are on the island that are already working on reducing stigma, and they're listed here for you, and I'm sure you recognize these. And then as far as the current and future state of mental health in the Cayman Islands, more data is being collected. That's obviously important. You look at some of the Icelandic countries where they have incredible databases and they're able to do a bunch. So that's already being started here in Cayman. Groundbreaking for the first long-term residential mental health facility. Fiona was telling me about prior to this what it meant for someone in Cayman to not have a facility here and having to go to another country. There's no reason you would have to do that. Novel treatment options continue to be developed globally and even in your own backyard, as in the case of Journey, and I would invite you for more information to come out to the booth. And there's significant progress to be made, but I think you can applaud the efforts that have been made here in Cayman, and thank you for your time.
Thank you so much to Dr. Lewis for that informative presentation and seamless presentation in spite of our clock malfunctions at the top here. Also, thank you for your patience. But we will probably not have a question and answer session for this session just because it's been, we are a little bit over time. But we do invite you to please visit the Ironshore booth. It's right outside these doors at the far left, and have a conversation with representatives from Ironshore. There's a very strong presence from Ironshore today. So please feel free to stop by. But thank you very much, Dr. Warrington. Thank you for your informative presentation. Happy birthday to Ironshore on your 10 years in the Cayman Islands. We have a bit of a little gift on behalf of our conference, which is also 10 years old this year. And for you. straight into the next session, and I've actually promised Dr. Gatcliffe that I will not give him a heart attack with the time. I do now have my phone, so I have backup. But Dr. Troy Gatcliffe, MD, is a part of the Gynaecological Oncology team at the Miami Cancer Institute at Baptist Health, South Florida. He earned his medical degree from the Royal College of Surgeons in Dublin, Ireland, and completed an internship and residency in obstetrics and gynecology at Boston University Medical Center in Boston, Massachusetts. Dr. Gatcliffe then joined the faculty at the University of Texas Southwestern Medical School, Parkland Hospital in Dallas as an assistant professor teaching the largest obstetrics gynecology training program in the country and earning a National Faculty Teaching Award. He completed a fellowship in gynecologic oncology at the University of California, Irvine Medical Center in Orange County, California, where his research interests included molecular signaling pathways in ovarian cancer and chemotherapy of cervical cancer. Board certified in gynecologic oncology and obstetrics and gynecology, Dr. Gatcliffe is a fellow of the American College of Obstetricians and Gynecologists and the American College of Surgeons. He offers minimally invasive surgical techniques, including robotic surgery, for all complex gynecologic and women's reproductive cancer diagnoses. He has a strong professional and personal interest in caring for the patients from the Caribbean and Latin American area regions, and has lectured throughout the West Indies and worked with public and private sector physicians in several countries to raise the standard of healthcare for women with gynecologic cancers. Dr. Gatcliffe was born and raised in Trinidad and Tobago. We welcome him back to the Caribbean for our presentation this morning on gynecologic oncology. Forgive me. You will be speaking to us on the rise and fall of robotic surgery.
Versus Jesus, or why do you believe in alternative medicine versus conventional medicine? And a lot of it has to do with what you're exposed to, as well as the number of biases that we as humans have that sort of colors the information. I think the big question is, why do you believe certain things? Why do you believe in Allah versus Jesus, or why do you believe in alternative medicine versus conventional medicine? And a lot of it has to do with what you're exposed to, as well as the number of biases that we as humans have that sort of colors the information we receive from the world. A large portion of it's geography, right? So if you're born in Oklahoma, you're much more likely to become a Christian than you are a Hindu, simply because everyone else around you is a Christian. But in terms of the specifics of our beliefs, they're very, very highly driven by, what we're imprinted with early. So, those people that are around us, as well as the fact that we naturally, as humans, seem to have these pieces built into our brain that want us to believe things that are not necessarily backed up by the evidence. There's been some very, very interesting research over about the last 15 years or so that has cleverly shown that children, I'm talking here under 2 years old, seem to be naturally wired to believe in things that are not necessarily actually there. And that certainly helps contribute to our belief in supernatural things later in life. I think one of the things that you have to do if you're trying to help other people see that maybe what it is that they are thinking is not necessarily accurate is you don't go up to them and say, hey, you're wrong. That's a completely wrong thing to do, and we actually know that from research, is it's called psychological reactance. And I'll just say, hey, screw you, I'm double right now. So instead what you have to do is you have to help them understand, why is it that I believe these things, and why is it that you believe what you believe? I'm a huge fan of the scientific method. I think one of the best things that our culture has produced over the last 400 years is the scientific method. And the reason is because what the scientific method does is it takes all of these biases, all these heuristics that we're naturally prone to, and it helps to eliminate them. It helps to control for all the things that we as humans naturally do so that we don't fool ourselves. And that's the key to any sort of real understanding of things, is not just, oh, well, here's my evidence for it. It's, well, here's my unbiased evidence for it. For me personally, it's about seeing the world as it is, not as I want it to be. And I think the world would be a much better place if all of us were trained in how to think critically, in how to think rationally, in how to logically examine questions, and not just find what I want to believe, which is what we do naturally, but find what actually is or what actually isn't, so that you do so in an unbiased way.
Good morning. You thought this was a talk on surgery. Why should we be looking at that clip? Today is a pretty special day for me. It's 9 years that I've been coming to Cayman and 20 years that I'm a physician, but it's the first time that my wife will ever hear me speak. Yeah. So, Carolyn, this talk, if you're somewhere in this room, this talk is dedicated to you, my love. Thank you for your continued support. It's nice to see everyone here. Thank you for giving us your morning. I put that clip up because I'm going to talk a little bit about belief bias, because we in the world of robotic surgery are in a conundrum. We are in a mess right now in terms of one of the aspects in which we use robotic surgery, which is for the treatment of cervical cancer. So I have no financial disclosures. So to get right back to the psychology of it, belief is powerful, all right? The belief bias is the fact that we give value, weight, strength, and importance to an argument, not based on whether the argument is valid, but based on the conclusion that we already believe to be possibly, probably true. So if we agree with a view, we seek data points that support our position. My dad in Trinidad thinks Donald Trump is the greatest president in the history of the United States. Guess where my dad gets all of his news from? Thank you. All right. So you see, we seek points of view that align with what we want to believe is true. So what someone wants to believe is true, they believe it into truth for themselves. But truth and beliefs are actually different, and they need to be discerned. So the belief bias effect has been one of the most studied concepts in psychology now for almost 3 decades. It was first described way back in '89. So to just run through this for you so that you can be settled and ready to go through some of the data that has turned the world of cervical cancer surgery on its head. The belief bias effect is a tendency to be influenced by our knowledge about the world, by evaluating conclusions and to accept them as true because they are believable rather than because they are logically valid. So let's look at the 2 syllogisms up there. All right, I want you guys to follow this with me. There are 2 syllogisms up there. One is, all flowers have petals. Roses have petals. Therefore, roses are flowers. The other one is, all fish can swim. Tuna are fish. Therefore, tuna can swim. If you follow the logic of those 2, many of you said right up front that the first one is true. It's believable. It's believable because we all know roses to be flowers. But that syllogism, the logic of that syllogism, can't be used to deduce that roses are flowers. Only the second syllogism is actually logically valid. So here are 2 indeterminate syllogisms. This is a little experiment that's been run many, many times by psychologists. They are both constructed in exactly the same way. So all flowers have petals. Pennies have petals. Therefore, pennies are flowers. All roses have petals. All flowers have petals. Roses have petals. Therefore, roses are flowers. They're both constructed in exactly the same way. Now, when you run this in an audience, most people think, I'm not sure what pennies are. What's a penny? But maybe this guy up on the top there knows what he's talking about. So pennies are flowers. Do we think pennies are flowers? But pennies are pasta. So if most people look at that, most people come up, well, I'm not sure. I'm not going to conclude that pennies are flowers, but he sounds great because he's up there and he's an authority. He knows what he's talking about. A whole bunch of you would have thought, well, yeah, pennies are flowers. Now, when we run it the opposite way, it's the same syllogism, But most people in the audience, because of our experience and our beliefs, automatically assume that roses are flowers based on that logic. But in fact, you can't deduce that from the way the syllogism is constructed. So the belief bias in medicine is very powerful. The drive to accept believable conclusions in the face of inconclusive results is very strong. And even well-substantiated conclusions may be difficult to accept if they counter our beliefs. So why am I talking about all this psychology at the beginning of this talk? Why am I taking you through this? Because we have been turned upside down in our heads. I'm a gynecologic oncologist. I take care of women's cancer. I use robotic surgery every day to take care of women with cancer. But in one aspect of the cancers that I take care of, particularly cervical cancer, our notion of using robotics for cervical cancer has just been turned upside down on its head. And the truth is that we don't know what to believe. So I'm going to present to you the data as it has occurred over the last decade. And then we're going to talk about what we should think and how we should believe it. So the question is, when is it time to reject a long-held belief? Is a technologically advanced surgical method that does, in fact, reduce perioperative side effects, must that be better for patients? Is it better for the cancer outcomes of the patients? And so here's what has happened. Let me just take you through the journey. We have been moving on a journey since the 80s towards less and less invasive surgery. So surgery used to always be performed through open incisions. And in fact, in cancer, those incisions are never horizontal. They're often big midline vertical incisions. Then we moved to vaginal surgery. And gynecologists would start taking things out through the vagina with no incisions. Then in the 80s, we moved into the world of laparoscopy. And I'm going to review that in a quick video so that people can remember and know exactly what laparoscopy is, because robotic surgery is merely just another form of laparoscopy. It's just laparoscopy 2.0. Then we had robotic surgery, and I'm going to show you a little bit of robotic surgery in a second, because that's not the main intent of my talk, is to show you the data that's turned all of us upside down. So minimally invasive surgery, laparoscopic or robotic surgery, has been around now and was already described all the way back in the 80s, right about when laparoscopy came out. Oncologists started adapting this. So it's been almost a quarter of a century that we have been using laparoscopy in the field of gynecologic oncology. And in fact, in the United States, importantly on this slide, you'll see that the bottom arrow here is laparoscopy. Never really got massive uptake. But as soon as the robot became approved for use in gynecology, not necessarily in gynecologic surgery, but in gynecology, it was in 2006, the year that I entered fellowship, minimally invasive surgery in gynecologic oncology, as well as in just general gynecology, but I'm an oncologist, so that's what I'm speaking about, took off. And open surgery took a steep decline. That's the red curve. So now we have done millions of robotic surgeries all over the world. And robotic surgery is indeed very, very sexy. So many of you have heard me over the years come to Cayman and talk about robotic surgery and gynecology because it sounds so awesome. It's the most wonderful thing to say that you went and you had a robotic surgery, and the technology is so cool and it's really cutting edge, and it makes you feel like you've gotten the best that medicine has to offer. And in fact, in many fields, it is the best that medicine has to offer. So the known potential benefits, perioperative, patient-centered benefits that have to do with recovery and doing better after surgery, are not disputable anymore. So the fact that you don't have to have a large incision, you can have these tiny little incisions, the fact that you may go home from the hospital within 24 hours, in fact, many hysterectomies that I now do just for benign reasons, say for fibroids or for endometriosis, many of those patients actually wish to and want to go home on the same day. And I've been sending patients home on the same day after robotic hysterectomies for about 3 years now. All of these things are the fantastic side effects of having a minimally invasive robotic surgery that are patient-oriented, but we never really had been looking at the survival outcomes specifically related to certain cancers, and that's what's turned us on our head. So here's me in the operating room on Wednesday, just gone by. So just to take you through what robotic surgery is, it's basically laparoscopy 2.0. All right, so robotic surgery involves placing trocars, just like we do for laparoscopy. So the belly is insufflated with carbon dioxide, and that creates space for the surgeon to work. So a whole lot of gas is pumped into the abdomen, and it creates the abdomen into a big dome. Looks like the patient is pregnant. Trocars are placed. And then what happens is we place the patient, if you want to know, for pelvic surgery into a very steep Trendelenburg. We put their legs in the air and we put their heads down. And what does that do? It causes the bowels to fall out of the pelvis and into the upper abdomen so we can see all of the pelvic anatomy. So your bowels are like a barrel of snakes. They just move around when you move the patient. So if you tip the patient on her head, the bowels fall out of the way. Now you can see everything. Here we are bringing the robot in. The robot is sterilely draped. So we use the same robot over and over again for multiple surgeries. And the robot is kept sterile for each patient because the arms are draped in sterile plastic. The robot is driven over the patient. And then we dock the robot onto the patient by connecting the robotic arms onto the ports that we've placed. So what you used to have to do with conventional laparoscopy is the surgeon stood at the bedside and just manipulated the instruments right there at the bedside. And let me tell you something, it would kill your back. By the end of the day, you'd have a crick in your neck. And you'd go home and you'd beg Carolyn for a massage, you know? And it was really tough on your body. It was really hard to do. Now what happens is the surgeon is still there. The surgeon's still in the room. In fact, you saw me, putting the trocars in. Here's my assistant attaching the robot to the trocars. Now what I get to do is after I put the trocars in, I can take off my gown. I can take off, all the sterile stuff. And I'm going to go and sit at a console right in the room, right next to the patient. And I'm going to have the robot control the arms. So it's just laparoscopy 2.0, and there you can see the camera going in, and now we can see inside the patient. And what I get to do, rather than what used to happen in the past, is instead of looking at a two-dimensional screen, I go and I sit in this console, and I get a 3D, high-definition view that looks like I'm in a virtual world that is really the patient's abdomen, and it is completely mind-blowing the first time you put your head in this thing. So for surgeons, this is like the best thing since sliced bread. I mean, there's nothing better. There's nothing better than doing this. So this must be great stuff, right? You gotta use this. We gotta use this. So to give you like 10 seconds, this is what I'm seeing inside. I'm moving the instruments and I'm doing the surgery, and the robot is moving the instruments for me, and I'm sitting right next to the patient and I'm operating away. I get to be not sterile, and it's wonderful. So robotics is used in many, many different fields of medicine, not just gynecologic oncology. And it's used in many, many different ways just in gynecology alone. So we take fibroids out with it, we take endometriosis out with it, we take ovarian cysts out with it. And the advantages of robotic surgery are now beyond repute in terms of the perioperative advantage for the patient in terms of smaller incisions, faster recovery, and so on and so forth. So we started getting some data, some real outcome data with some survival data about maybe 10 years ago, 5 to 10 years ago. So the Belgians, this is just a couple of the studies, there's many, but the Belgians showed us their experience, we looked at the outcomes, and what we found is that, yeah, we all thought, why not? Let's use this for cancer. I mean, it must be good because it's such a great surgical technique. None of these studies, though, that spurred us on to bring it into the use for cancer were based in any randomized control trials. They were not prospective studies. They were mostly surgeons or single institutions looking at their outcomes. Now, some of the first survival data that was published was not really well published. It really was just perioperative data. And so we saw kind of the same stuff that we knew before. There's shorter operative times, there's less morbidity, patients stay in the hospital less, but we were never really looking at the cancer outcomes. So everybody thought, well, yeah, let's just use this for cancer. It's great, right? So the NCCN, the folks that govern the way we practice medicine for cancer in the United States, started to say, well, radical hysterectomy procedures may be performed. This is in 2014, right? This is 5 years ago. May be performed via laparotomy or laparoscopy, and laparoscopy or robotic surgery is acceptable. So right then and there, we kind of got like a carte blanche. Well, the NCCN is saying, you know, you can do open surgery, you can do laparoscopic surgery, and you know, I mean, the robot, I mean, oh my gosh, it's fantastic. Let's use it. So here we go. The guidelines now say, sure, go ahead. You can do either. And then a meta-analysis comes out. So those of you in the room that are scientists and those of you that follow statistics, a meta-analysis is a review of all the preponderance of data that we have. So in 2017, 2 years ago, a meta-analysis comes out using 23 studies. 23 studies. And all of them are retrospective studies. None of them are prospective randomized controlled trials going forward. But the meta-analysis says that blood loss is less, hospital stays are shorter, return to normal activity is faster, transfusions are less, bladder catheterization is less, and the overall survival has a tendency to look better in the laparoscopic side of the equation versus the open side of the equation. Now, if anybody in the room is a statistician, the line here represents the confidence interval of 1. When confidence intervals cross 1, they're not necessarily statistically significant, but they may be showing some kind of trend. Okay, so we look at this and a meta-analysis comes out, all retrospective, and now we think, yeah, we're seeing that using robotic surgery in cervical cancer is a really reasonable thing to do. So we were all waiting for this study that was started in 2008. This study was presented last year at the Society of Gynaecologic Oncology, and it was finally brought to publication, although it was out in abstract form and in oral presentation form since the SGO last year in March of 2018. It went to publication in the New England Journal of Medicine, one of the most high-impact medical journals in the world, and its main author is Pedro Ramirez, who is one of the main proponents of robotic surgery and its use in the world of oncology. Fantastic surgeon, highly, highly decorated and respected physician. And he runs a randomized control trial that is looking at robotic surgery versus open surgery. It's a multinational study. It's being performed at multiple centers across the world. And in fact, the publication is so important that the New England Journal calls it one of the 30 most notable articles in all of medicine, not in oncology, not in cancer, in all of medicine. And why? I'm going to show you why. So the primary objective of the LAC trial, as it's called, the laparoscopic abdominal cervical cancer trial, comparative trial, is to look at disease-free survival at about 4.5 years in patients who underwent a total laparoscopic or robotic hysterectomy versus a total abdominal hysterectomy. So this is comparing old-fashioned surgery through an open incision to a minimally invasive approach, either laparoscopy, where the surgeon stands at the bedside and manipulates the instruments, or robotics. Remember, laparoscopy and robotics are similar. Robotics is just kind of laparoscopy 2.0. It is a randomized trial, and in fact, the trial was not necessarily randomized in the way true randomization should be done, and we'll talk about that in a second. But it takes into account cervical cancer patients. So this is a cervical candidates who can be given surgery for cervical cancer in the first place. Because once you cross a 1B2 into a 2B cervical cancer, those patients must be treated with chemotherapy and radiation. They're not surgery candidates. So these are appropriately selected cervical cancer patients who are randomized to either going and having an abdominal hysterectomy or a laparoscopic hysterectomy. The trial is closed prematurely in 2017 by the Data Safety Monitoring Committee. All well-performed randomized trials have a separate panel of physicians, separate from the investigators, that are not letting the investigators know what's going on with their data. They're following the data kind of in secret, and they're looking at what the results are as the results are evolving. And if there is a signal, a strong signal, that something is really, really earth-shattering about the data, they can choose to unblind the trial and publish the data, or actually bring the trial to a screeching halt. And the Data Safety Monitoring Committee of this trial forced the trial to close in 2017 when all of the people who needed to be accrued and randomized into the two arms were not yet enrolled. So to give you a little an idea of what happened, there were two groups. They were roughly equivalent in terms of the weighting of the two groups. And 274 underwent open surgery, 289 underwent some kind of minimally invasive surgery. In medicine, this is a big trial. These are big numbers. In order to perform a surgical trial, these numbers are large. And the trial was initially appropriately powered if it had been fully accrued to detect a true difference between the two. But remember, the trial is closed prematurely. And everybody that needs to be enrolled, all 720 patients that needed to be enrolled to the trial, were not fully enrolled into the trial. And in terms of the distribution in the minimally invasive arm, most of the patients in the minimally invasive arm actually underwent old-fashioned laparoscopy, where the surgeon stands at the bedside and not robotic surgery. So one of the criticisms of the trial is that it's not a true comparison of robotic surgery. So remember, we love robotic surgery. This is hot stuff. This is cutting-edge medicine. And all of us that perform robotic surgery believe it to be great medicine. And in the trial, the majority of patients that underwent minimally invasive surgery did not have robotic surgery. So at the time that the trial was presented and published, there was about a 60% data completeness because we had not yet undergone the full longevity of the follow-up. But the Data Safety Monitoring Committee said, this trial has to stop. We have to release what's going on, and we have to tell people what's happening. And this is what happened. This is the single most important slide of the entire trial that turned everybody on their head. Now, if you understand Kaplan-Meier survival curves, when two curves in medicine diverge like that, the upper curve has an improved survival, and the lower curve has a decreased survival. In other words, there is a survival advantage if you are in the arm of the curve that is higher. And the curve that is higher on that slide is the open surgery patients. So when you have curves that are not overlapping, and as time goes on and the years progress, those curves diverge like that, that's a very powerful, supposedly statistical signal that there is a major difference in the outcomes of the two arms. And therefore, in this trial, shock of shocks, the patients who underwent open surgery did better from a cancer perspective. Oh my Lord. Oh my gosh. How could that be? Why? I mean, robotic surgery, best thing ever. So, most importantly, the trial was constructed as a non-inferiority trial. And the statistical significance of the data at the time that the trial was shut down did not achieve statistical significance. And yet the trial was stopped and the data was published in the New England Journal. So for those of you that know statistics, and many of you in the room certainly do, a 0.8 p-value for a non-inferiority trial is not statistically significant. However, the hazard ratio of just the curves alone was. So we got a signal here that there's something going on. There's something about open surgery. There's something about open surgery that appears to be better. I'm choosing those words carefully. There is something in open surgery that appears to be better. So Pedro Ramirez decides to update his data in 2019, this year. He returns to the ASCO and the SGO meetings. He has one more year, and the data has remained essentially the same. The curves stay divergent. So with one more year of follow-up, there's no more difference, and the data looks to be the same. Remembering that the data has not been completely collected for the statistical power that the trial was designed for in the first place. So John Boggess is another one of the big thought leaders in the area of minimally invasive surgery. And he says that, yes, this was a non-inferiority trial. It was correctly constructed. It needed 4.5 to 5 years, which they had, and it needed 740 patients, but only about 600 patients were accrued. And most importantly, the trial was terminated prematurely, as we all know, and only 85%, a large majority, but not all, of the data of the patients that needed to be accrued were accrued to the trial. So again, in other cancers, we know, for example, in endometrial cancer, cancer of the uterus, we have really good trials that show that endometrial cancer and the use of robotic or minimally invasive surgery is superior. Same thing in colorectal cancer. So what is it about cervical cancer? Why? We know from other cancers, why is it that all of a sudden we have this signal, this signal that's telling us that in cervical cancer, there seems to be something different? So where our beliefs are being turned on their heads. We know that in other cancers it works just fine. So why not in cervical cancer? I don't want to believe this. I love robotics. I don't want to believe this. But yet we're getting a signal that something is amiss. So he takes a trial and has someone independently review it, probably at his own institution, I'm not sure, but a professor of epidemiology looks at it, and the professor of epidemiology ultimately comes up with the conclusion that, of course, as we all know, the trial is incomplete and not completely accrued, and in fact, there is a major problem with the randomization of the trial because it was the surgeons who were allowed to decide whether the patients went into one arm or the other. It was not a computer-generated randomization process that said whether you went here or went there. So now we've introduced a surgeon bias. Now there's bias in the trial. Okay, forget belief bias that we talked about. Now there is selection bias in the trial. All right, so we have a randomization problem. And in fact, looking down other parts of the data in the LAC trial, there's some major contraindications because we know that robotic surgery is better in terms of perioperative outcomes and intraoperative complications, but yet in the LAC trial, there appears to be no difference between minimally invasive surgery and open surgery. That's odd. How could that be? How could there be so many trials that show that there's a major advantage for having some kind of minimally invasive surgery, but yet the LAC trial says that there's really no difference? That's kind of weird. There's no difference in short or long-term morbidity, long-term surgical morbidities, and there's no difference in quality of life. You mean to tell me 1 week after having a massive incision from stem to stern to have a cancer surgery, you're going to be doing the same as the lady that walks out the hospital the next day with the little incisions? Very dodgy, very dodgy. But nobody wants to look at all of that stuff in the trial that's a little dodgy. We're just looking at those survival curves and we're saying, oh my gosh, the survival curves have diverged. And so something is amiss. In its infinite wisdom, in the same issue of the journal, in the same issue of the New England Journal, at the same time, a retrospective database study looking retrospectively at a massive database in the United States called the NCDB, the National Cancer Database, is published by a fellow. a trainee in gynecologic oncology out of Mass General Hospital. And they look at over 2,000 patients, in fact, almost 3,000 patients. This is a massive number of patients. You could never get this number of patients in a prospective study going forward. You'd never be able to accrue it. It would take 3 decades. But retrospective data is reasonable to look at. So he does a study, goes and looks at the National Cancer Database in the United States, and looks at everybody who underwent a radical hysterectomy between the years of 2010 and 2013 for patients undergoing cervical cancer. And he finds the same thing. Oh my gosh, a prospective study and a retrospective study that suddenly look at cancer survival and are giving us the same signal. Interestingly, there is a side table as part of the same study that shows that survival was improving in the United States up until 2006. What happened in 2006? The robot was introduced. No, it can't be. Introduction of the robot coincides with decreasing survival in cervical cancer using a retrospective database. Oh, no, this can't be real. This can't be real. I'm not going to believe this. Both studies published in the same journal, in the same issue, giving the same signal going forward. And in fact, just looking at US cervical cancer mortality, it's going down until 2006, when all of a sudden it seems to plateau at the same time that the robot is introduced. More signals, more evidence that something may be going on with minimally invasive surgery. Multiple editorials come out. People go wild. In the world of medicine, this is like the impeachment thing going on up there. All right, we're all over this. People are publishing, people are talking, they're all over the media, CNN. There was not one by Fox. I don't know what happened to Fox. But the New York Times, Time Magazine, NBC, ABC, everybody's getting in on the action. Pedro Ramirez is on the news. It's being covered like wildfire in the media, and then the English get involved. And the English say, let's go look at our data. Let's look at NHS data in the United Kingdom. Oh, no. No. This is a retrospective study. This is looking at data out of England. Everybody having hysterectomies for a few years in England. But it's giving the same signal as the SEER database in the United States. The Koreans get involved. They look at their data. Oh, no. Oh, no. Then Alabama gets involved. More Americans. They show the same thing. All of these, mind you, are not prospective randomized control trials following 2 groups forward in time. They're retrospective, sometimes single institution, sometimes multi-institutional studies. Here's a multi-institutional study presented 3 months ago at the major cancer meeting in the United States looking at robotic surgery. Not laparoscopy, mostly like the LAC trial, mostly robotic surgery, some laparoscopy, but mostly robotic surgery at multiple institutions using 700 cases from major academic centers, and oh no, there it is again. Now we have all of these studies. Here are the 2 culprits that set everybody on fire, and here's all the retrospective studies that have come out since. And we don't know what to do. We honestly don't know what to do. ESGO, the European Society of Gynaecologic Oncology, now says that minimally invasive surgery, you can read the bottom line there, sorry I couldn't get it bigger, is no longer valid. No longer valid. It's no longer valid, says ESGO. So everybody in Europe now has their leading society coming out with a statement that says that minimally invasive surgery is no longer valid based on an inconclusive prospective study that was stopped early and a whole bunch of retrospective data. The SGO sent a letter to all of us 2.5 weeks ago. And thank God they were a little bit more circumspect about what we should do in the United States. And they said, while the reasons for these outcomes remain unclear, the preponderance of contemporary published literature suggests that survival outcomes for women undergoing radical hysterectomy for cervical cancer treated with minimally invasive surgery compared to open surgery is probably inferior. Gynecologic oncologists are encouraged to consider all available data as they counsel their patients as to what is the most appropriate surgical approach. Belief is powerful. If we agree with a view, we accept data points that support that position. We are biased towards the believability of a conclusion, view or perspective, and don't actually honestly evaluate the arguments for their merit. So what someone wants to believe to be true, they tend to believe to be true. Truth and belief need to be discerned because they are not the same. So, hopefully we'll generate some questions. I have remained on time, I believe. I know now what it's like to receive an Academy Award. Because what all of you don't know is that my colleague and I here have a massive clock that is clicking down in front of us. And at the Academy Awards, you get 30 seconds to give your speech. What they do there is they start to flash it orange, and then they flash it red. And then, of course, the orchestra starts to play, and we go to commercial. So I think we have 5 minutes between both of us to field some questions. Thank you for your attention, and it's a pleasure to be back.
Ladies and gentlemen, we actually have a bit more than 5 minutes, fortunately. But please feel free. I know that there are some mics walking around, some ladies and gentlemen with the mics. If you have any questions for either of the gentlemen at the table today, please feel free.
I really enjoyed the second talk about gynecological malignancy. I'm a general surgeon, and I think there are parallels with laparoscopic colon surgery. When laparoscopic colon surgery first came up in the late 90s, there were lots of enthusiasts who are skilled laparoscopic surgeons to push the technique forward. But what we found at that time was that there was high level of recurrence, particularly at the abdominal wall, and that really slowed down the development of laparoscopic colon surgery for cancer. So subsequently, there were lots of theories looking into why that's the case. Is it because of the intra-abdominal gas aerosol effect? Is it because of specimen extraction through a small open cut, causing implantation of tumor at the wound? But because of the recurrence problem, colorectal surgery really took a long time to develop properly. Subsequent to that, lots of refinement of the technique. We put in wound protection, plastic sheet, so that when the tumor extraction, there's minimal contact of the specimen to the abdominal wall. And subsequent randomized control study have shown no difference in terms of survival data compared to open surgery, both overall survival, lymph node recovery, and so on and so forth. So the last 10, 15 years, most surgeons now are moving towards doing laparoscopic colon surgery without any concern about a worse outcome from the oncological point of view. So one question I want to ask is, the technique of extraction in terms of laparoscopic surgery for cervical cancer, is it similar? Because obviously I'm not a gynecologist, I don't really know how you extract the specimen, but that may have an impact in terms of your overall outcome. I'm also very surprised and astonished that for a large multi-center study, I mean, for all the expense and effort put into it, it was not a randomized study to begin with. I've never heard of a prospective study addressing such an important question to allow surgeons to choose the approach. I just could not believe that anyone could start a trial doing that. That was astonishing to me. Going with the first speaker, another question I want to ask is that with the technology that you were proposing, are we going to see more medication so that it can be taken just once a day with the multi-release technique? Obviously, patients taking tablets several times a day, they can miss the medication. So are we going to see that majority of medication can be treated with once-a-day treatment rather than several times a day?
Is this on? Could you repeat that? I'm sorry. Start from the beginning.
With your multi-layer technology of delayed release, are we going to see majority of medication in the future available as a once-a-day treatment, which is much more convenient for patients?
Oh, I think so.
Why are we not seeing more medication produced and manufactured in that way? I mean, slow-release technology has been around for a long time, so I hope that in the future we'll see a lot of development in that field.
Well, I think it has to be targeted to what disorder you're talking about, because, for instance, I worked a lot in insomnia, and it's the same issue you're talking about here. I want to put you through receptor blockade, to sleep if you have insomnia for a certain period, but I don't want you affected after you wake up. So, it depends on what area you're trying to target. As we talked about with ADHD, it started out with immediate release because that was targeting school time, and everybody agreed that that was a good time to target. And then it started being added on to where we're now at the point where we have extended release formulations that cover the entire day. So it really just depends. And by the way, there are situations where people need immediate release adjunctively because their extended release doesn't cover for certain periods of time. One of the things that I hope to convey when I was talking about Jornay, for instance, is the fact that being absorbed in the colon gives it a different pharmacokinetic profile than being absorbed in the small bowel. Small bowel is very good at absorbing, colon not so much. We have 74% bioavailability as a result of that, but that gives it a different PK curve that allows it to extend further into the evening. If you look at our PK data, and it's available at the. But I agree with you. I think that extended release, sustained release, whatever you want to call it, formulation should be utilized, but they need to target the disorder that you're trying to target and pay attention to the receptor interactions that you want to occur. Thank you for the question.
Dr. Gatcliffe?
What's your question?
Can you repeat? No. So great question. It's great to have a surgeon here. Thank you for your question. It's very intuitive. So port site metastases have been a problem in all laparoscopy for cancers. And we've found ways and techniques in the majority of our cancers to avoid or at least ameliorate some of the issues with port site metastases. I think you're absolutely correct. The colon data now shows that the survival advantage is neither. So certainly, in the world of colon surgery, many surgeons are finally moving towards laparoscopy because the data is pretty robust. And there is not an inferiority problem. In other words, just like the way the LAC trial was designed, it shows that laparoscopy is not inferior. So you have a choice, and you're not going to subject your patient to any harm by using laparoscopy. And you're right, it's been a slow adoption curve in colorectal surgery, but most colorectal surgeons in the States are using some form of minimally invasive surgery. The way the tissue is extracted in most gynecologic cancer cases is actually through the vagina, because once you perform a hysterectomy, you have a natural orifice that's now open. And unless the tissue to be extracted is too large to fit through the vagina, then an open incision is made to extract the tissue. But most cervical cancers that are going to be eligible for surgeries are typically quite small and very easily extractable through the vagina. So your question is very, very astute, because the big game now is why? Why is this happening? Why are we seeing this difference? And it is postulated, like you said, that perhaps it's the carbon dioxide aerosolizing the cancer to other places. Although cervical cancer, unlike, say, ovarian cancer, is a solid tumor that grows in the cervix and is not slough or move about the pelvis the way, for example, an ovarian cancer does. So the plausibility that the carbon dioxide gas is spreading the cancer around like little particles in the abdomen is something that we're thinking about, but there's not a ton of biologic plausibility that is that, but it's something we're thinking about. One other thing that we're thinking about is that in all gynecologic surgeries, some form of manipulator is usually inserted into the uterus to be able to move the uterus around to allow us to get into the different planes and sides of the uterus as we perform the surgery. And is there something about inserting the manipulator into the uterus that seems to maybe cause the cancer to spread? Interestingly, what everybody is looking at now is where are these recurrences happening? So the patients that are not doing well, the patients whose cancers are coming back, which seem to be occurring more in the minimally invasive arms, where are their recurrences? Are there recurrences distantly, away from the site of the original cancer, or are they nearby? And some of that data is starting to emerge, and we don't yet have enough robust data to be able to tell what the differences may or may not be. But the big question now is we have these signals, and I choose my words again very carefully. I'm waiting for somebody, I guess, to ask me the question that I really want someone to ask me, David. So get ready. I didn't put it in the talk because I knew you'd be here with that bow tie on and that you'd be ready to ask me the question. So the real question is, what am I doing? But right now, what we're trying to do is just sort out the why. We have signals. We have a signal that's telling us that there is a likely difference between the two approaches. We just don't know why. Many of us have not been able to get over our belief bias, and therefore we don't want to accept the data as it stands. Yeah. David Stone with the question of the hour. Oh, we have another question in the back. All right, before we go to David. Yeah.
Yeah, just a question and comment, Dr. Warrington, regarding ADHD. You did mention that we sometimes underdiagnose those children in the classroom with inattention. But on the other side of the coin, do we overdiagnose those with hyperactivity? Because many times, I'm a pediatrician, teachers send children already with the notion this child needs medication. So can you comment how we tease out, because we know children don't go outside as much as before, let out that energy, as we say. So how do we tease out the hyperactive children from those with ADHD, and also for the parents who child does need medication but have the qualms of medication?
Yeah, this is a great question. And it's interesting, just to put in context, the inattentive aspects of ADHD currently are more focused on females and more likely to be female. And I think ultimately that's going to come to a 50-50 split. And that speaks to the diagnostic aspects of that I was alluding to earlier. But your point is a very good one, is the overdiagnosis. Now, if you are being properly evaluated, as in every medical intervention, you will have all the data available to you to be able to make a determination. So I'll give you a quick anecdote on that from my own experience. I had a patient that was admitted to the children's psych ward when I was at University of Florida. Came in 3 times, and he was tried on every version of ADHD medication available at that time, including Wellbutrin, bupropion, which is third line, and even mood stabilization. I mean, we moved, down the road of getting into areas that you're trying to figure out where are we, what are we doing. It turns out that in that scenario, this poor 8-year-old boy was being abused at home, and that was the sort of agitation and aspects, running away and that sort of stuff, which was described as hyperactivity. So to your point, you have to take into totality the entire diagnostic information that you have to be able to make sure that you make a good determination. The unfortunate thing is that there's no test that you can do. It's a clinical diagnosis, and the best available information comes from numerous sources, not just parents. A lot of times parents will bring in children, and to use the terminology here, there will be this belief by the teacher that this child is hyperactive. I actually had someone came to me once, the poor mother said to me, They say he can't go back to school until he's on a medication. And I said back, I said, did she happen to mention which one and what starting dose? Because if she's going to be making medical determinations, I think I should benefit from that, right? So you get a lot of pressure to be able to do that. And as a matter of fact, in the case I just mentioned, that child did not need ADHD medication. So if your thinking there is that every hyperactivity is a moment for a stimulant and just adding that on, that's just bad practice of medicine. So every case should be taken in a diagnostic pathway to make sure that it's, the diagnosis is solid.
You have one more question.
Hello there, handsome. I'm going to call this one for Dr. Gatcliffe. I'm interested to know, because we can look at the information on the point of time of 2006, but I think that's ironic to judge the merits of using robotic surgery or any minimally invasive surgery, because you are talking about judging it against decades and if not centuries of use of a open technique that has now been refined and put forward and benefited from all the technology that we have now and the protocol studies that using antibiotics and the postoperative care. But I'm curious to hear from you as to what you might think as to why you saw that divergence, on top of the fact that, of course, we are dealing with an incomplete study, a study that did not show a statistical value in terms of a p-value that was good. Do you think it's multifactorial as to just new technology that needs to refine itself? For myself, we talked about this for robotic surgery. When we first came out, we were getting a lot of char. We were getting a lot of burned areas because we weren't using energy properly. And we've refined that incredibly. I mean, just in the conferences I've gone to in the last 15 years, the change in how the tissue looks and how people are approaching tissue dissection has just evolved completely different. So I just wanted to get your comment as to what you think is perhaps maybe a reason for that divergence.
Yeah, it's a great question. So I think the correct answer would be, I don't think that any of us actually really knows yet. I think we're probably going to understand that in the fullness of time in a few more years. I think your assertion is very astute. Open surgery, conventional surgery, laparotomy surgery has been refined, and we have decades and decades and decades of experience, and now we're basically looking at a very short period of time for a relatively new technique, and we're looking at an incomplete study. So the big question that many of the people that have been criticizing the LAC trial, people whose belief bias says we don't want to accept this data, they're questioning, what really is the cause? Why is this happening? Many of us think that it may have something to do with dissection technique. Many of us actually think that it may be the manipulator or the way the vagina is closed. We just really actually don't know yet. But I think that the positions that have been taken by the societies, especially ESGO, and the kind of turning on its head by a number of major academic institutions that have now completely stopped offering any form of minimally invasive surgery for cervical cancer, speaks to the fact that we have embraced data that is incomplete, data that is not robust, data that was not performed in the best possible randomized way, as our surgeon colleague highlighted and I put up in my slides. So we're in a really gray area. We're in kind of, in a way, no man's land. And so each of us as practitioners, certainly as individual professionals for ourselves, and then in some places, whole institutions are choosing to take a stand. And they're saying we either will or we will no longer offer this. In terms of my own practice, I feel that because we're in a gray area and we're starting to see signals that potentially tell us that minimally invasive surgery may be inferior, I certainly don't want to do anything that would potentially put my patient at risk. So for the time being, until the data is better, I am no longer offering robotic radical hysterectomy for cervical cancer in the interim. So that's my personal stance. But I have a colleague in my group that is just going to continue to adequately counsel the patients, as the SGO said, and in discussion with the patients, make a decision together as patient and doctor in terms of which way they like to go. Yeah.
We have one more question. Two more questions.
Good morning, Dr. Gatcliffe. I had a question for you. Not a surgeon, definitely a layman when it comes to all this. It's very, very interesting. But I had a very basic question just about the folks that were in the study for the two approaches. And the first question that popped to mind for me was, what were the ages of these women? Potentially, what is the BMI of these women? And then based on that, the second part to that is, if you're going to do an open surgery, what's the chances of actually going back and doing another one versus having a minimally invasive surgery where there may be this predisposed bias for any surgeon to say, well, because it's minimally invasive, if I miss some, I can always go back later. And just wondering if those two things at all play into this from a very layman perspective.
Yeah, so we think not, but again, I'm not trying to be evasive, but the answer is we don't know because the LAC trial was not truly randomized by a computer system, which is the way most randomized trials are done. A lot of it was based on physician preference. So in terms of, and you can look at the trial, you can Google it and it's all there, the two groups were fairly evenly matched for age and BMI. So there didn't appear to be any major differences between the two groups, despite the fact that they weren't truly properly randomized. In real randomized trials, double-blinded randomization is supposed to remove selection bias, and it's supposed to eliminate any question of differences between the groups in terms of characteristics like this. So it's a great question. In terms of going back, there really is no difference in terms of going back. If you had to go back for a second surgery for whatever reason, I don't think that there would be any difficulty going back regardless of the approach.
James Hospitalis. Thank you both for excellent presentations that took us on a deep dive into pharmacology and the issues of human behavior, and Troy, to yourself for the presentation on an important issue of health technology assessment. And I see a link between the presentations. On the one hand, mental health, and you say, well, how's that linked to the surgery? Well, you started by talking about our belief systems, and what are our question in my mind is, what are our belief systems about ADHD, and who defines it, and when does it become acceptable to just medicate children? As a father and as a granddad now, as a godfather, I felt amazement at what is possible with the dosing technologies and so on. And it sparked a couple of questions and perhaps some unease. As a population health doctor, I would ask you to comment on the issue of the medication of the human mind that is taking place through widespread use of medicines, some of which are intended to control behavior and some of which have side effects of that. So and then perhaps a bit more on the epidemiology of ADHD and what we know about its trends and differences between different environments, and therefore what can really be done to prevent it. Its links to nutrition, its links to additives in food. We're so mass medicated that, or not just medications, but exposed to all sorts of chemicals. Part of the problem is discerning the effects of being in different arms of things, Troy, if you will. Troy, my question is you showed really interesting, powerful data on why the difference between open surgery and robotic, minimally invasive. And if we're going to turn our backs on what seemed to be a lot of benefits, certainly in terms of short-term complications, because you had lots of data showing the robotic stuff was better, right? So if I boil it down and try to, from layman's terms, it seems as if there's something going on, broadly speaking, that the human doing it is better still. What have you thought of evolving to not throw out the baby with the dishwasher, so to speak, but to say, okay, what is it about how humans do it? That's subject to a next step in 3.0, which would be to marry it with artificial intelligence and get all the data from all the thousands of doctors and tens of thousands of cases and run that through some deep learning partnership with, such as my son, advertisement, my son's principal scientist at Samsung Artificial Intelligence Research in Cambridge. And they have a big health line, and they haven't decided how they're going to spend all this money. This is a wonderful opportunity to come up with 3.0. And I wonder what thought has been given to using an AI-enhanced approach to not giving up on the robotic surgery, but combining it. Thanks. Thanks to both of you.
In terms of the sort of preventative nature of ADHD, I wish the data were better. I wish we knew what kinds of things caused it to the specificity that we were able to prevent. I think when we talk about the treatment or over-treatment, whatever category you're talking about in the psychiatric world, but let's focus on ADHD. The risk of not treating once you get a diagnosis of ADHD, and I mentioned earlier a solid diagnosis of ADHD, not putative, not just throwing a stimulant on to see if it helps. That's not the way it should be done. The way it should be done is the way it is done in good medical practice, which is you arrive at a bona fide diagnosis using the available data you have. Once you get that, you can start on behavioral approaches. And as a matter of fact, the American Academy of Pediatrics, SDBP, they think that should be done first. And I don't have a personal, professional problem with that. But I will tell you this, there are very dire risks of not treating to the extent you need to treat. So in other words, if behavioral takes care of it, I think that's great. But if medication is needed, if behavioral doesn't take care of it, and you saw the information I put up is that the combination works best. The risk of not treating is dire for the patient because those children go on to have more difficulty, a lower socioeconomic status, more likelihood to go to incarceration. There are all kinds of problems that come about as a result of not treating ADHD. I'm a huge proponent, there's not a bigger proponent in this room of not treating or not treating just because. I feel like if it's indicated, you need to treat. But there is a big problem with not treating ADHD, specifically ADHD, but some other psychiatric disorders as well. So I'm with you in terms of let's make sure that the right people get the right diagnosis and right medication. But I think that are we over-medicating? Yes, probably. There are probably children getting stimulants who don't need stimulants. But I think there are also children who need stimulants who aren't getting them as well. So the goal is to try and get the accuracy of who needs what and give them that.
I'm going to keep my comments very short because the big red screen here is going to start having explosions at any moment in time. So I think artificial intelligence would be fantastic. I think, shameless plug for your son, we should get him involved in looking at all of this data. And I think that would be the next thing to do to try to sort out what's going on. I just wanted to add to Dr. Warrington's, not so much a question, but a comment. And I'll leave this as the non-psychiatrist, because I know that, Aniki's been standing there with my gift now at attention, and she's trying to tell us to shut up. But I'll leave you as the non-psychiatrist, as just a plain old surgeon. You can teach a monkey to do surgery, right? But here's what I think is going on with me. So I'm about to turn 50, and I wonder about the effect of the current state of the world and in which the way we process data and the way our kids process data and how that's affecting the plasticity of the human mind as it develops. Because my kids now are completely convinced, along with my wife, who I've now seen is in the room, that I have ADHD. And I have ADHD because when my brain was most plastic, when I was a child, I could remember as a teenager sitting for hours studying uninterrupted. I could attend for 2-3 hours before I, had to get up. Now I can barely attend to something for more than 30 minutes. I'm amazed that all of you in the room are not bristling to get out of here. I mean, and the reason I think that is so is because we now live in a world where there's so much data flying at us constantly that we are becoming prone to constantly needing to attend to multiple inputs at multiple points of time. So, I mean, I worry about myself as I walk around the hospital. And the only time, interestingly, that I have to continually attend to one task is when I'm in surgery. Yeah. Right, David? Yeah. Thank you, everybody.
Thank you very much, both of you, for
my gift.
very, very educational talks. I'd like to call Dr. Gatcliffe up to receive his gift of thanks. Thank you. Handing over to Nancy.
Hey, thank you very much for riveting talks, and Annika Brown for being our chair for this morning. I really appreciate it. We're going to go straight into the coffee break, but because we're a little bit over because of those exciting Q&As, what we're going to do is ask that you just take a 10-minute rather than a 15-minute break and come back into the room at 5 minutes to 11. If you get a chance a little later, make sure you check out the Health Service Authority booth and the Cynical Well Check as well, and enjoy the coffee break sponsored by the Wellness Center.
you deserve. So I sit alone and write this song. I would have given it up, I would have given it all. You know I'd do anything to wake up to you in the morning. So many feelings involved, maybe I'm too critical. When we hit the cassette, I miss your falsetto. I think about you, still think about you. I still think about you. You know that I do, I think you do too. I still think about you. I think about you. Empty days and no replies. You used to fill up all my nights. Guess affection fades and cause decline. When you touched me, God, I felt alive. I would have given it up, I would have given it all. You know I'd do anything to wake up to you in the morning. So many feelings involved, maybe I'm too critical. When we hit the cassette, I miss your falsetto. I think about you, still think about you. I still think about you. You know that I do, I think you do too. I still think about you. I think about you, still think about you. I still think about you. Still chasing that groove, it's the way that you move. I still think about you. I think about you. Think about I can't let it go, I can't let it show. I can't take it, no another night alone. I can't let you go, I can't let you know. If she isn't you, I'd rather sleep alone. I think about you. Usually I don't rush, but you got me feeling needed. Yeah, I'm sweating you like a pool day, slipping and sliding your way. Let's dive in like a vacay. Oh yeah, oh yeah. Don't know what I'm feeling, but I'm feeling you. Even if you play me, baby, I can't lose. If I crash and burn, I'm only crashing into you. Yeah, we're getting closer while you're slowing down. Don't
Welcome back, everybody. We'll soon get started. I'd like to encourage everyone to come into the main conference plenary room, please, so we can get started. Hope everybody enjoyed their delicious coffee break. I know there were some people lining up when I left the room next door. Thank you very much to the Wellness Center for that break. So this conference is all about innovation in healthcare and also innovation in many other things. And one of the things the great organizers of the conference organized for us to do this year is have live streaming next door, because we realized we were getting really, really full with all of these conferences every year, more and more people subscribing. So the good news is it's live streaming next door, but what that does too is you've noticed probably a little more elbow room around you this year. It means that some people are choosing to slip out, maybe have a coffee and listen to the live streaming next door. So we'd just like to take a moment to encourage everyone who may be watching live streaming and listening next door to just come through to the main room so that we can be together for this session starting right now. Thank you. Thanks again to the Health Services Authority. They have a patient portal. I've been on it for a couple of years. It's really great. You can book all your appointments, get pharmaceuticals and so on, save you time, money running around. So that's really a good thing to sign up for. Also the blood bank, we're always needing more blood donors in the Cayman Islands. Also like to encourage people to check out the Cynico Health Check Station, which is on throughout all the breaks and lunchtime. Welcome all the delegates back. I see some more people trickling in. We'll get started very, very soon. Also at this time, I'd like to thank other major sponsors apart from Ironshore Pharmaceuticals, who are our Premium Plus sponsor, and that is Compass Media, and supporting sponsors DART, Ocean Med, Spectrum Therapeutics, Memorial Global Health, and Nicholas Children's Hospital. Thank you. While we're waiting for a few more people to come through with the coffee break that was moved back a bit because of the Q&A session from the previous session, I noticed an ad on Facebook very recently from the Wellness Center, which has had a milestone as well, similar to our 10th anniversary. And that milestone for them is they've just moved offices. And their kind of tagline on their Facebook post announcing their office move was that they had more light. And that really struck me as interesting because artists talk about having light and the need to use light to create art. And one of the very first art therapists, and again the connection between the arts and medical, is Anne-Marie Gray. She was the first visual art therapist, and subsequently I know there have been music therapists and I think a drama therapist as well in the Cayman Islands, and she got her career start at the Wellness Center. So shout out to Wellness Center to be innovative with healthcare professionals and also for their amazing coffee break. Thanks again. Big round of applause for them. All right, so at this time I'd like to introduce our next session chair, Dr. Bella Baraja. She received her medical degree from the Universidad Central de Venezuela and completed her residency in internal medicine at the renowned Cleveland Clinic in Florida. She is board certified in internal medicine by the American Board of Internal Medicine. Her work experience includes 5 years as a hospitalist for the 700-bed Memorial Regional Hospital in Broward, Florida. Dr. Baraja then moved with her family to the Cayman Islands in 2011. She presently works as a private physician at Helix Healthcare and holds privileges at Doctors Hospital and also HSA Georgetown Hospital. She has been a director and is now vice chair for the Cayman Heart Fund. As such, she's the main organizer of their annual international symposium. She also served on the board of directors for the CIHSA. And she's very special to me because she is a doctor for both my octogenarian sprightly parents, and I really appreciate that, and they sing praises for her. Dr. Bella Baraja.
Good morning, everyone. It is really my privilege to be here, and I would like to first thank the organizers for including me, and thank you, Nancy, for the nice and kind words of introduction, and it is my pleasure to see your parents always. I would also like to echo her words in respects to all of the people who make this happen and how much we thank them. It's an extremely exciting time in medicine. The turnover in technology and medical advancements is so fast, is sometimes mind-blowing and hard to keep up. So I think these two talks that we're about to listen to are quite contemporary relevant. They're going to focus on evidence-based medicine, communication, using technology and other tools so that we can achieve the best patient care and also be cost-effective, because in the long run that also improves patient care. I would like to remind everyone to try to remain quiet so we can all listen to the speakers. The talks are approximately 45 minutes in length, and then we'll have ample time for questions and answers. So I would like everybody to take advantage of the paper and pencil and write your questions down. We will try to get to everybody's questions. The first speaker we're going to introduce is Dr. Erick Gryzbowski, and I know there's a Z after the Y, but I was told it is Gryzbowski. He is from Bolivia, and he comes to us from Abbott Diagnostics Business. He is a clinical solutions specialist manager for the region of North and Latin America for Abbott. The topic of his speech is going to be state of the art of clinical support systems in the healthcare digital transformation. He aims to act as a bridge between health data, use of evidence-based medicine for exceptional patient care and real-world scenarios, with focus on new business model solution for heterogeneous health systems. He is a medical doctor, but also received a master's in health economics from the University UPF of Barcelona. He also has a degree in epidemiology from the National Institute of Public Health of Mexico. He has diplomas in health programs, impact evaluation, and models of programming. Dr. Gryzbowski has 10 years of experience in real-world evidence, health economics, and outcomes research for public institutions and the pharmaceutical industry. He teaches, is a professor of biostatistics and epidemiology, and he has ample international experiences with organizations like the United Nations and Doctors Without Borders. So it is my distinct pleasure to welcome Dr. Gryzbowski up to the stage.
Hello, everyone. Thank you very much for this kind presentation. It's an honor and a privilege for me to be here and to have these spaces to speak about these technological advances. Maybe the title of the State of the Art of CDS is a very strong and long title, but we are going to make an approach about our clinical solutions regarding to this topic around the world, and of course, we will be able to respond any question that arise from these new technological and new advances in medicine, but it's not for the future, it's right now and it's happening. No? So if you can help me with this small video that we have at the beginning of this presentation after we start. Okay, what you can see here in this amazing dynamic data that is shown by Gatmander and my, could you please stop over there? Or we can start again. Let's go back to the beginning, please. Okay, put it on 1919, 100 years ago. Okay, it's good over there, so we can see the effect of the First World War. So this is the world. This is the world 100 years ago. As you can see in green, we can see all the Americas. In blue, all African and sub-Saharan countries. In yellow, we can see the Occidental Europe, and consolidation of Asia and Oceania in red. The size of bubbles, the size of bubbles show us the size of the population, the population. And as you can see, in this axis, we have the life expectancy. And in this one, we have, in the x-axis, we have 4 different income levels, GDP per capita. 100 years ago, the world was around, most of the world, of 75% of these 200 countries that are showing this in this graphic, the life expectancy was around 4 years. 4 years, and you can check the income level. So please play it, and let's see what happened in the last 100 years. Okay, you can check that coming down was the Second War, the Industrial Revolution, what is happening right now. We're coming to the 21st century, and as you can see, all these countries. That was a small briefing of the world history in less than 1 minute. Okay, so what we can see here is a positive trend, an increase in life expectancy, and this increase is like more than 60 years in life in global life expectancy, and in global income. Global income too. If we could split, for example, some of these bubbles, China, for example, you could see that some of the poor provinces of China are around the average of the African countries. And if we can think about Shanghai, Shanghai has the same life expectancy that most of the European countries. So, what conclusions can we get around this is that with intelligent inversions in 4 topics, any country could get the results. Intelligent inversions in health, education, infrastructure, and technology. Okay, so can we start with the presentation, please? This is the digital transformation in health. Once again, it's an honor and a privilege to be here. Can we start? What are we showing? What are our global healthcare challenges around the world? We have all the reimbursement cuts. Health, it's always the most affected with government reimbursement cuts, so we have to squeeze budgets. Staffing shortage, hospital and laboratory consolidations, lack of personnel, and we have greater information to unstructured data. That is the same of having nothing. No, we have petabytes of data around the globe, but if this data is not used and is not linked directly for a clinical outcome, is the same that having nothing. So, what is happening? We are creating around the world, and Abbott and CDS is no exception, new business model solutions that we need to use it around all the global and all the heterogenic health systems, because as you will see in this presentation, the spending in health will increase. It's a reality, and there's nothing we can do about it. At least we think intelligent in this kind of new business model solutions, like risk sharing, pay-per-performance, bundle payments, and other structures that are working around the globe, and we need to analyze it and adapt to our health systems. So that's what I show you right now. This is what's happening right now, and as you can see, the Cayman Islands has, this is an official site that I get the life expectancy around 83 years, and one of the most wealthy and high average or GDP per capita income. So, what's happening? What is the result of this population aging? This population aging, it's affecting us with the increase of non-communicable chronic diseases. If you can see these green bars here, are the bars related, what is happening with health regarding to population aging. And as you can see, the chronic respiratory diseases, and please check and keep this in mind, the cardiovascular diseases, diabetes, and chronic kidney failure appearing as a global problem in terms of mortality. When we see this data and we split it for age groups, what we can see is in global terms, this is global data extracting from the Bill and Melinda Gates Foundation, from the Health Metrics Institute. This Health Metrics Institute, I always encourage my students and everywhere I am to use this data, because this is real data, and they make better work than World Health Organization. So they put the World Health Organization to do his job and trying to improve his results in the last 10 years in order to make this appearing. No? So what is important here is that 73% of deaths in 2017 were due to chronic diseases. Data in healthcare, as I told you, is most useful if it strongly correlates for a clinical outcome. Data, dispersed data on the cloud is not useful if we are not checking out what are we extracting from this data analytics, and which actions are we going to take regarding to this data. So, healthcare spend is increasing from the same data from Health Metrics, this Bill and Melinda Gates Foundation. The analysis from 195 countries from 1991 to 2015 give us the opportunity to extrapolate and go further 200 to foreign. So the data here is we have $8 trillion in healthcare spending that was rise from 2007 to 2017. This 8 trillions was increased to 10. And the projections, the forecasting show us that it could be $15 trillion in 2050. If you remember the income levels that I show you on the first slide, this show us that it's not particularly to the first world countries that we can say. No, this problem, it's up to us, to all the world. Every country is experimenting this increasing, and our region, the Caribbean and Latin America, is not the exception. So therefore, spending in healthcare, it affects to all the world. And when we are thinking about risk management that it's the backbone of epidemiology and global health, what are we watching in this world? It's that less than one patient, less than one patient here is spending 42% of our economic resources dedicated to health. And all the epidemiology efforts and all the global health efforts will need to focus on avoiding that these patients, the population risk management, should be focused on avoiding that these patients comes to here. This is a this is a one patient sick. And most of these patients are healthy or with chronic diseases in initial stages. So we must improve the health services management. Abbott has almost 100 years of experience in laboratory data. So most of our information will be focused on laboratory, but I will try to leave the message that it's not only laboratory. The strength of laboratory data for helping us, for taking decisions, that is the basics of health economics. It's to act as a bridge between epidemiological, hospital, clinical data, and economical outcomes to help stakeholders to take better decisions. So, speaking about laboratory data, this is a very nice study. It's a Colombian study for the Inter-American Bank of Development that it's seeking for something like 3 very simple laboratory tests in more than 10 big laboratories, because this is showing us one of the most biggest insurance companies around Latin America. What's happening here? What we can see is most of this laboratory has very heterogeneous. We are looking for a glycated hemoglobin if some patient has some kidney function laboratory and some cholesterol level. 3 very simple tests that we were supposed to everyone on the room, if they get to the hospital, we're supposed to have. What we can see here is that only one patient, in the best scenario, only one patient of every 4 has this has all these 3 package of a study. And how it affects us? How it affects us? Of course, to the population and of course to the healthcare system. This is the same example, but when we divide it, it's a very long cohort. It's more than 324,000 patients. What happens if we are looking for at least 2 glycated hemoglobins in the process of healthcare attention? Let's remember that the American Diabetes Association asked for at least 4 glycated hemoglobins. We were looking for just 2. What happened regarding to the ambulatory process? And let's take a look of these guys that were no compliance in these glycated hemoglobins. Of course, we made less tests, less hemoglobin tests, and it's a cost saving. We were saving at least $1.5 million because we were not doing glycated hemoglobin. But these guys who were no HbA1c compliance, in terms of complications, it was $116 million expensive in this cohort, retrospective cohort that we were following from 5 to 10 years, this patient. So this gives us an example of what's happening, okay? And all this, this is important. We are analyzing these 2 scenarios in the English Caribbean. How is the cost of retinopathy, of cardiovascular disease, of nephropathy regarding to diabetic patients? And the second scenario is a very optimistic scenario with wide coverage, broad coverage, and total access for medication and all resources. But let's think it's real, no? As my Hans Rosling, my global health guru, says, we need to work with the world as it is. So make it real, and we can see how many millions are we expending on these complications of only one disease, that is diabetes. If what we would see right now, it's the epidemiological distribution of diseases. Globally, one of every 4 patients is dying around the world from cardiovascular diseases, stroke, diabetes, and chronic kidney diseases. If we take a look of this comparison to the Caribbean, we will see appearing some other causes of death, no? For example, we have natural disasters, of course. All Latin America has this not to be proud of violence statistics, but we can take a look that we are experimenting this epidemiologic transition for chronic non-communicable diseases, cardiovascular, stroke, and once again, diabetes and chronic kidney failure. Let's think about if we have people from the laboratories here that for all these oncological diseases, we have many biochemical markers that can be useful for us in order to take decisions just considering the laboratory data. What happens when we take a look of not the cause of death, what is happening with the health system regarding to this amazing metric that it's called disability adjusted life years? Which are the diseases that are squeezing the small budgets in health in terms of long-term expenses, And as you can see here, all the Caribbean, it's once again, we are watching all this small quadrant that is cardiovascular diseases, but you can see how diabetes and chronic kidney failure increase. Of course, in terms of disability, will appear some other diseases like back pain, osteoarthritis, congenital, but let's think about this and this in the Caribbean. Let's make a comparison. All the epidemiology is based on comparison. No? When two epidemiologists ask one to each other, how is your husband? And the other one will say, compare it with what? No, of course. Because this is a comparison between the Caribbean and the Great London area. As you can see, we don't have this. Violence is much less. Oncology is bigger. It's bigger, but let's see this. If it's still being a problem in London, the diabetes, but not as much as our region. No, and this corresponds to this global transition in terms of diseases. So, what was the purpose of showing all this information, all these boring numbers that we can see is because we have an opportunity. We have the opportunity from the laboratory to leverage the power of the laboratory unique position as a data epicenter. Why? Because we can create greater value and broader healthcare challenges working in concert with all the health system. And this is the image that we need, that we want to purpose for these new interventions. No, is the people from the laboratory, is the people from helping to the administrative tasks, to the clinical staff to take decisions. Why? Because we have petabytes of data that can be used every day, and can be used only if we match this data for a clinical outcome. These are our examples around the world that we will speak about. Artificial intelligence. If you're living in this world, in the last 5 years, you have heard about AI. And this artificial intelligence, in terms of health applications, can be divided in two big groups. These groups are the rules-based. Rules-based, that means that it's you and your own clinical guidelines, according to your needs and regarding to your specific resource allocation, that you define which clinical guideline to use in order to improve the healthcare outcomes of your population. What happened with other kinds that it's increasing every day is the database. The database includes all the machine learning, neural networks and all this stuff, but maybe in health it will take a little bit more to be useful, because the algorithms of self-learning is making a slow process. So let's focus on the first one. In the first one is that like augmented intelligence, because we are still being the ones who choose the best algorithm to include this on the healthcare process and to improve our outcomes, very strong related to our needs. So, the American Medical Information Association definition defines clinical decision support as relevant information that it's applied and given in a timely manner to improve decision making. And most of your institution that probably has been investing a lot of money in electronic health records, when you have a clinical decision support system inside that, you can assure that your return of clinical investment and your return of economical investment of this big inversion, because it's not cheap to implement the electronic health records around the world, and I think that the Grand Cayman is not exception. So how does CDS could improve this? And the other definition, I like it, is because it comes from the Health Informatics Medical Society that it gives. It's a process for enhancing health-related decisions and actions with pertinent and organized clinical knowledge, always focused on the patient. So this is a CDS. This is the clinical decision support. And how does it work? This image can show us regular healthcare attention. Healthcare attention in terms of the patient arrives to the system, and once that he touch the health system, he will be linked to invoice data. Invoice data that could go to SAP, okay. Then the patient goes and get the proper attention, the proper clinical attention. And the clinical attention, now, it will be recorded on electronic health records. These electronic health records will go to a database that most of the time is called Hospital Information System or Electronic Health Records. Then your physician asks for laboratory and images. Laboratory data will go directly to Laboratory Information System data. If you have some software that it's we encourage everyone to have it, because when you're looking for many drugs, multi-drugs in the same patient, you can choose and you can have a better manage of adverse events if you have this pharma data. And at the end, the patient will come out from the service and we will link all this information again to the invoice data. This happens, the health will be coverage and will represent an spend of money every time. If the money comes from the public services, it's better. From the private services, it's okay. But when it comes from the out-of-pocket of the patient, we know that it's the worst case of financing the health. So once we got that, we can understand that we have 5 different databases, and the clinical decision support system can be enhanced to any of these databases. Of course, as I told you during this presentation, the characteristics of the data characteristics of list data are better because it's structured. It has been decades of working in order to have the ISO implementation, the quality management of this data, but every time and every day, the electronic health record is improving to have the same thing, the same kind of structured data. So when we complete this, let's think about that CDS can be useful in any of these examples. For operational excellence, I will show you an example in Germany on the next slides. Our focus is high quality level regarding to assure the adherence to clinical guidelines. And high-level experience with medical continual educations and updated and standardized information that can be updated, as I said, in the same minute that you want, because you create a knowledge base that can be adapted anytime you need. The potential use cases are clinical advice to physicians in order to improve the clinical guidelines adherence, general well-being advice for patients, of course. You can increase the demand of clinical trial rules. That's very interesting for our region, because we know that the big clinical trials are always running right next door to hell. They say, like in the USA, it's getting like more than 90% of the clinical trials around the world. But what we have in our region, we have many patients. We have many patients. We can create rules with the inclusion criteria of the clinical trials that are recruiting patients to show to the National Cancer Institute or all the institutions that are running these trials that we have the proper patient in order to include and to increase access to these new medicines, new diagnostic tests to our populations. And last but not least, we can improve the coding. We can improve the coding, and improving the coding, we improve reimbursement. This is an example. This is a global example, but let's think about chronic kidney failure, diabetes, sepsis, that I have the authorization. Today I get the authorization to show a very interesting protocol that we're running in Spain, reimbursement and comorbidities, and all other diseases that can be enhanced by CDS in order to improve and to have a better patient impact, a better clinical impact, and when you have a clear clinical outcome, this clinical outcome can be easily monetized. And, of course, to have a finance impact, that it's all we need in the healthcare system. For example, this project that has been running in Ohio hospitals was using the new stratified risks of the new troponins in order to make a good stratify. We go to the pathway, to the clinical pathway, and to see exactly which are the points, which are the pain points on the on this clinical pathway. So, enrolling heart failure patients, identifying potential myocardial infarction cases in the emergency at the emergency department. And as CDS, as I told you, CDS is not a therapy, it's an enable. And as an enable, what CDS does is to help the patients go inside the proper clinical pathway of attention. And as they are on the proper clinical pathway of attention, we will have better clinical outcomes. In this example, the acute myocardial infarction cases reduce the length of stay with a proper stratification of the risk. And what happened with the chronic cardiac failure? The chronic cardiac failure was focused on avoid readmissions. And as you can see, we take information from the list and the hospital information system to increase this. And I told you, this 1.72 less days of stay can be easily monetized to your population stage. What happens with the glycated hemoglobin is the same. We develop algorithms to find missing patients, and to local referral pathways and provision of lifestyle change programs, and as programs to increase the adherence to education programs of these patients, with very simple information taken from the laboratory information, like the glycated hemoglobin. We don't need to go as far for like Netherlands of other places. We are running this. We are finishing an offline it's a Netherlands example regarding to chronic kidney failure. In this chronic kidney failure, we have two steps. To provide data and value if the people, if the hospital is running, it's running and it's properly adherence to the clinical guidelines. And in the case two is provide insights, the hospital management to improve efficiency and define pathologies. As I told you, we doesn't need to go to Netherlands. In Colombia, in 100 days, we identify 300 cases of chronic kidney failure that was out of the human eye. The previous process was the biochemistry following the trend of creatinine and glomerular filtration rate, but 300 cases that escaped from the human eye were defined by CDS, and this represents an early detection and avoiding hemodialysis and probably kidney transplants. So that represents a lot of money in terms of healthcare. The last one, this information has changed. I was on third year of the university when the UK PDS study comes out, the ARM 35, and these are the decreases that only a 1% reduction of glycated hemoglobin represents 21% of any final outcome associated with diabetes, 14% in myocardial infarction, and 37% in blindness and kidney disease. So if we as enablers, we work over there, we can help and we can find these patients, these hidden patients and the patients that are in our total prevalence of the health system. This is a very interesting reimbursement process in Germany. They were looking to find, I don't know if in this country you are working with diagnosis-related groups. The diagnosis-related groups works as the cost of a myocardial infarction is not the same if this myocardial infarction comes with other comorbidities, as diabetes, as chronic kidney failure. So we have the ICD code in this example. We have the ICD code, but we help them to find the comorbidities, the hidden comorbidities of these patients. So when they ask at 3 months of using the CDS, they get the proper reimbursement of these patients with gorgeous evidence, because a glycated hemoglobin of 12% is diabetes. low glomerular filtration rate found by the laboratory, it's chronic kidney failure. So in less than 3 months, they pay the price of this solution, just getting the proper reimbursement of this solution. For the last one, it's a very hard and it's a very interesting because acute decisions are very hard. Acute diseases like sepsis, if you are working and you're giving some important instructions in chronic diseases, and if it's not the proper instruction, the outcome will not change a lot. But in terms of sepsis, a bad suggestion, a bad messages can increase the mortality in terms that you can imagine. No? So what was the CDS used for this is to give a proper coding of the sepsis to help, as I told you, we only help, we are enablers, no? To help in the early diagnosis, to help to find complication factors like age and oncological patients and other stuff, sepsis, to give sick recommendations and reminding for initial monitoring, and to improve the SOFA score in terms of have it fastly than with a manual calculation. This is an example of a simulated report. This is an offline project that is coming to the best way of our project, because the best way of our project is that when we are running alive, when the patient is sitting by the doctor and you're getting some information data, you are getting the alerts and the messages and these things that only helps the doctor. What do they say regarding to artificial intelligence is that artificial intelligence will not replace the doctors. Of course not. We have a lot of here, many years of study in our minds. But what they say that doctors that are using AI will replace the doctors who are not using them. So this is example in terms of sepsis, and as you can see, the results of this on only 1 year of data, 6 million data records with 751 patients, we find the bed stay reduction, 402, 1.42 avoidable days of bed stay in septic patient. That's very strong data in terms of ICU. 1.01 avoidable days. We know how much it costs the ICU everywhere, and I think that Grand Cayman is not the exception. And this is the places that we are real programs running alive. We hope to have some programs here. And as you can see from this example, Abbott is redefining the healthcare of the future and starting today. This is one of my favorite poets that says, when I pronounce the word future, the first syllable belongs to the past. When I pronounce the word silence, I destroy it. And when I pronounce the word nothing, I create something that belongs to any no existing place. Thank you very much for your kindly attention.
Thank you, Dr. Gryzbowski. Such an interesting talk. So many topics that are so relevant. And I would like to open the floor for questions. We have just under 10 minutes for questions. So if anyone in the audience, do we have a mic? Oh, mic is coming.
Yeah, I just have a question because I'm coming from the old school of medicine. And as I'm aging, I'm almost in the process of retirement. I know that it is evidence-based medicine is taking over everything. So, you hearing me now? Yes. Yeah. Okay. So, the concept right now is when you really define the word health. The health, what we are really looking when you are using the word health here is the physical health. Because everything which you are depicting here is related to the physical side of this body. But World Health Organization basically defined the health as a physical, mental, and social well-being, right? So when we are doing the health, physical health, and we are pushing the patients for hours and hours to really get that evidence that this is what you have already created a mental pressure on that patient of staying in so many hours in emergency or wherever in the hospital patient is. And it is very true that patient is never laughing when they are around, even if they are not sick. Or when they are sick, they really don't know what's happening. And by the time that mental agony is over, and when the bill to the patient is given, and thousands of the dollars are given to the patient's bill, even if there is insurance coverage, there is still about 10% and 20% that patient has to pay. And what happens after that? You have basically taken care of the social well-being of that family, because that $1,000 or $2,000 that the patient has extra is now gone to the healthcare system. So when we are looking totally at the cost of the country, people are making the country. And what we are really causing right now is that we are trying to sell the health. And somebody really has to start looking at what is going to happen 10 years or 15 years or 20 years from now. And the concept of the health has to really take into consideration totally in a different way. Otherwise, we are going to be doomed into this black hole of the health. This is my perspective of this health concept.
Thank you very much.
Good evening, good afternoon, everyone. Professor gave a very good speech. In a postgraduate program, I was recently asked whether or not clinical examination is becoming obsolete. And I think what is happening with modern day medicine is that we are being taught that we should not be patient-centered in dealing with our patients, but we must rely heavily on informatics and computerized data and artificial intelligence. I would say that research and modernization is a good thing, but I'm from the old school, and I still think that we should have a more humane and patient-centered approach to managing our patient. And in fact, it is very important that there is the human component in managing our patients, because input equal output. And if the wrong data or if the data is miscued, we can draw a lot of wrong conclusions. Now, it is quite obvious that research data is important, right? Such as randomized controlled trials, which give very good evidence in allowing us to use treatment guidelines, right? And just to draw an analogy, in the UK in the 80s, they did a white paper on tobacco smoking and its effect on the health of the population. And if you review that study, you will note they compare the effect. So what the government did was to induce duty. The duty on cigarette was about 70% to the real cost of the cigarette. Yes, there was a reduction in smoking, right? And when they look at smoking-related disease versus ischemic myocardial infarction or disease due to cardiovascular disease, they noticed that there was a significant reduction in cardiovascular disease compared to lung disease. Also, they noticed that the health budget from the NHS, instead of decreasing, continued to increase significantly. So also, the development and improved healthcare, it is a double-edged sword in that although we reduce the burden of some disease, on the other end of the spectrum, what is happening is that people are living longer. So there's more need for healthcare, more hospitalization, and more need for chronic care. So we need to have a holistic approach to the problem of healthcare. Yes, data will help us, and especially where we really need this data is in terms of the lab data, in terms of high specificity and sensitivity. That is where we'll need the data so that when we do these tests, we'll have better outcome in managing our patient. And this data is to be used to guide us, guidelines. But I don't think we should entirely rely on this AI, because I think in the long run, the outcome will not be where it should be. That's my opinion.
Thank you.
Thank you very much. That's an excellent comment.
We have time for one more question.
And if we can add something to that, is I strongly recommend this book of Dr. Topol that it's called Deep Medicine. Deep Medicine goes strictly related to the comments of Doctor. What AI is doing is just helping with some processes that often passed of our time spending with the patient. For example, you can remember your last attendance with the physician. If you have 20 minutes in a public scenario, it's a lot. It's a lot. Most of the times we are spending less than 10 minutes with the doctor, and the first 5 minutes are spending just clicking in the electronic health record. So what AI and, for example, this CDS is offering to the physician, it's to have more time in this humanized medicine, in the medical touch with the patient, and avoid, and you can rely on artificial intelligence instead of trying to watch the last 8 notes of the patient, the last 8 visits of the patients, and trying to find as fast as you can the trends in glycated hemoglobin and creatinine and all this stuff that always goes out of our mind and goes out for the human eye. So this kind of data can be analyzed, and you can rely on them because the lack of error is very small, and you have more time to increase your patient touch, your patient time, asking about the medical information, the natural history of this disease, and all the symptomatology that can be obtained only with the medical skills. And that is some of the affordabilities, and as I said, Dr. Topol's book about this much better than me. Thank you very much.
Great point. So last question, please.
Yes, good afternoon. Very nice talk. Thank you very much. Very interesting. I feel that from your presentation here, to implement clinical decision software, it would seem that we would need to have electronic health records. And considering that the Caribbean area is a low resource, low income area, how likely would we be able to implement clinical decision software? I'm speaking from a Caribbean perspective. Or in other words, the question is, has anyone been able to successfully implement this sort of process in a low resource area? Do you have any advice as to how the Caribbean could be brought into this era of clinical decision software without having widespread use of electronic health records? I imagine most Caribbean countries probably don't have electronic health records established probably in most of their clinical practices. So what kind of advice would you give the Caribbean if we were to try or attempt or want to implement this kind of systems here?
Excellent comment. Excellent comment, because yes, indeed, we need some strong information to implement the clinical decision support. But as I emphasized, at least we need a laboratory information system. We need to work with the region as it is. So if you don't have an electronic health record, it's not a limitation. But you need a laboratory information system. Laboratory information systems are more common and most widely used, even in limited resource locations. So you can start using CDS, using LIS, and using the big data information that comes from the laboratory. And as it improves your processes, you can walk around and walk aside the electronic health record implementation. But the electronic health record implementation is not mandatory. A laboratory information system, yes, because we need data. If we don't have any of them, unfortunately, CDS can be applied.
Thank you very much. Sorry, I think we're a little bit over, like, so,
I just want to leave the audience, if healthcare system, hospitals and the companies were not on the stock market, what would be the escalation of the cost of the healthcare today? I leave the question for everybody.
thank you.
We will go with that on mind.
And once again, thank you to Dr. Gryzbowski, and I would like to present him with a thank you gift, and this ends our first session.
Thank you very much, Dr. Bella Baraja, for chairing that session. We really appreciate it. Thank you, Dr. Gryzbowski, for that riveting presentation as well. At this time, what I'd like to do is ask those of you who have chosen to stay here to attend Ms. Carole Appleyard's presentation, Medical Telemedicine Outcomes for the Cayman Islands and the Caribbean region. Please remain seated because she's coming right up next. I'd like to acknowledge members from the CIC Farers Association, an association instrumental in providing this for Cayman. For those who have registered for the PAHO presentation, The Challenge of Climate Change and Health for the Caribbean, please take this opportunity to enjoy lunch, which is available in the Rembrandt room, which is just down the corridor and around the corner, outside on the veranda also, and next door in the Grand Cayman room. Please enjoy your lunch if you're choosing the second option, and we will be right back in this room at 1 p.m. sharp for the second option. And for Carole's option, that's right now. Thank you. It is time for me to introduce the second speaker. And once again, very engaging conversations, very controversial topics, which always makes for a more interesting session. So our next speaker is Carole Appleyard, who is the president and CEO of Carole Appleyard Consulting. She'll be speaking on medical telemedicine case study outcomes for the Cayman Islands and the Caribbean region. So very localized to us. As I said, she's the president of the CEO of the company with her name. She is Caymanian, and she owns a Caymanian-owned international healthcare consultancy company, the focus of which is to ensure healthcare economic fiscal sustainability through innovative, proven solutions in response to the fiscal healthcare crisis within not only the Caribbean region, but globally. She's a former long-term board director of the Cayman Islands Health Insurance Commission. She held multiple healthcare executive and consultancy posts and has undertaken numerous innovative healthcare projects
with successful outcomes throughout the Caribbean region, North America, the British Overseas Territories, and locally within the Cayman Islands. So very knowledgeable of our region. Carole's presentation and papers are in the diverse dimension topics of financial sustainability of national healthcare programs, universal and private healthcare programs, financing, catastrophic care cost containment, overseas care facilitation, contracting networking, health insurance, and medical medicine. So here is Carole Appleyard talking about medical telemedicine case study outcomes for the Cayman Islands and the Caribbean region.
Good afternoon, everyone, and thank you very much for attending my telemedicine introduction to telemedicine presentation here today. I'd like to start you off with a video because they say a video or a photograph is worth 1,000 words. So I am starting off with this important video. There are actually 2 case study videos of medical telemedicine. One is stroke, one is neonatology. As you are aware, these are the massive, big cost to governments, insurance companies, patients alike. And also for the saving of lives. This is absolutely essential. So can we proceed with our videos? This is what happens during acute stroke.
So let's get vital signs on him, get a blood pressure. Hey, Don, can you squeeze my hands real hard? Jane is going to start an IV in your left arm here, okay? Has he had a CAT scan yet?
He has.
Okay, good.
When it comes to stroke, time is critical. Within minutes, there's permanent damage to a patient's brain.
For every minute the brain is deprived of oxygen, 2 million brain cells die.
Telestroke is the opportunity for stroke experts to provide care to patients at the point at which they present, so they don't have to be transferred up to Portland to get that care. Telestroke transports us into the emergency room to take care of those patients in remote facilities. Hi, Don. This is Dr. Okan.
Hi, Dr. Okan. He's got right-sided weakness, a right-sided facial droop. He's got some expressive aphasia.
So this way we can have the total visual presence of the physician we're talking to in Portland be right here with us and really help us make decisions that can be critical to the care of the patient.
This gizmo is our stroke robot. Hey, Dr. Okan, this is Don. He's one of our employees of the hospital, and he developed stroke-like symptoms about an hour ago on his right side of his body.
Okay, Don, I'm going to ask you to do a few things now. Can I have you open your eyes real wide? Real wide. Give me a big grin now. Can you put your arms up for me? Hold them up like you're holding up a platter. Hold them up there. Can you get that right arm up? All right. Okay. By transporting us essentially into the room of patients, we can see them, examine them, talk to their family members, talk to the providers and work with their providers, look at their CT scans as if we were there providing care to them, saving hours of brain damage.
Providence Telestroke Network. Miles away and by your side, our stroke specialists are with you when every minute counts. With locations throughout the Pacific Northwest, Providence Telestroke Network brings stroke expertise to communities where it's needed most.
Okay, we're connected. Hi, Mom. I'm Dr. Ellenby. I'm one of the ICU doctors up at Dornbecker in Portland. Dr. Lundquist asked me to join you and take a look at your child here. It sounds like he's going to need to be transported up here to Portland, but we can use this telemedicine technology so I can actually see what's going on. Telemedicine allows them to get the specialist consultation that they want in real time, and it allows the consultant to see what's really happening as opposed to depending on the physician on site assessing the patient and then communicating that assessment over the telephone, which is a skill. We now have a camera there and can see what's happening. It helps them get the neurologist or the pediatric intensive care doctor when they need him right away.
Because as we all know, especially in the pediatric world, we do not have adequate subspecialists to go throughout the entire state. We only have 2 pediatric intensive care units, both of them located in Portland. We only have certain subspecialists, once again, located in Portland. So this provides, helps with one of the crises that we have in healthcare, which is the distribution of limited personnel, and those personnel are going to be located in the bigger cities where they have more of the population to see. So this will provide outreach programs in the future with telemedicine as it evolves from its infancy state.
So we can both improve the immediate care the child gets by helping the docs on site. We can reduce costs when we don't transport patients unnecessarily. A lot of these children can be cared for in the community safely. It's just a matter of improving the comfort level on both ends of the call to know that things are being done correctly. In the acute care situation, when time is minutes, for example, with regards to stroke care, you need to have a neurologist make a decision pretty quickly as to whether or not to deliver what can be a brain-saving medication called TPA. Those neurologists aren't available around the state, but they are here in Portland, and they can provide the consultation with telemedicine.
I'm going to watch along here while the doctor asks you to do a few things here.
Okay, Norman, tell me your date of birth, if you could.
March the 17th, 1935.
Perfect.
Well, I can talk with the family, which is advantage both to get additional history, but also to reassure the family of, that the consultant, the intensive care doctor's been in the loop early on and really knows what's happening. I can also look around the room, get a look at the monitors, get a look at the x-rays, which actually can be now digitally sent as well up to our site. But it allows just for a better, more intimate relationship with what's going on as opposed to the anonymity of being on a phone call. And you never really quite know what's going on when you're on the phone. Video, you see what's happening. And it can be very reassuring for the families to kind of have a visual as to where they're going. Instead of getting in the middle of a dark ambulance in the middle of the night, 5 hours away, they have a visual of where they're going, and there's people waiting for them on the other end, and they repeatedly tell us how much that improves their overall stress level in a stressful time otherwise. We should be down there just a little bit before midnight. It's an advanced practice nurse and a respiratory therapist who'll be in very good hands on his way back up here. They ought to be able to take you with, depending, I don't think there's any special concerns right now. So you'll be able to come back up with your child. RSV is a common virus right around now, especially for premature babies, and can slow down their breathing. That's why they had to put the breathing tube in. But it looks like he's pretty stable at this point. Okay, Dr. Lundquist, anybody else have any other questions? Mom, do you have any other questions? He'll be in good hands on the way up.
Could you cut the video now, please? Thank you. There are more videos like that, but I needed to show you, first of all, 2 videos on 2 very expensive case studies. So we go to, where is the clicker, Dr. PAHO? Oh, yeah. Thank you very much. We go now to the introduction of the presentation. In July of this year, RP Light 4 Next Generation Technology arrived here in the Cayman Islands, the first of its kind in the Caribbean region. And this is just a photograph that shows its arrival and shows myself with the 2 engineers, the medical telemedicine engineers, One is a local gentleman, and the other one is the one from Santa Barbara, California. Both engineers worked together to set up RP Sally ready for startup. That was a proud moment again. RP Sally is Caymanian owned and operated, by the way, which is also a first in the Caribbean region, which brings the power for change into our own hands here, starting with the Cayman Islands. I'm hoping my presentation shows you the difference. Although it is called telemedicine, telehealth, remote presence, AI, all kinds of different descriptions about it, I wish to show you the difference because there are many differences. Telemedicine brings healthcare within the reach of isolated populations residing in medically inaccessible areas. That is mostly through audio. That is mostly mobile phones, a mobile phone connection over the public internet service. Whereas medical telemedicine goes the step further, as the videos show. Medical telemedicine facilitates fast, accurate diagnoses and care to complex catastrophic care cases, such as stroke, within seconds of connectivity. Everything is done in one go, everything, including immediate real-time reporting, as was stated in the video. I'll take this opportunity to just give a brief overview too. My case studies at the time, I did my case studies for the entire region and Central America as well, took place 6 years ago. And I did an in-depth study, and I traveled to those locations as well. And the results, and I put on presentations, very complex presentations, which are available to you. If you wish to see such things, you may take my business card. But that was far too lengthy to present today to you. And overwhelmingly, the Caribbean region and Central America, isolated countries such as Belize as well, are very, very interested in this. And I could prove the financial aspects of well-being for healthcare budgets throughout our region. And I've now advanced to promoting telemedicine throughout the world. And we are in 2,800 locations throughout the world, including the Arctic Circle. So I'll go on with my presentation. Now, what is the difference between telemedicine and medical telemedicine, which RP Sally is medical telemedicine? It has the security of the FDA approval of medical devices. And is ready at all times to handle even the largest hospital networks, as well as single and multi-specialist locations with direct 30-second reliable connectivity, having networks of users in the hundreds and thousands of locations locally, regionally, and across the world. Medical telemedicine encompasses all specialities, and especially has emphasis on catastrophic care to save lives, as well as saving immense healthcare dollars. FDA medical telemedicine systems are equipped with peripheral robotic medical tools and the fastest access for comprehensive, best outcomes where time and acuity demands immediacy of diagnosis and best care outcomes. These are the telemedicine clinical applications. Some of them, it is far more extensive than this because we can include education, we can create our own networks, our stroke network, our connectivity with other islands, and we have 2 more islands here in the Cayman Islands where this application may be extremely useful too. Telemedicine clinical applications consist of catastrophic care, stroke networks and outreach, critical care, high-risk obstetrics, neonatology, mental health inpatient and outpatient, emergency services, trauma, burns, disaster preparedness, dermatology, pediatrics, contagious disease, Ebola isolation, long-term care, home care, and the list goes on. I can also say that there is a mini version of medical telemedicine device that is specifically built for ground ambulances and helicopters, so that they can see the patient at the point of the trauma, at the point of the stroke, even on the way to the hospital. Next slide. Tackling the hardest challenge first. Stroke is the leading cause of adult disability worldwide, with up to 2/3 of individuals experiencing long-term disabilities. Medical telemedicine enables providers to deliver miraculous care when the minutes matter the most. When I say when the minutes matter the most, in stroke, it is called the golden hour. And for acute stroke, that golden hour is vitally important. And so when you can have all of the details about the patient, you can make a diagnosis that assists the patients from the 30-second point onward. So immediate action is initiated. And this is the part that saves lives and saves funds, healthcare dollars. Telestroke networks. Those were networks that you saw in the videos. Telestroke networks benefit both patients and providers by creating real-time remote access to telemedicine neurologists within 1 minute maximum response time. United States nationwide, there are only 4 neurologists per 100,000 US residents population, which makes the need for telestroke services critical in the world, and particularly in remote locations such as ours. Catastrophic care and stroke case study outcome. This is a singular case that I'll bring before you. These are the cost aspects and life-saving aspects of a case such as the one in the video. Treated locally, this local medical telemedicine case costs were ground ambulance, inpatient hospital bill, medical telemedicine consultations and follow-up. The whole of those consultations were less than $600, by the way, because the parity is on par with our health insurance commission standard fees that are on that website. So it's absolutely affordable. Long-term rehabilitation on the case was not required because the fast diagnostic response and the fact that treatment plan was set up immediately. Average cost per case in these cases is $25,000 plus. I always put plus in case there's an extra test or something that covers that bill. I've seen these bills in person. The overseas air ambulance evacuation case cost, which was the only solution in some cases of acute stroke before telemedicine came on board. So you would have the evacuation by air ambulance, which for stroke takes a longer period of time in the air at a lower altitude to make sure that the patient is comfortable and to make sure that going at the higher altitude does not affect the stroke, in a negative way. So you have the cost of the air ambulance, you have the wait time associated. You have the inpatient overseas bill, which is always quite high in most cases. Long-term rehabilitation costs would be phenomenal. All care managed overseas on this type of scenario, the average cost per case is $1 million plus, depending on the length of the rehabilitation overseas. So if we just take 10 cases of overseas care for acute stroke, we're looking at $10 million. If we look at 10 cases managed here at home, where the patient is more comfortable, the family can come and visit the patient, and they have a faster return to work time or return to normalcy, that would be 10 cases for $250,000. So this is just one single case comparison, and this is the way we can look at it, where we can take acute cases and make them our priority for cost savings and saving lives here. And it wouldn't do any harm to our tourism either, I'm sure that, because we are connected to 2,800 locations in the world at this time. It was 900 locations 6 years ago, and that is growing. This is an interesting matter that always comes up, and it's about what are they doing in the United States about parity? States with parity laws for private insurance coverage of telemedicine, 2018. When I first started my study, about an eighth of that United States graph was telemedicine, that telemedicine was being used in those states. So this is 2018 graph, and you can see all of the states in orange are using telemedicine and have parity laws. That means, I don't want to get into it too deep because I could do a 3-day presentation on this one alone. But that means that they have agreements with government, and they are in agreements with the insurance company too, about what sort of a fee, what sort of circumstances are payable under telemedicine and health insurance. Now, the states that are in black do not have parity laws at all, so patients have to self-pay. I'm sure they will negotiate parity laws and come on board, but as of 2018, they are not on board, and as of today, when I'm speaking, they're not on board. It does not mean they're not on board with telemedicine, because they are performing telemedicine, but patients are paying for it themselves. The insurance coverage and the governments of those states do not have parity laws between them at this time. All right. My presentation is short because of the videos and because I felt sure that there'd be quite a number of questions. So I would also like to take this opportunity, which is vitally important to me and to us here in the Cayman Islands, to ask you if you would join me, ladies and gentlemen, in honorable recognition and immense gratitude to the Cayman Islands Seafarers Association for their commitment and loyalty to bringing the next generation medical telemedicine technology to the Cayman Islands and indeed to the wider Caribbean for the benefit of all people in order to save lives and healthcare funding. I would now like to introduce the executives of the Cayman Islands Seafarers Association who are here with us today. Mr. Denniston Tibbetts, President, Mr. John Douglas, Vice President, and Mr. Eden is not here? Okay. And we have the seafarers here. Pardon? We have Mr. Ivan Farrington. Excuse me? Yes, Mr. Farrington is a member of the association who attends these conferences every year. I know because I remember his face. And a past president also of the Seafarers Association. And their loyalty to ensuring that we were on board with medical telemedicine, and this system is the best in the world, bar none. And I will talk on my last slide about that. My last slide is here, and this is me doing my training on the robot. So instead of my face, that would be the doctor. And these things this is the desktop, as it were, for the robot. And these are the medical peripheral things that you can bring in. So the diagnosis is done right where it is on the spot. And you have zoom cameras, you have stethoscope, you can make the robot go anywhere you wish. And the audio and visuals are amazing. And the new progress in this area is such that next year's addition to the program is going to be absolutely amazing. It's called Bridging. but I will talk about that at some other presentation. I'm here today to just introduce you to telemedicine and how it works and how there are differences. And don't think that when someone says, I can do telemedicine, that they're doing medical telemedicine, because this is the all-in-one, and the audio visual from the iPhone is a different matter altogether. It's still very good, but it isn't going to save you the big dollars. So my focus is on the big dollars and saving lives. And thank you, Seafarer Association. Could I have ask the seafarers if they'll say a few words about themselves? Okay.
Thank you. My name is Dennis Tibbetts. I'm the president of the Seafarers. Well, the Seafarers basically formed in 1994 to have all of the past seamen together to try and help our country, as we did when we were seamen. For those of you who enjoy the Cayman Islands now, it all started with the Southwell years, which we were a part of when we sent all the allotments home to build this country. We're not recognized as we should be, but I press it every time I do a presentation that one of these days, our past can never be forgotten, but one of these days we'll be recognized for what we are. Also, as far as your presentation went, we're very pleased that over the years we have supported the health services and yourself. I feel compelled to say something on the stroke, because unfortunately, I had a stroke 3 weeks ago.
I'm sorry to hear.
And I don't know if there's a format for what causes it and all that, but I was told by the doctors at the time that my pressure went up. So my daughter took me to the emergency. The doctors wheeled me in and did a ECG and a brain CAT scan. And they found that there was a slight infarction on the right side of my brain because my pressure went up. Fortunately for me, in 3 weeks after I'm whole, it didn't go as far as to touch the parts of my brain that control my movements, you know. So I'm very pleased and I'm very grateful to God. Unfortunately, this Sally that we just purchased for the health services was not in operation as yet, so I was unable to enjoy the fruits of our providing that. Nevertheless, we still feel very privileged to have provided it for you, and we look forward that in future it will be used properly and to the advantage of the Cayman public.
Thank you.
Thank you all very much.
I just want to make a comment, not a question, but on behalf of the health services, I want to say thanks, Carole, for your presentation. And again, I just want to echo Carole's gratitude, because unbeknownst to quite a number of persons in Cayman, the current telemedicine robot that we have is currently considered to be the best state-of-the-art robot. And I particularly want to say thanks to all of the persons who helped to bring that technology to the Cayman Islands. We've seen, Carole showed where comparatively there's a saving when we keep the patients here locally. And we had a colleague who had a stroke, and I was the person who was on call that night. And unfortunately, we were able to access the telemedicine neurostroke network that we had established. When we called and we asked how much it was going to cost to send the patient overseas, we had to find $500,000 before they would be willing to accept the patient. And so we accessed care overseas through the use of the telemedicine robot, and it didn't cost the patient as much as $6,000. So there's so many advantages because the patient was kept at home, the patient's family was able to be here, so all of the not only the tangible costs, but there are so many other intangible costs and benefits that came out of us keeping the patient at home. We're currently looking to use the robot more extensively so that we could end up saving, decrease the spending on healthcare. And so, again, thank you very much. In fact, as of next week, the first week of October, we're going to be running a neuro clinic with one of our a neuropsychiatry clinic with one of our psychiatrists. And she will be running a clinic 3 times per week with the use of the robot. So remotely, she's going to be able to access her patients. So we have this technology here, and we just want to say thanks. As medicine advances, sometimes it comes with benefits, and sometimes, as you saw for those of us who were in the first presentation, sometimes the benefit is not as great as we thought, especially when you look at the evidence and you do retrospective studies. But this particular technology is the technology that is available to us, and hopefully we will see, as time goes on, the savings associated. So once again, thank you very much, and thanks to you, Carole, for bringing it along with the seafarers to us. Thank you.
Yeah, just one question. I was wondering, is this technology only available from the proprietary equipment that they provide, or can this be sort of extended to use mobile phones or to use other devices? Because I was wondering, as he was speaking, whether, you can do this through a company like you're doing here, but you can also pick up a phone and FaceTime a doctor in the States that you've spoken to or made a contact with. So there's alternatives I can see to your business. And I'm just wondering whether your business can go in that direction, or whether there are other alternatives to what you're providing.
Absolutely, and that's in the works as we speak. I cannot speak about it right now, of course, because engineers are working on that in California at the present time. It will be called a bridge, and if you want to know more about it, I'd be happy to talk to you at the conference one-to-one. Okay, so that's coming. But you must understand that with catastrophic care, it requires medical telemedicine to adapt to it. The regular telemedicine is great, and it's an absolute bonus. But with the peripheral medical attachments, with medical devices such as RP Sally, you're right there in the room as though they were with that specialist in Miami, and everything pertaining to accurate diagnosis is going on within that 30 seconds immediate time frame that's needed for stroke. So yes, there is something, but these medical telemedicine systems are all operated at source, meaning there's 100% guaranteed connectivity within 30 seconds. So a company would not want an inferior, I don't like the word inferior, but shall we say, a regular iPhone to come in and interrupt something very serious that's going on. Yes, iPhones are going to be able to connect, but there will be a subscription fee for connectivity to such high-level catastrophic care medical systems. I'm sorry, could you speak loud?
Is there any increased insurance coverage that the hospital or anybody would require to actually do?
Absolutely. In fact, I know that this conference is being recorded. There are certain things that I wouldn't want to have out there in the open. So certain things I need to talk with individuals that have a greater interest in medical telemedicine to speak to me, and I can tell you more. But yes, definitely yes. If you'd like to speak to me, please look for me at the conference, and I can tell you so much.
Yeah, I have a couple of comments and question. I think the introduction of this kind of intervention is critical to moving forward in medicine. I'm a psychiatrist, and I see the value of it even outside of psychiatry, but I'm thinking about the rapid increase in diagnoses of behavioral disruptive behavioral disorders, for example, and the kind of impact it can have on a school child's life if they have to wait 1 month to see a psychiatrist. And I think this is particularly important when one thinks of the small islands, like the BRAC. I mean, we're small, but when we think of like Cayman BRAC, and handling referrals for various kinds of problems, which can really cause a lot of disruption to the person's work and personal life and school life. So to be able to bring this kind of power in diagnosis and prescription in a short period of time is very important. I'm thinking also about the whole business of second opinions and the cost to the Cayman Islands of having to send people overseas for second opinions, when with telemedicine, we could get the second opinion more quickly and at lesser cost. And I think this is something we need to embrace. The one limitation I see, of course, has to do with the power of the internet and how much power we can bring to the Cayman Islands in terms of internet supply so that our systems can run efficiently. Because as time goes on, I see this expanding. So my question really is, are we looking at that aspect of things? Because our companies have to be able to provide the kind of internet security and the amount of, what would you say, gigabytes, whatever, that we need to use to maintain this.
Right, thank you. That was music to my ears. Yes, this system is approved by the FDA. It's the only medical telemedicine system that is out there that is approved by the FDA. So we have all of that in place now. As I speak, it's been in place for a long time with this system. We've had RP Sally 1, now we have RP Sally Next Generation. So yes, I would like to talk to you and give you more specifics. So if you could, if we could talk when I leave my speaking engagement, that would be very interesting, and I could give you a greater update.
Next question.
It's not a question, but it's just a response to... It's just a response to Dr. McGill's interest. She mentioned second opinions, and that's a very useful aspect of this, very useful tool. Well, the robot provides the resource for second opinions. So, for example, we have a number of our physicians that send patient overseas for a second opinion, just a second look. And we've had some of the overseas physicians saying, well, you know, if there was a way where we could interact with the patient locally, then they would not have to come overseas for the second opinion. And so right now, we're in discussion with a number of our overseas providers, trying to make some arrangements so that they can actually access, they can see our patients remotely, so that we don't have to send the patients on a plane for second opinion. And well, Dirk, my classmate, left, but he was asking a question about using cell phones. The advantage of using the next generation RP Sally is that the peripherals that come with it, it has stethoscope. You can see your CT scans, you can get your ECGs, your EEGs, you can hear your heart sounds, your lung sounds, and that sort of thing, which is the reason why it is FDA approved as a medical telemedicine robot, which is a little different from when you have a little makeshift thing with your phone, which does not allow you to have these other peripherals. So that was in response to his question.
And I must add to let you know that the privacy around the cases is 100%, whereas iPhones, telephones, mobile phones, connectivity is generally, usually, the public internet, which can go down at any minute, even if you haven't paid your bill. So whereas this system is built for specific catastrophic care events, it can handle all the rest, but when you're built for catastrophic care events and best outcomes, you have to think long and hard before you allow cell phone access into that area. And that is what is being thought about and discussed at Telehealth Innovations right now with the engineers. So we will be looking at that. It definitely will be available by next year for sure. But there will be a subscription fee to cross that bridge into the higher level system. Small subscription fee. So that's what the future holds.
Thank you very much. I would love to thank Carole.
Yeah.
And it's a very proud moment that we have this technology here, and I hope we're an example for the region, and they follow in our footsteps. That way we can all enjoy this, because it's where medicine is going, is the future.
Yes.
We should all be able to access this care. And here's a little token of appreciation.
Thank you.
Again, thank you for joining us.
Thank you. I'll just say there are a lineup of our British Overseas Territories that are waiting and on order for this. So we will be connected as a family and as a group of regional buying power that we have never had before.
Thank you very much once again, Carole Appleyard, and the Seafarers Association that are with us as well. I'd like to acknowledge them again. Thank you very, very much, Dr. Baraha, for your chairing this afternoon. Enjoy your lunch now. You get the opportunity to enjoy lunch. And thank you very much, Doctor, for your remarks as well, your speech. Yes. Excuse me. So for those of you who were involved in this session, take the opportunity now to enjoy lunch, which is available in the Rember room just right around the corner by the registration desks. Those of you who are heading off to lunch now, enjoy your lunch. We'll see you back in this room at 2:10 p.m. sharp. That's when we're going to have the next featured speaker after myself presenting for Nasolo. The next featured speaker in this room after me will be Dr. Carrie Rood, who's the Extension Veterinarian and Associate Department Head at Utah State University, with his presentation on One Health, the veterinarian's role in combating antibiotic resistance, zoonotic disease, and climate change. So quite a lot on with climate change this afternoon. For those who have registered to attend the PAHO presentation on the challenge of climate change and health for the Caribbean, please remain in your seats as the session will come up very, very soon. We're just waiting for people to filter in from the other room after their lunch. And as a reminder, we have lots of exciting exhibitors this year, so after the session, please do visit all of those booths and the health check. I am now going to introduce the next session chair, Dr. Samuel Williams Rodriguez. He doesn't need a formal introduction because I did that yesterday. He is the Director of Primary Health Care and the Medical Officer of Health at the Cayman Islands Health Services Authority. So I think at this opportunity we should probably allow just a couple of minutes to have the others come through before we get started. So within that couple of minutes, before I hand over to Dr. Williams, I just wanted to go a sort of an interesting timeline of the last 10 years that brought us up to this 10-year anniversary. 2010, the first ever CI National Healthcare Conference, which is a leader in the region now. Envisioning the future, the dawn of medical tourism. Imagine that was the dawn 10 years ago and how far we've come. Quality care at what cost? Then we went to 2011. Envisioning, to improve healthcare, you must improve quality. Create a culture of a happier, healthier, more productive population. 2012 was all about economics. Placing patients at the center of healthcare. Do we want wellness or well-being? 2013, we went into workplace wellness. Get off your seats. And at that time, the DG5K was launched because of the inspirational talks from that session, from that year's sessions. And we also took note of the sex or gender discriminations and dimensions in healthcare as well. In 2014, we looked at non-communicable diseases, NCDs, and our thrust to work on the biggest burdens on the healthcare all over the world. In 2015, Emerging Trends was our title, and the Healthcare Decisions Law was born shortly after. 2016, we looked at chapters of a healthy life because, of course, every demographic and every age group will have different needs throughout their life. So we looked at from cradle onwards. There's always something we can do to improve our lives. 2017 was all about food for thought and realizing that we are basically what we eat. We're the gasoline that's put into the engine. We looked at how we could manage our diets through the decades of our lives and letting food be our medicine, which is really interesting from the cultural side as well, because in the old days and even now, Caymanians and Caribbean people have been very big on using natural medicines, what we call in West Bay bush medicines, for their healthcare needs, and that's still happening today. 2018, Empowered Patient. It was all about it's your health, take control, get educated, become empowered. And 2019, this year, of course, is innovation and a particular focus on one world, one environment, one health, which is very, very apt right now in the era of climate change and the instability that that brings. So I'll turn over now to Dr. Samuel Williams to chair the afternoon session. And welcome to Dr. Rue, not his first time in Cayman. It's lovely to see you again.
Thank you, Nancy. I guess a few people are finishing their lunch and they will be joining us soon. However, we need to try to stay on time and then we're gonna move on. The next presentation is on climate change and health, and it was supposed to be given by Mrs. Nasolo Thompson, consultant from PAHO, but she cannot be with us here today even though she was planning to attend. So Ms. Nancy Barnard will do that presentation on her behalf. Just a bit about Ms. Nasolo. The topic actually is the challenges of climate change and health. I think it's very important because a lot of people are aware of climate change, but when we associate climate change with how can that affect our health, I think people normally will pay more attention to the association between what's happening with the climate and our health. I'm just going to read a short bio for Nasolo. Nasolo Thompson is a public health professional with over 18 years of experience in program management. Over the course of her career, Nasolo has worked with community-based organizations and the International Labor Organization on AIDS and HIV and AIDS, worker health, and toward the elimination of child labor. She has also worked with the United Nations Development Program to coordinate program implementation across 5 technical areas. Since joining the Pan American Health Organization in 2017, Nasolo has been responsible for supporting the governments of the Cayman Islands, Bermuda, and Jamaica to address the health program and the social determinant of health across the life course. She has worked on a wide range of issues, including the national profile of worker health in Jamaica, health promotion strategy for communities with high levels of social inequity in Jamaica, review of the national neonatal intensive care policy and protocols in Jamaica, workforce health planning in Bermuda, early stimulation for young children in high-risk communities in Jamaica, national climate change and health sensitization in the Cayman Islands, gender-based violence training for healthcare workers in the Cayman Islands, Bermuda, and Jamaica, and the health agency policy in Jamaica. She also has worked in maternal, child, and adolescent health. So there is a short 5 minutes introduction by Skype by Nasolo. I don't know if it's ready. Is it ready? Please go ahead with it.
Good afternoon, everybody. On behalf of the Pan American Health Organization and World Health Organization, it gives me great pleasure to bring greetings on behalf of our PAHO Director, Dr. Etienne, WHO Director, Dr. Tedros, and PAHO WHO Representative for Jamaica, Bermuda, and the Cayman Islands, Dr. Bernadette Theodore Gandhi. It is with great pride that I remind anyone who will listen that PAHO is the oldest public health agency in the world. And since its founding in 1902, we have been active in provision of technical cooperation and mobilizing partnerships to improve health and quality of life in the countries of the Americas. Being cognizant of the robust global scientific consensus of Earth's changing climate and the associated adverse negative effects, not only on the Earth, but also on the health of its inhabitants, it is incumbent on us all to implement systems and initiatives to address the implications of climate change for health and health systems. PAHO and the WHO have been partnering with governments to do just that, and I'm happy that the Cayman Islands has not been left out. Dr. Tedros once said that people living in small island developing states are on the front line of extreme weather events, rising sea levels, and increasing risk of infectious disease, and that we owe it to these people to do everything we can to help them prepare for the future that is already washing up on their shores. In our thrust to advance universal health, PAHO WHO has moved to pay closer attention to the populations most vulnerable to climate change and its effects. On November 12, 2017, WHO, in collaboration with the UN Climate Change Secretariat and in partnership with the Fijian President at the 23rd Conference of the Parties, launched a special initiative to protect people living in small island developing states from the health impacts of climate change. The vision is that by 2030, all small island developing states will have health systems that are resilient to climate change, and countries around the world will be reducing their carbon emissions, both to protect the most vulnerable from climate risk and deliver large health benefits in carbon-emitting countries. The 4 main goals of the initiative are to 1, amplify the voices of health leaders in small island developing states so that they have more impact at home and internationally. 2nd, to gather the evidence to support the business case for investing in climate change and health. 3rd, to promote policies that improve preparedness and prevention, including climate-proofing health systems. And 4th, triple the level of international financial support to climate health in small island developing states. We recognize that the health sector can significantly contribute to both mitigation and adaptation efforts by reducing its carbon footprint, building upon its work to make its healthcare facilities more resilient and environmentally friendly. We are aware of and appreciate that many mitigating efforts are being undertaken by other sectors which also benefit health. For example, a reduction in greenhouse gas emissions from industry and transportation sectors which support the alleviation of air pollution. In our approach, we must strategically engage in intergovernmental climate change discussions. It is important that all sectors work together in ensuring that we are better able to anticipate, prevent, prepare for, and manage climate-related health risks. At PAHO, a good environmental steward, we intend to do our part in reducing the effects of climate change. We encourage you all to catch the fire for this movement, considering that our health depends on our action. The earth is changing and we must respond and not react to what is imminent. As Dr. Tedros said, the future is already washing up on our shores, and as such, this moment, this meeting could not be more timely or urgent. I hope this will be a very successful meeting and that all objectives will be met, and most of all, that we will be more equipped to tackle the imminent and long-term threats of climate change. Thank you and have a wonderful meeting.
Okay, I want to thank Ms. Nasolo for that brief introduction. Now I want to present to you Ms. Nancy Barnard, who is now a stranger for none of you, and she's going to be delivering the presentation on climate change and health for the Caribbean. Ms. Nancy.
Thank you very much, Dr. Williams, my healthy neighbor. So if you could bring the slides up, that would be great. So I'd like to preface this talk by saying a few things. The first thing is I found out that I would be doing this yesterday. So please bear with me because it is not my presentation, but I'm very passionate about this topic. So hopefully I can do Nasolo and PAHO some justice with it. I'd also like to say it's a really, really important topic, in particular for the Caribbean region and SIDS, Small Island Developing States. So I don't know if the audio is on in the other room, but if people are hearing and kind of want to come into, the reason that we have so much elbow room is because a lot of people are watching the live streaming next door, but if we want to get together in this room, that might be a good idea as well. And finally, I'm not a medical practitioner, so although this is talking about climate change and health, we want to make sure we have like 10 minutes at the end so that medical practitioners, doctors, nurses, technicians, etc., can speak to some of the things that this topic might raise. Okay, so the relationship between health and climate change. First of all, do you guys remember about 10, 15 years ago when we talked about climate change, one of the most common images was a polar bear sitting on a little broken away ice floe. Hands up if you remember that. I know I do. So to me, and I'm sure many of us in this room, it was very much an environmental problem. People didn't think of the health impacts. To be very honest, I didn't until a few years ago. We're the Ministry for Health, Environment, Culture, and Housing, so we have other big subjects. So, we were looking at it mainly from environment. But actually, the impact of climate change on environmental determinants, which then affect health, is a massive issue. And it's just been opening and unveiling itself to us at the Ministry of Health, which some of my colleagues are here, over the last 2 years. What we want to do with this is outline the role of the health sector in adaptation and mitigation. And I want to stress that the main role is adaptation because, unfortunately, while we can do our part in reducing, greenhouse gas emissions and fossil fuels and everything else, at the end of the day, we're tiny, right? So while we don't contribute in a large part to the problem, we're going to be largely facing the issues that come our way. So we're going to have to learn really fast to adapt. So PAHO's key health and climate change adaptation strategies and the regional health plan is what I'll cover. And then I'll get a little bit more into the local context because you're probably sitting here going, okay, that's nice, but most of us here live in the Cayman Islands. And so we want to know what does that mean for our own backyard? Evidence. Now, there's clear evidence. There might have been some climate change deniers, 5, 10, 15 years ago, but now there's clear evidence, okay? And in fact, I'm sure you all have been watching the news recently with the news going on with the United Nations meetings. Over the last 20 years, including WHO, International Panel on Climate Change, that human actions, principally the burning of fossil fuels and the associated release of climate pollutants, are causing significant changes to global climate system. This, to me, is a massive issue. And actually, my daughter went off to school. She's 14. She wanted to go off to school, though our schools here are outstanding, but she wanted to go, so we didn't stop her. And I thought, I'm going to look into what I can do to offset every time that girl takes a flight at the end of every term. So I Googled it the other night, layperson Googling, this is not scientific. I was so shocked and dismayed. I basically have to, and I love gardening and have a bunch of neem trees planted in the backyard, and they drop seeds. I'm sure if you all like gardening too, you'll see that. They're very easy, and the faster trees are growing, the more carbon they suck out of the air, apparently, the faster growing trees. And I thought, oh, it's probably about 5, right? But for a round trip from Cayman to Toronto, where she's at school, I can't remember the exact figures, but I would have to plant about 30 trees. That's a lot of trees for every flight. And you imagine we hardly ever travel. The people that travel all the time for business and pleasure and, and not just aircraft, but our cars, which is why the Ministry of CPI, Commerce Planning and Infrastructure's car-free day with the civil service was outstanding, because so many of us took them up on that and took the bus and so on and rode in. And so we just need to make roads safer and everything, and just really pay close attention to what we can do, whether it's plant 30 trees every time your kid takes a flight, or in our personal choices. We absolutely have to do it now. By the end of the century, scientists project that there will be almost 4 times the amount of greenhouse gases in the atmosphere as compared to pre-industrial levels. We've touched on this a little bit in previous talks, and we will in talks that come up with the One Health as well. This could result in a 3.7 to 4.8 centigrade rise in global mean surface temperatures. Basically, we'll soon see how that ties in with health. I was shocked when I went to Grenada last year when we had this conference. Last year was in October, and I was in Grenada at the intergovernmental conference with all the Caribbean regions on climate change for WHO and PAHO, and it was a shocking discovery of what we have to face. So there's a lot we have to do. Here are some projected warming trends that are coming out of that. The top is 2020 to 2029. The bottom doesn't bear thinking of. It's a long time from now. It won't really be many of us in this room. It'll be children, grandchildren, nieces, nephews if we don't have kids. 2090 to 2099, basically the end of the century. That's, of course, worst case scenario, as I understand it with this slide, but a lot of it will be uninhabitable. Now, the thing about this kind of session is I don't want to just paint doom and gloom, because I think that's part of the problem. We've always, as human beings, got to have hope, and we've always got to figure out what technology, what innovations, what inventions can we do to stem the tide, mitigate, and adapt to what we have coming down the pipeline. But one thing we just can't do anymore is ignore it, and I think we're at a conference, so probably we all like to read and watch the news and everything else, and I'm sure most of us in this room are pretty clued in on it, but just help spread the word. Now, the increase in average temperatures may result in severe disruptions to precipitation patterns, as well as frequency and intensity of extreme weather events. In the Cayman Islands, for the past 10 years, my colleagues over in the meteorological office have noted that there are the average temperature has gone up year over year for 10 years, right? The hurricanes, anecdotally, hands up if you remember 1 or 2 hurricanes in your childhood. That was me. I remember when Gilbert came through after Jamaica, and I think it was like 88. It was a big deal, and that was maybe a 3 that brushed past us. Now it's kind of every single summer. There's this march of the discs going across the Caribbean, and I heard word the other day that they were thinking of coming out with a Cat 6. I don't know where I heard that from, so please don't quote me on it. But the point is, they're getting bigger, they're getting badder, and they're getting more often. And we need to, figure out. Luckily, we're outside of the main band of hurricanes, but in the Cayman Islands. But it affects our neighbors and our global stressors with these storms. There's potential for. You've seen them, storms and floods. You only need to look in mainly the southern U.S. and other parts of the world. They had it in Spain the other day, in India. Mass displacement and disruption of livelihoods in low-lying coastal zones and small island states. Inland flooding, particularly vulnerable urban centers. We have breakdown in food systems from drought, flooding, and extremes in precipitation. And potential for increased risk of violent conflict associated with resource scarcity and population movements. Now, The violence over that might not be very widespread, not in the Cayman Islands right now, maybe other parts of the Caribbean, but in other poorer parts of the world with a lower GDP, they are really starting to show themselves. If you think about it, if resources are going down, access to clean water, to food, farming is being changed because of droughts or floods and so on, all of that is going to affect everything from the bottom line to what food you can access, medicines, and everything else. So it's really something to pay attention. And, the fires in California last year, I mean, the conditions worldwide are speaking loudly and clearly. And while we can't go into all sorts of negative states on it, we need to harness that information and be alarmed. So with these climate change issues, we'll also see a slowdown in economic growth and exacerbation of poverty. Again, maybe not so much here, although, I don't know, I put my hand up when I say I'd like to start planting more fruits and veggies because things are getting really pricey. So negative implications for health targets, including achievement of the SDGs, Sustainable Development Goals that we're all trying to reach by 2030. Greater risk of injury, disease, and death due to more heat waves and fires. Increased risk of food and waterborne diseases. That's a big deal as well, which is where our lab technicians, I see Tony here, are very, very critical to the work we're doing to adapt and mitigate to climate change. Increased risk of vector-borne diseases. And, shout out to our Mosquito Research and Control Unit, MRCU. They're a regional leader. And, it's one of those things you're always kind of walking this tightrope. People are becoming more and more aware of their health, and they're more and more aware of what chemicals and insecticides and larvicides you might be using, but at the same time, it's that balance, isn't it? If you don't use something by a certain time, you might get a crop of new eggs and new mosquitoes, and then you might have a vector-borne disease exacerbated by climate change. So we're finding this kind of push on one side and this push on the other side, and we're kind of in the middle trying to do right as the Ministry of Health and PAHO and WHO. We also have increased risk from undernutrition resulting from diminished food production in poor regions, as I say, maybe not so much the Cayman Islands, but other regions. This slide of Nasolo's is very technical. I think we're looking at this one, which is this top one, which isn't as worst case scenario as this one. So this would be the better case scenario, but it kind of shows where the vector mosquito Aedes aegypti, and it's the one with, it's really easy to spot. They're tiny and they're more domestic mosquitoes around your house and yard, but they have little black kind of lines on their legs, and they basically, vector a lot of these diseases, Zika, chikungunya, dengue, and so on. So they're really, really dangerous little critters. Actually the largest killer in the world. When you think of killers, you think tigers and all the rest of it, but it's actually the good old mosquito. And this slide is just basically saying with the rate of greenhouse gas emissions, we're going to be, we could increase by 8 or 13%, I believe, is, hopefully I'm doing justice to that slide. And this one shows the selected significant climate anomalies and events in 2018. It talks about, I'll just pull out a few of them out of interest for us. Hurricane Michael in 2018, maximum winds 250 kilometers an hour. Michael was the third most intense hurricane to make landfall in the contiguous US based on central pressure, the fourth most intense based on wind speed. And again, that was just last year. Florence as well. Following suit, we've got Alaska, warmest year on record, second warmest year, trailing behind 2016. Let's jump across the globe over to the Antarctic. You're looking at the sea ice and the melting, and that will, of course, increase the sea level rise and so on. So all over this globe, all over this planet Earth that we live on, there are events and anomalies happening at an alarming rate of speed. Right, let's turn now specifically focusing on health. How does this affect our health and well-being? There are three main groups of health risks associated with climate change, right? The first is a direct impact. You have your extreme weather, which we've talked about, hurricanes, fires, that kind of thing, heat waves, just basically disasters. And it's not just what happens. I mean, I don't know about you all, but, what are we now, 15 years after Ivan here? Who was here for Ivan? See a show of hands. It's the traumas that go on in the weeks, the months, the years after. It's that. So it's the stressors. It's the economic impact. What does government have to spend to bring the country back into line? It's the loss of tourism. So the deduction from the economy. It's so much just for the direct impact. And then, diseases and so on. Then it's impact through natural systems such as air pollution, food and water contamination, when you have floods and so on, distributional shifts of vectors, hosts, and pathogens. And let's talk about air pollution. Asthma is a very high level, one of the main NCD killers. I want to say it's about number 4 in terms of the list. Not to put anyone on the spot. In Cayman, about 4 or 5. So basically, imagine now you have, it's hot. It's more hot and more humid, and that's going to cause more upper respiratory illnesses and events, more asthmatic conditions, and you've got more Saharan dust coming over. So all of that will really affect the health. Impact also through socioeconomic systems. I talked about food and water insecurity, conflicts due to resource scarcity. Forced displacements, let's talk about that in a minute, and mental disorders. But I'm going to come back to forced displacements and the mental disorders when we talk about the Cayman context. And all of this leads to climate change, social and behavioral context, and health system conditions. Okay? So what are we going to do? What are the direct impacts? You talk about heat with increased cardiovascular disease deaths, temperature effects on foodborne diseases, and so on. Sorry, should put the next slide. Extreme rainfall, sea level rise, injuries that come with that, and so on. Health determinants and health outcomes. If we have destruction of health infrastructure, that's a main thing. And so obviously, Dr. Williams, Ms. Lizette Yearwood and the team have to look at continuing after a disaster. Fatal and non-fatal injuries, there's a lot of that could go on with temperature and precipitation effects. One only has to drive by a construction site anywhere here in Cayman in the middle of the day when you're, say, popping home to your AC house for lunch, and see those guys, mainly men, some women, working on a site, and you just go, oh my goodness, how are they out there? So little things like policy, split shifts, starting earlier, longer lunch like a siesta, working later. These are all things we have to start thinking about from a policy level. So all of the health risks previously stated are strongly affected by non-climatic determinants as well, such as socioeconomic status, your age, your gender, your ethnicity, displacement or disability. Climate change disproportionately affects poorer populations and children, and for some risks, in some situations, differ between women and men. And climate change will exacerbate inequalities in health. Who are at the highest risk? Children. Hands up if you have nieces or nephews, grandkids, children who are really concerned about climate change. Okay, so I heard a young person the other day say to me, what is the point? Not what is the point in terms of what's the point of doing anything, because the person knows they have to do something. The 16-year-old that said that knows they have to do something. But even if we do something, it's too late. Like, that is now what some of these teenagers are thinking, and that is scary, because here's what we looked at in another slide earlier. We looked at world wars and how that affected various things. But with world wars, they were in certain areas of our globe, and they were politically brought about. This climate change issue is talking about the very breathing, living ball of rock that we live on. Like they're all saying in the media, there is no planet B. I even believe Fox when they say that, although I don't watch Fox. But there is no planet B. So children and teens are the ones most exposed to all of this, and the ones left to sort the problem out. Okay, so they face the highest burden. So what specifically can we expect more of? Heat strokes, dehydration, drowning and trauma, malnutrition. I mean, what happened in Bahamas was just heartbreaking. All of that from that hurricane. Malnutrition, growth retardation and delays, and increased risks of infectious disease, Again, I mentioned respiratory problems and immunosuppression and skin cancers due to, again, the ozone layer issues and so on. All right, let's switch now, coming more local, regional to the Caribbean experience. Sorry. So the Caribbean experience, I don't need to tell all of you because I see Danielle in here. I know she's been working with hazard management and just has experienced a lot of these things across our region. You know, we're all really experiencing this in this region if we've lived here for even a year. And it's not just Cayman, it's not just our close neighbors, it's just knowing that we live and work amongst people from all over the Caribbean and knowing that their homelands are affected too. The last bullet point, between 1966 and 2015, 60% of all climate-related disasters in all small island developing states all across the globe, 60% occurred in the Caribbean. So other SIDS, like the Maldives, are experiencing a lot worse when it comes to sea level rise and disappearing land, more so than perhaps we are right now. But we in the Caribbean are facing more of the disasters and related disasters. Nasolo Thompson with PAHO wanted me to highlight the increased leptospirosis cases between 81 and 2007. And that's an increase that is directly apparently attributed to climate change. And she also wanted me to point out these, you know, I've mentioned the storms and what's happening with the warmed climate. So I kind of think just knowing they might be coming more and more often and stronger causes a lot of undue hardship and stress when you're planning for everything. Our region accounted for 90% of all deaths, 79% of all affected persons, and almost 90% of all damage costs within that period, despite our island's small carbon footprint and emissions. And again, they're talking about small island developing states. So again, it's much more so a threat to us and other SIDS as opposed to the larger countries that are contributing most to the issue. It's also our livelihoods, the tourism industry upon which we so heavily rely, our culture, you know, just think tangibly of some of the old houses that could be washed away and destroyed, or if we don't have funding towards saving those kind of things because we're so focused on raising roads and shoring up systems to support climate change, it's going to draw the economy and the money away from everything else. Right, so here are, I'm a bit midway point. We're soon going to get into the Cayman context. But let's look at what 2 meters sea level rise on Caribbean countries will do. I just want to again remind you that I am not a scientific expert in this. This is somebody else's slides. Very important though, because 2 meters sea level rise is not outside of the realms of possibility at about 2100. So again, it's more our probably grandkids, grandnieces, and nephews that will be affected, but a couple generations, not that far. They're saying that basically, the experts are saying over 3,000 kilometers square of land lost could be lost in low-lying places such as the Bahamas and so on. Remember we talked about displacement? Who will have to leave because they're living in low-lying areas and go, not just move within their country, but move to another country and become refugees, climate change refugees. Look at all the tourism, multi-million dollars of tourism income lost. Some of these are really alarming. CARICOM, right, and we're an associate member state, but the main CARICOM states, they think they may lose, if they had the 2 meter sea level rise in a generation or two, they think they may lose 31 airports. That's 42% of our region's airports. So what's that going to do to us living and working and enjoying life here? And then they talk about seaports as well and the loss of those. So it's not the most, it's very sobering, but it's important to kind of have it come home to us. So where are we, our health community, you all here? You have a critical role in the response, okay? We need a broad public health approach, which is what Dr. Williams and his team, Timothy and the rest are leading, which not only looks at preventive and curative that are under direct control, but also we really need to lean on our leaders. It needs to come from the very top. I'm not going to call his name, but there's somebody in the Cabinet Office who deals with policy, and we really, really need to make sure this is seen as front and center of, he's here in the room, of the government priorities. Because as I say, at the end of the day, this is one globe that we're on, and this is the actual, this is kind of survival of the species. This is very big stuff. There's no way to minimize this stuff, and more scientists and health practitioners are coming online with this. So mitigation and adaptation, we can, again, focus on reducing emissions. I'm not going to read out everything, but what can we do with hospitals? We can make hospitals greener. I'm sure at the question and answer session we can talk about that a little bit. We can strengthen our health system resilience, right? Adaptation plans, assessment plans, climate risks, and so on, early warning systems. We can train people. We have to start talking about climate change. When people are coming in and they're saying what they're worried about or what's happened to them, we need to start making this part of our daily vocabulary in the healthcare industry. Energy, intersectoral actions, co-benefits. I'll talk about that in a little while, but we really need to be looking at, this is not just an issue for a ministry that takes care of health and environment. It's not just an issue for infrastructure and building better roads and pavements for people to be able to drive higher up, or even better still, walk or ride their bikes safely. This is about every single ministry and subject field in government and the private sector that there could possibly be. This is a real joined-up approach that's needed. Climate-informed health programs. So I'm sure you've heard the expression health in all policies, so we also need to make sure the health programs are all climate-informed, okay? Because we are going to see more and more of these health events, and the doctors can speak much better to that, but everything from, let's start from the very top, headaches, stroke, heart, upper respiratory, heat disorders, skin issues because of the higher prevalence of cancer, skin cancer, and so on, and stress, overarching stress. So all of this is due to climate change. Just to drill down into one of them, if we look at public health programs, we can revise service delivery to respond to the risks. So for example, there are regular activities and programs that they do with public health can be reviewed and updated to consider seasonal trends, and so short-term and long-term climate change trends as well in all their operations and right across the board, which is why we're so grateful for various groups. Dr. Williams chairs one of them, the remind me, the one that MRCU is in, the surveillance committee, so that we can really bring all the sectors together to see what's going on. And where are we with this now in the Caribbean? I mentioned I went to Grenada, and last year this time, actually at the time of this conference, and shortly after, what we did with that was we pulled together a Caribbean action plan, and that was published in May of 2019. It's easy to download from the PAHO website. They talk about empowerment. Don't feel helpless, let's do something about it. They talk about evidence, right? And a lot of people have talked about that today, data and evidence, implementing it, and the biggie, resources. We need to promote health issues. Intersectoral is big. We need to strengthen educational and research capacities to inform decision making. It's not just an add-on. This is not something that we can tack on. This is something that needs to be mainstream and happen really, really quickly. I'm sure you all have watched Greta Thunberg. I think she had some quotes similar to, actually, no, I want people to panic. People don't go out of the room panicking and say, I said so, but we all need to have a collective sense of serious urgency about this matter with health. So empowerment, evidence, implementation, and resources. We need to look at national and local actions, regional and global actions, and what are the indicators. And to this end, I'm pleased to say we've made a lot of progress in the Cayman Islands, both before and after this was launched, which is available on the website in St. Lucia. Right, there's an action plan for the Caribbean. And what are the next steps of the action plan? COSHOD, CARICOM's Council for Human and Social Development, and Cayman Islands being an associate party to CARICOM, does become involved with their meetings. The 25th Conference of Parties for the UN's Framework Convention on Climate Change, very long acronyms here, pre-COP meeting in Costa Rica in October, and also one in Chile from the 3rd to the 12th of December. Ironically, you have to take jet fuel to get there, so we're trying more and more to do like attend remotely and so on. And then what can we do to mobilize all of our resources for implementation? So I mentioned Ms. Greta. I think she's just yesterday been nominated for a Nobel Prize. Hands up if you saw her speech. After the fact, before the fact. Yeah, so it was really inspirational. I don't even know. I would just recommend you just go and watch it. And she's just a trailblazer, and I'm finding more and more youth today are blazing a trail like it used to be, kind of a little patronizing. Oh, well, the youth will show us the way, but actually they're really showing us the way now. It's fascinating. There's a group of 3 in Cayman that do that as well. They're all at CIS at school. Some have gone to university now. Let's look at the global context. Here's one of the biggest issues with climate change and health, is what they're terming now eco-anxiety or ecological grief. Yes, it is a thing. The recommendation out there apparently is to adopt a climate change lens through which we can see how the crisis is increasingly shaping the world, which can bring people to therapy. We help people understand their distress. These last few slides I added, so this wasn't from PAHO, but I was allowed to add a few slides. People worry about, and the healthcare practitioners, relationship fractures and personal distress stemming from the crisis. For example, teenagers might think, well, gosh, thanks you guys, I get to inherit this and you all did it, and aren't you worried that the biodiversity is doing this and that maybe my grandchildren can't grow up in Cayman like you did because of sea level rise and whatever. So there's all this stress, and it's actually got a name. I didn't know that till a few months ago, eco-anxiety or ecological grief. I mean, you just don't want people to feel helpless. You want them to feel, okay, this is a major problem, but let's do this about it. So I imagine a lot of people will be looking at this in university courses and so on, what to do to adapt. So now let's switch to the Cayman context. There was a study, I've put a link to it there, and all these slides are available on the website. In 2017, that's the one I'm going to go by, although there have been recent ones going around on Facebook, but as I say, I couldn't really track where the study was coming from, so I didn't include them. Those ones were a little more alarming. That was this week. But the one study in 2017 showed that assuming the fossil fuel use for combustion keeps going, right, the way it has been, and there are not urgent changes made, that it projects sea level rise up to, I'm going to take the meters, okay? 1.3 meters on average. And an extreme scenario with as much as 1.8 meters by 2100. So again, that's 2 generations down. And they're saying best case scenario 1.3, extreme 1.8 meters of sea level rise, okay? So just call it under 2. So the worst case scenario would be, which we're not hoping for, we're hoping for the 1.3 or even mitigating that further down. It could mean rapid sea level rise of up to 0.75 inches per year by the end of the century. This particular study also concluded that the Paris Climate Agreement emissions scenario, if met, would result in a median 20 inches of sea level rise by 2100. So they're saying even if we can keep global warming to a certain degree by reducing these emissions and so on, that there still will be this 20 inches of sea level rise, and that is referred to Mooney. So this next slide, again, please do not be alarmed with this, because this is taking the worst case scenario. I gave you 2 scenarios before. One best case, one more alarming. This is out there. This is on a reputable, I don't know how reputable it is, but it's ArcGIS, sea level rise projection for the Caribbean. This is their projection for if there was a 5-meter sea level rise. This is very much a worst case scenario, and I'm not going to say anything one way or the other about it. It's out there on a website. extreme scenario, worst case scenario, sorry, shows most of the Cayman Islands except for the Brac, which of course has a bluff, the little island on the right, shows most of us inundated with water. So obviously we don't want to get there, and that's obviously one person's interpretation of the very worst case scenario, not even the extreme or the best case. But it's just to kind of show, how much it brings it home. Also in the Cayman Islands, earlier this year, we had Nasolo Thompson come with these colleagues, Dr. Daniel Bus and Adrianus Vlugman, and they came to talk with Evelyn Porter and about 50 practitioners from relevant authorities, departments, units, but also the private sector and advocacy groups and just people who were really keen on this, the National Trust and so on, to talk about this, to talk about climate change and health. And that was a real eye-opener. As I said, we've had other things in our context. We've had advocacy, we've had activism. This was just, I think, earlier this week or last week. Kids talking about climate change, and we've had a few of them now. So they're really getting activated on that. Earlier this week, we had National Trust had a speaker series, and they focused on climate change. So again, it's very, very topical here. And finally, last but not least, in our context, right, we talk about what we're going to do for Cayman. So yes, we have global issues, regional issues, and national issues. And to the credit of the Department of Environment, they went about looking with a large group of stakeholders at what they called achieving a low-carbon, climate-resilient economy, the Cayman Islands climate change policy. You probably can't see it, it's not on there, but this was actually drafted and they invited all stakeholders. But again, back in 2011 when this was drafted, it was perceived as an environment thing. Oh, the birds will suffer, mangroves are going to suffer, whatever's going to suffer. By the way, mangroves make amazing buffers for shoring up our land, so we really need to save those as an aside. But that stalled. That wasn't seen as super important those days, and hardly anyone contributed to it except for the environmental side, the health a little bit. So now, to the credit of Gina Petrie-Banks, the director of DOE, and her team and others, we're going to reconvene as a group and really make a go at making a national plan with all the various stakeholders involved. So thank you very much for your attention, and hopefully we can all do our part to spread the word on this important matter and make sure that we can leave things better than we find them and become just a little bit more alarmed so that we can do better for the Cayman Islands. Thank you.
Thank you very much, Ms. Nancy. We appreciate you volunteering. Don't go too far. Volunteering to deliver this presentation in sort of short notice. And so we also have a present for you. Courtesy of her report. So nice. Thank you.
Thank you very much.
Thank you very much. Okay.
Thank you.
All right, so we have another presentation coming ahead of us, but I just want to say a little bit about the importance of One Health. Yes, hello? Yeah. Hold on. Any questions from I think there's a question here. We have a microphone right in the front here. There's a microphone coming for you.
Yes, I don't want to be scaring anyone, but people here who have been going to church and things, we learned that from very young age that all of this the Bible have predicted. You have predicted this. Yep.
All right, thank you for your comment. Any other question? There's a question over here.
Hi, this is for Lizette. As a hospital, we have a lot of waste products, and I was just wondering, is there a long-term plan to actually recycle anything at the hospital besides the batteries?
There is a microphone for Ms. Lizette here.
Oh.
Yes, actually, the health services has started in a phased program to do recycling. It is actually part of our strategic plan. So we too need to do our part.
Thank you, Mrs. Any other question on this?
Well, I'm just hoping that we're going to be scheduling more days where everyone can get involved on the island without, maybe going without driving a car, carpooling, whatever we can do, even how small it is, just so that we can feel like we're doing something besides what we're already doing, of course.
Yeah, I agree. I think all of us need to do a lot more when it comes. We sometimes have the sense because we're a small island, we don't contribute to climate change, but we do. So we all have to put our effort together in order to do that. Any other question? No? Okay, if there is no other question at this moment, before the presentation from Dr. Rood, I just want to make a few comments on One Health. There is a few people here who have shirts looking like this. All of these are members of the One Health group. One Health is a new concept of how to approach health. And I'm sure Dr. Rood will talk a lot more about that and give more details. But if you have any queries about One Health, you can ask any of the people here in the public with this type of shirt on. Before Dr. Rood's presentation, I want to call to the podium Mr. Demoy Nash. He's a senior policy advisor for agriculture in the Ministry of Education, Youth, Sports, Agriculture, and Lands for a few brief remarks. I think he's on his way to us.
Members of the Ed Table, to the conference organizers, to everyone present, pleasant afternoon. I'm here this afternoon to speak on behalf of our Honorable Minister, Juliana O'Connor-Conley, who is unavoidable absent today. And if you know the minister well, you know she's an eloquent speaker, so my task is very hard today. I'm going to speak on, as the gentleman who introduced me, food safety, food security. I'm honored to be one of the speakers at this year's staging of the Cayman Islands Health Conference. The issues of food safety and security are vital to the health and well-being of those who call this nation home. We in the Ministry of Agriculture welcome this timely discussion. Some time ago, the Pan American Health Organization, PAHO, outlined the leading cause of deaths in the Cayman Islands as diseases of circulatory and endocrine system, as well as nutritional-related illnesses. The Chronic Disease Risk Factor Survey 2012 also highlighted that almost 20% of the national budget for that year was allocated to the Ministry of Health due to the prevalence of non-communicable diseases. Since food security, ladies and gentlemen, plays a major role in a population nutritional status, it is logical for one to deduce that we in the Cayman Islands lack food security. But what is meant by the term food security? Food security, ladies and gentlemen, refers to the availability of residents access to sufficient quantities of foods of appropriate quality. It also refers to the adequate utilization and consumption of these foods and the stability of one's food supply. In essence, food security in any nation is only achieved once the majority of its population is fit and healthy due to easy physical and economic access to safe and nutritious food. We in the Cayman Islands are blessed to live in a verdant, tropical paradise. Our soil is teeming with nutrients and is ideal for the cultivation of numerous crops. Despite our optimal conditions, the diets of the majority of our population consist mainly of processed meats and foods with high calorific value, significant amount of salts, sugars, and fats. These poor consumers' preferences have resulted in prevalence of obesity and increased incidence of nutritional-related non-communicable diseases such as diabetes, hypertension, stroke, heart diseases, and some forms of cancer. Not only are these diseases costly to the affected individuals, they also constitute one of the main national public health problems here in the Cayman Islands. The impact of poor consumer preferences became most evident in 2014, when the Cayman Islands saw its food export bill jump from CI 138 million. In 2010, it moved all the way to 190 million CI. In the same period, data showed that the agricultural sector stagnated, with its annual output remaining relatively constant at about CI 9.1 million, and its yearly contribution to GDP just over 0.04%. Notwithstanding this modest contribution, ladies and gentlemen, the domestic food and agricultural sector has a vital role in the thrust toward food and national security, and by extension, the health of the people. Backyard farming, ladies and gentlemen, may hold the key as an important source of food and nutritional security and livelihood in the Cayman Islands. Backyard farming supplies and has the potential to supply diverse vegetables and fruits that are rich in micronutrients. It also holds the potential to supply an increased variety of spice, herbs, condiments, and crops of medicinal value. Although backyard farming already features prominently throughout the islands, we as a people must become even more self-sufficient and increase our domestic production by leaps and bounds to ensure that more local food is available for consumption. Increased food security and nutrition means an overall increased health within the population. Eating locally bolsters consumer confidence in the safety and the quality of our food. Our farmers will be encouraged to increase domestic production based on increasing demand for their produce, and this will ultimately lower imports and provide greater food stability. A sole reliance on import threatens the food security and nutrition of any nation. It also follows that any external shocks in trade food access will adversely affect food availability. It is evident, however, that all is not lost and hope is on the horizon for us here in the Cayman Islands. According to the draft document of the Cayman Islands Nutritional Security Policy and Strategy 2016 to 2025, more and more Cayman residents are already exhibiting changing preference and joining the worldwide trend of enjoying the value of homegrown produce. We as a people are now benefiting from consuming fresher, tastier meals while cushioning ourselves to some extent from price hikes and shortages. The Ministry of Agriculture plans to develop shortly a coherent policy that will address food security and nutrition. The overall objectives of a food security policy are to ensure that all people have continued access to sufficient supplies of safe foods for a nutritional adequate diet, and in so doing, achieving and maintaining health and nutritional well-being. The draft policy has put forward several strategies that can contribute to the overall health status of the islands. Prominent among these are the promotion of a healthy diet and lifestyle practices, and the adoption of a nutrition approach in estimating requirements and planning programs for meeting national food needs, affording domestic production opportunities to influence taste. Ladies and gentlemen, with these measures in place, we at the Ministry of Agriculture are certain that the Cayman Islands will achieve food security and significantly reduce the incidences of non-communicable diseases in the country. I thank you for listening.
Thank you very much, Mr. Nash. It's good to see that the Ministry of Agriculture and the Minister are so engaged when it comes to food security and food safety in the Cayman Islands. We know the importance that they have for all of us here. And also want to thank the Ministry for their support to this conference. And we hope that this support will continue throughout the years. Our next presenter is Dr. Kerry Rood. Dr. Kerry Rood presented in this year's One Health Conference. And his presentation was so impressive that we invite him to present in this one. And it seemed that he liked the Cayman Island a lot because he said yes right away. So we're glad to have him here. The topic of his presentation is the One Health, the veterinarian's role in combating antimicrobial resistant zoonotic disease and climate change. Most of you will be aware of the impact of antimicrobial resistance is having right now. And in the future, actually, WHO projects that antimicrobial resistance to become the first cause of death worldwide if we don't do something right away. So I'm just gonna read a short view from Dr. Kerry Rood, and then we'll just give him to take the stage. So Dr. Kerry Rood is an associate department head and has served as extension veterinarian at Utah State University since 2007. Prior to this academic appointment, he served as the Vermont State veterinarian and chief animal health officer. A 1997 DVM graduate at Kansas State University, Dr. Rood has been in mixed animal practice in Oregon and Utah. Kerry has received a number of awards, including Undergraduate Advisor of the Year, Utah Veterinarian of the Year, Teacher of the Year, and President of the Utah Veterinary Medical Association. As part of a team, Dr. Rood was instrumental in garnering professional, public, and legislative support for the USU School of Veterinary Medicine, a joint regional program between Washington, Idaho, Montana, and Utah. Kerry is from Cross Bay, Oregon, and raised on a family-owned dairy and beef operation. Dr. Rood married Rachel Taylor in 1989. I think she's here with us in Cayman. Welcome. And they have 3 daughters. If you get any spare time, you will find him road cycling or competitive pistol shooting. So I just inviting Dr. Rood to the podium and to deliver his presentation.
Thank you. I appreciate that. I'm honored to be here, and what a wonderful conference. A really well-organized, runs like a top. I really appreciate the effort that's been put in here, and you're taking health seriously here in the Caymans, and we really appreciate that, and it's recognized, I think, globally with the content of this program, as well as the expertise of some of the speakers, excluding me. I will tell you, however, that when we talk about climate change, one of my hobbies, and it's not easily recognizable when you look at me, is road cycling. So I like to get on my bicycle and ride around, and I've got the whole gear, the helmet, you name it, I've got it. And I was in a race some It was actually about a year and a half ago. And during the race, we're in this group of riders, and there's a little competitive tension. It was supposed to be sort of a friendly race. And we were arguing or discussing how many grams our axles weighed on our bikes and how much faster we could go. And then it just hit me. It was like an epiphany. You know, if I lost 10 pounds, I could go faster than buying the $2,000 titanium axle. Nonetheless, I had this brilliant idea that I needed a carbon bicycle. And I asked my wife for a carbon bicycle, and the answer was no. And if you're not familiar with those bicycles, they cost quite a bit of money. And so I thought I had compromised and worked the price down on the model and some of the components. And I again went to her and asked, and our family discussion was it doesn't fit the budget. So then I said, well, you know what? I'm going to appeal to her and her do good for the universe and the environment. And I said, you know, if I got that carbon bicycle, I'm sequestering carbon into the bicycle's frame. So I'm actually green. I'm 2 times green if I ride it. So I got the bicycle, and some months ago, she suggested that I hadn't been riding as much as I should, and I'm hurting the environment now because the bike's not being ridden. Well, I'm very pleased to be here, and it's a wonderful opportunity. My stay has been nothing but hospitable, and I really appreciate it. There are 2 examples that make the argument of why veterinarian or animal health should be included in this One Health paradigm, this idea that we should include people, planet, and animals, or environment, as we think about these issues. The 2 that are foremost right now to us in Utah is this idea about the dependence on opioids that we're seeing in our human patients and the crisis that's there. A number in the legislature got together and said, let's pass legislation to address this. And they forgot to include veterinarians. And an unintended consequence is that now we couldn't treat our canine, feline, and animals with pain medication because it was too difficult to get in terms of policy and regulation. So veterinarians weren't consulted in that legislative effort. The second in Utah is a little bit more recent, and that's they've legalized medical or medicinal cannabis for human use. During that legislative discussion and the legalization in the state of Utah for medical cannabis, they forgot again about the veterinarians. And because it still remains federally illegal, we as veterinarians in our Practice Act cannot discuss it. So if you as a client came in with your animal and wanted to discuss the use of medicinal marijuana or cannabis, it's illegal for us to discuss it. Now, I'm not saying prescribe it, I'm saying discuss it even. And so there's a couple of issues where veterinarians weren't consulted in the legislation, and I just wanted to highlight that. So I'm excited to talk a little bit about this idea that the animal health veterinarians should be included in the conversation. A brief agenda in front of you. We're going to talk a little bit about this, continue the discussion on population growth and global warming and that effect that we see in the world. We're going to look at land scarcity as well as some food security or insecurity issues. I appreciate a representative here from the government, Mr. Nash. By the way, I think you have a really good political future ahead of you. Once you started speaking, he really got into that voice, and it really came, that confidence came out, and I appreciate that. But that idea of having the resources available so that you can provide some community gardens and those hobby farms, I think you called them, spot on, particularly here for Cayman. We're going to talk a little bit about this idea of sustainability, and then I'm going to end with some conversation about CAFOs. Ooh, big evil CAFOs. These are concentrated animal feeding operations, and we'll look at some of the data. So as our population continues to grow worldwide, we see that there's been a an interesting decrease in the birth rate. So that's good news. Previous speaker mentioned that she likes to be a little optimistic. Well, here's some good news. Our population rate is actually decreasing. However, our population continues to increase. I will point you to the x-axis here on this graph. About 1802, Cayman had its first census. Do you remember how many people were in the first census here in the islands? 933, according to somewhere I read online. And so it was 0.9, it was 0.9, let me get back here with this pointer. It was 0.9 billion worldwide, but I thought that was an interesting census here. The global warming, I propose, is going to rise the tide, and we've heard some previous speakers here before. I assume it's the reputable source here in the islands because it said it was. Let me get my pointer here. The island's most reputable, trusted source just had an article here the other day that talked about the impact of climate change here on our small islands. I really appreciated this quote, and it said, while small island developing states contribute less than 1% of the global greenhouse gas emissions, you're going to take the brunt of it, is basically what she's saying. Is that unfortunately, these islands, you're going to take a lot of the brunt of global warming. And so I appreciate the voice that we're hearing coming out of the Caribbeans that say, hey, wait a minute, world, stand up, let's take attention here because it's really going to affect us. And I saw that worst case scenario that was pretty sobering. In this particular article here in a paper, suggested that a number of private structures would be affected, and if it raised, the sea level was to raise here in the Caribbean. Well, where's all the land? We just have more land we can put to production use if this global population is increasing, right? Well, this is interesting data or a chart that shows that we kind of have the land we're going to have in terms of what's available for production. Now, there are some gee whiz new technologies that come out that help us green up uninhabitable lands and that sort of thing. But if we look at it on a fraction, we sort of have what we have, and we need to treat it well. And compounded with that is the fact that we're losing, in developed countries, we're losing land that can be in production to developments and urban sprawl. And so that's really an issue particularly in England and in the UK as well, or that is the UK, and in the EU as well as in the United States. That's a big problem as we look at where are we going to grow these things as we move forward. Food security is an issue. And when we talk about food security, we sort of have it's not only protecting our supply from folks with nefarious intention, but it's also the insecurity that we have around food. 1 in 6 people in the United States, 1 in 6 children actually in the United States are food insecure. Don't know where their next meal's going to come from, or they have some anxiety that's associated with that. Here in the Caribbean, I found this that indicated that a number of the states are insecure as well in the population because 80% of the food that you consume has to be brought in. And we heard that earlier from Mr. Nash, that 80% of the diet comes from foods that are not grown locally. And so one big hurricane, some political unrest somewhere, and they decide that we're not flying anywhere, can really affect food security here in the islands. This is an interesting concept. Not only do we need more food in the future, but we need to reduce the waste of what we have. And as in the U.S. in particular, 40% of our food is wasted. Now, I've seen data that even put that a little higher depending on which population you look at. I work at Utah State University, and I go to the cafeteria and I see the sheer volume of food that's wasted by our students. and it's amazing how much is wasted. And we need to do a little bit better at reducing our waste, because if we can reduce our waste, then the burden to produce more is not as large. So if we can just reduce our waste, that is fantastic. Now, what is healthy and sustainable food production? We have to use this triple bottom line. I think you've probably heard that in some of your public health type conferences. And this is where we look at the environment, we look at human involvement in the environment, and we look at our the economic viability or vitality of our economy or of the environment as well. So basically, I tell my students it's the 3 Ps when we look at sustainability. It's people, it's the planet, and it's profit. And sometimes when you hear that term sustainability, profit gets thrown out of the window. They say, you know what? You shouldn't be profitable. Well, I'm here to tell you that if we can't get good agricultural if we can't have some profitability in agriculture, it's still not very sustainable. So it can be the best thing for the environment, it can be the best thing for the people, but if it's not profitable, it's not going to stay around very long. And so we have to find that happy median between all 3 of those components. So there is this upward pressure to produce more food. This is one graphic infomercial here that suggested that maybe we're going to have to produce 70% more food production to accommodate that 9 billion projected population by 2020 or 2050. And that ebbs and flows and depending on what model you look at. But the fact is we're going to have to produce more with less land, and we have to do it in a viable way on the planet and on the economy, etc. So these are some really large challenges and problems that we have here worldwide. I tell my students in an animal science class that I teach, I tell them right now, in fact, I was supposed to lecture today, but I haven't, so if anybody in the class is listening, hello, from the islands, it's great down here. And I tell them that these are actually, not only are they challenges, but they're opportunities, and I believe in the future generation. I actually think if we can get them off of video games, I think that they are wonderfully smart and bright, and they have resources that I didn't even dream about when I was their age. And I think that they're up to the challenge. We just have to, as the older generation, if we will, motivate, and they're actually motivating us, and so I think we're going to be in good hands. Here are some of the animal production issues that we see that could be challenges in the future. They include animal disease prevention and control, animal traceability, animal welfare, this whole public perception of agriculture. In the States in particular, and the EU, we're seeing this huge uprise in public perception of agriculture. And in some areas, it's a little bit of a scorn to be involved in agriculture. Imagine that. We have emergency preparedness. We have to be prepared for emergencies, and as well as this whole issue of antibiotic resistance. Let's talk about these challenges that we have and the opportunity we have to rise to the occasion and solve some of these problems. In terms of animal disease prevention and control, as the climate changes, as it warms up, we see the emergence of more diseases. And in particular, what's really scary is nearly 3/4 of all the diseases that are new to humans come from animals. And so we have this animal-human zoonotic type of a relationship that as global warming affects the planet, we're going to see new and unusual diseases that emerge. And we're seeing that right now. We can list a whole host of names here that start from SARS to Ebola to a number of these. What was interesting about how we looked at animal disease and prevention, in the upper left picture, we used the UK and foot and mouth disease as the poster child for disease prevention in animals. So foot and mouth disease is a viral disease. It's not hand, foot, and mouth disease. That's a human different disease. But foot and mouth disease in animals is very contagious. It can travel some distance on fomites or inanimate objects, as well as even in the wind and aerosolized form, etc. And we use that as the model. I don't know if it's the right model to continue to use. I think it's these more obscure diseases that are showing up that involve a human zoonotic public health concern that we're going to have to be concerned about. In Utah right now, because of our climate change, we didn't have a lot of leptospirosis, which is a bacterial or a spirochete disease that can affect humans that they get. You typically get it from drinking dirty water or being exposed to animals that have urinated in water, etc. And we just didn't see that in Utah because of how Utah is in terms of climate and humidity as well as moisture. But lo and behold, the last few years we're seeing an emergence of it. And the reason we're seeing an emergence is because we see more travel of pets. For example, in St. George this year, they had a huge leptospirosis outbreak of people who were traveling to this southwest corner of Utah, in St. George, Utah, and their pets were using a doggy daycare swimming pool. And the dogs, of course, invariably were urinating and defecating nearby, or some of that was contaminating the water. The animals were becoming sick. Lo and behold, their human owners were becoming sick. So this is an interesting paradigm shift in veterinary medicine and animal health, is deciding which disease we should actually plan for in terms of emergency response. There's that ugly mosquito that we talked about. And this is an interesting bug here. This is a tick, the Asian longhorn tick, that we didn't have in the United States, and suddenly we found it a few years inside of the ear of one of our sheep in New Jersey. And so which is interesting, because that particular vector has an Asian viral disease that causes fever in humans and can create quite a bit of more morbidity and some mortality. So the emerging diseases and disease prevention. Another item that we struggle with in the States is this idea of animal traceability. Where does, at any given point in time, can we trace back to the animal and what farm it came from? And this is really key for disease control and prevention. There are millions of cattle that are transported from farms to farms in the United States on a yearly basis. And at any given any given day in Kansas, there's over 30,000 head of cattle on the roads. On any given day is the average. Probably a little less when Nebraska and Kansas State are playing football that day, but nonetheless, there you can get some of the scope. And unfortunately, we're behind in the States in terms of disease traceability or animal traceability as it relates to disease control as well. Other countries are doing a fantastic job. Hats off to certain provinces in Canada that are doing a great job with disease traceability, and in certain countries such as the UK as well as Australia. They're light years ahead of us when it comes to this realm, and we need to do better in the States. This is a little picture, an app. You can go into some supermarkets where you can scan the steak or the produce, or in this case it's a meat counter. You can scan it and it'll pop up the farmer's face and maybe a little a spill about where the animal came from, etc. And people really get into that. It's this whole farm to fork continuum that they like to be a part of, and to know where their food comes from. And I think that's important as well. We're a little bit behind in the States when it comes to that realm. Now, animal welfare. Animal welfare is something that we're all passionate about, and I believe that we all feel strongly about treating animals humanely and in a welfare way. Unfortunately, sometimes livestock industries get an exemption so that we can produce less expensive protein and food supplies for the people. And we're seeing more and more public backlash from that. On the lower left-hand side, this is the ewes that were culled in Australia were put on these transport ships to take them up to Southeast Asia, and more regulations are being passed for animal welfare, et cetera. And that's only continuing to develop, increasing regulations when it talks to humane welfare of animals. This is not a small issue, because anytime the news has this type of a picture that shows up, that's really not very appetizing for the public, and they don't like to see that mass die-off of animals. And so in veterinary medicine and animal health, that's really something that we're on the that we need to watch out for and be ready for. Public perception of production agriculture is also strained. We see groups that don't understand, number one, what GMO is, a genetically modified organism. And most of the papaya you eat in the world is actually comes from a GMO plant. So that's an interesting fact. But we see more and more of this public upswell, and they're raising a voice in terms of the perception of agricultural practices, and we need to be cognizant of that. Agriculture does produce global greenhouse gas. Now, we can argue over what percentage of that is there, but I tell my students it's undeniable that greenhouse gas is emitted from the production of agriculture. And I'll show you in just a minute why that's the case. And emergency preparedness, I showed this last spring. What's interesting about this is we have some wonderful emergency things that can protect the animals. So here is a hog shed in North Carolina, and some flooding took place, and we saved the hogs. But does anybody know what that pit is that's underwater right now? That's the waste lagoon. So we didn't save the E. coli and the waste from running into the water. So this was breached, yet we saved the animals, which is great, but it's one of those interesting things about emergency preparedness that when I was a state veterinarian in the state of Vermont, it's not something that we thought about. We thought about protecting the animals. If the waste gets dumped, the waste gets dumped, et cetera. And so that's an interesting switch, or an interesting thing to think about when we look at emergency planning. All right, I want to spend a minute or two on antibiotic resistance, because this is really an emerging issue that I think affects both human and animal realm. In fact, I know it does. CDC in the States feels that this is going to be our biggest health concern. In fact, it'll kill more people than diabetes by 2050. Antibiotic resistance is going to be huge in terms of the impact on humanity going forward as predicted by the CDC. You've probably seen some of these diagrams before, and what I really want to highlight today is this picture here of this chicken. Why in the world is a chicken on a diagram about antibiotic resistance? And so let's talk a little bit about that. This graph here shows it shows up a little better on the thing than on my TV up here, and it's all there. This shows the number of antibiotics that have been approved in the United States from about 1992 to 2015. Those that are in blue or some shade of blue are what we call the medically important classes of antibiotics. Medically important classes are drugs that have human importance in them as well. So some of those we would include our tetracyclines and our penicillin and our cephalosporins, etc. Those that show up to me as salmon color or red are the non-medically important antibiotics. So there are antibiotics that have no human use. but yet we might use them in animals. And so as you can see, medically important antibiotics, both non-generic and generic, have made up a large portion of those antibiotics that have been approved for animals. And that just makes sense because they're effective. We know that they go through a lot of research and development, and often antibiotics that went through a human approval process also then could make it through an animal process as well. I mean, you have to repeat some of the data and some of the trials, et cetera, but yet if it's efficacious in humans, why wouldn't it be in some animal species, et cetera? So that just seems like a common pipeline. However, it's concerning because this is how resistance could take place. Our federal government recognized this issue, and the FDA came out in 2017 with our veterinary feed directive. And what the veterinary feed directive stated is that no longer could you use medically important classes of antibiotics for growth promotion or efficiency in food production. So we could no longer use those classes of antibiotics to increase growth promotion or increase efficiency in production. You still, however, could use those antibiotics if there was a disease or a health concern or outbreak. So what it did, and their stated goal was that they wanted to reduce the total tonnage or the amount of antibiotics that were delivered to animals via feed. And that's a common way to deliver antibiotics to animals is via feed, because it's much easier to do that on a mass scale than to bring in individually and give them pills or give them a shot, et-cetera. So feed is a common delivery mechanism. So FDA, well, what did it do? Did their stated goal happen? Well, the jury's still out, but we have seen an overall decrease in the amount of antibiotics that's given to animals. And this is the latest statistics since the rule came out. But we've had a 28% decrease between 2009 and 2017, and which includes between 2016 and 2017, a 33% decrease. So we've had an overall decrease in the amount of antibiotics that are fed to animals. And the mechanisms of resistance, we know that constant exposure to an antibiotic can lead to resistance. And there's different mechanisms that go into that, but the bottom line is the microbes have to be exposed to the antibiotic, or several of the mechanisms have to be exposed, and general selection pressures will present with a resistance population of microbes. Well, are animals the only problem here? I think animals have been a role in the development of resistance, but this is an interesting new study that came out, and they're looking at strep, agalactica, and these are human cultures, and they said, these are cultured from animals, and they're looking at the resistance genes, and they're saying, did the resistance gene come from the bug that was in animals or the bug that was in humans? And lo and behold, this data shed some light that resistance can go the other way as well. So if it originates on the human side, it can be transmitted to the animal population. Let me repeat that again. If resistance emerges on the human side, it can be transmitted to the animal population as well. So a lot of times we point fingers at the animal side first, and we forget to point fingers at ourselves. I asked my class an interesting discussion point survey. One of the questions I said, are you ever frustrated when you go to your primary care physician, nurse practitioner, or physician's assistant seeking an antibiotic to treat what you think is an infection, and you didn't receive an antibiotic or a script? Are you frustrated? 70% said they were. So there is some expectation when you have a fever, when you have a sore throat, that you're going to get an antibiotic. And I think that's an interesting public health dilemma, and I think we're doing a fairly good job. However, I would argue in the state of Utah, which I'm most familiar with, we're not getting that messaging out there, at least with this generation that's coming up. They're not hearing that. Okay, so I think we can do a little bit better job that just because you have a fever and a sore throat doesn't mean you need a course of antibiotics. All right, so food animals are bad for the environment, right? Well, let's look at some EPA data here on the lower left. This is from the U.S., and agriculture represents about 9% of the greenhouse gas emissions. Over on the UK, that's UK data on the right. Their sector is a little bit higher, 14.5%, but be careful. The states aren't necessarily better than the UK. It's how they sort of calculate some of that data, and particularly when we look at transportation as it relates to agriculture transportation or transportation, right? So you have to be a little bit careful when we compare countries. We got to make sure we're comparing apples to apples or methane to methane here. And so what's interesting, though, about the UK data is they do a better job of putting out which animal and what percent is contribution by the species of animal. And so you can see pigs and buffalo and chickens, etc. down there. Now, we need to talk a little bit about anatomy here today. So before you start yawning, let's talk about some anatomy on the digestive system and explain why this may be so. We know that because of God or Darwin, however you believe, the animals, that was a joke, by the way, animals have evolved or adapted with some unique digestion systems. So different classes of animals have some different digestive systems. You as a human, this lower left diagram is your digestive system. So you're a monogastric, meaning you have a stomach, and then you have small intestine that proceeds down to the large intestine, etc. And you have a very rudimentary, if even present, cecum. My wife claims I have a very large colon and cecum, but that's a discussion for this evening. So here are different digestive systems, and we've got monogastrics, we've got ruminants, and we've got what we call hindgut fermenters. What in the world is a hindgut fermenter? Well, those are animals such as ostriches, believe it or not, horses, as well as rabbits. Their cecum and large colon has been adapted or developed to be able to ferment plant material. And so their fermentation vat, if you will, is distal to the stomach, or the true stomach, or where there's low pH. Ruminants, on the other hand, they've developed a 4-compartment or 4-chambered stomach. And I have to be careful when I use the term stomach, but those compartments include the rumen, the reticulum, the omasum, and the abomasum. The abomasum in the ruminant is what we would say the true stomach. So it's the organ that has low pH around 3, just like your stomach. Right now, my pH is really low in my stomach right now. Hydrochloric acid is being pumped out by the gallons right now. Well, during that fermentation process, these vats, this rumen in the ruminants, we have 4 things that are created. We have bacteria, and the animal actually lives on the bacteria. We have volatile fatty acids, which are absorbed and utilized through the Krebs cycle and and other cycles. And then we have gas and heat, and the gas that's produced is methane. All right, so here's a question. I'll just have you think about it. If a ruminant, here I've got a picture of a cow, if a ruminant is to get rid of that gas, does it use flatulence or flatus? Does it fart? Or does it burp or eructate? So the cow eructates. So it's burping. So in the press you might hear cows are burping, causing global warming, right? And that's where this that's where that root of the problem is because that rumen is producing during the fermentation cycle, producing some gas. How do horses get rid of the gas? Yeah, when I was in a country called Azerbaijan, I was giving a talk very similar to this. It's a Muslim country on the Caspian Sea, north of Iran. And the interpreter would not say the slang word for flatulence. She would not. Evidently, it's not there, it's not proper, or whatever. Maybe I shouldn't be using that term, right? But the gas is emitted through flatus or through flatulence in a horse. All right. Whenever we hear about emissions of gas or greenhouse gas from animals, we've heard that before. Does anybody blame horses? But why not? You know, in the States, we have our lowest cow numbers since the 1950s. We have the lowest cow numbers since the 1950s. Yet, we have highest horse numbers not since the 1800s, right? But we have the highest horse populations we've had since the 50s. But yet the horses are never blamed. It's an interesting thing to talk about when you go to dinner tonight. All right. Well, let's talk about then some efficiencies in livestock production. Here are two graphs for you. They're basically telling you the same message. One is from National Geographic. The other one is from another source that I found. And it looks at what is that ratio of amount of feed to amount of gain. So the one on the right is edible protein, in essence. It's kilograms of edible protein. So the units on the right are in kilograms. The units on the left are in pounds. It's essentially the same message that says, in essence, to get a pound of meat from a cow, we've got to feed it about 6.8 pounds of food. Not very efficient. Okay? But look at a fish. We can feed it almost a pound of food for a pound of gain. That's like me at Thanksgiving, right? I'm trying to think of the like holiday down here in the Caribbean. I don't know if you have a Thanksgiving. There's probably something. Okay, they celebrate something. All right? I thought only I could gain for a pound of food, a pound of weight. Fish are very efficient. Does anybody want to blurt out why fish are so efficient? They're monogastrics. But why are they so efficient? Pigs are monogastrics. Why are fish so efficient? They don't have to regulate their body temperature. That takes a lot of energy to regulate your body temperature, and that's why they're efficient. They're more efficient. So I bring this into context to ask you, or to further the discussion of what is this carbon footprint of each commodity, and we're talking about livestock here. What's the carbon footprint of each commodity worldwide? And you can see some efficiency differences there, right? So the amount of greenhouse gas, in this case it's CO2 that's emitted, the kilograms of CO2 that's emitted. Couple of points. Because of their digestive system, our cows and our small ruminants like sheep and goat are going to lose every time. Okay? Pork, chicken are more efficient. This is the root of some of the conversation of one day a week go to fish, or one day a week go to chicken. Instead of red meat, eat this other color of meat or whatever. And this is some of the root in that, okay, because there's lower amounts of CO2 that's emitted. All right, the other point here before we start with CAFOs. Do you see a range, though, that's presented? Right? So a lot of these charts, there's a range that's presented, and then in the bubble is the average. All right. So in the States, we have what we call concentrated animal feeding operations. They are CAFOs. You might have heard the term feedlot. So they're confined animal feeding units. And here are two examples. The one on the left is a beef feedlot that's in the state of Idaho, just north of where I'm at, about 150 miles. And then on the right is a dairy farm in the Midwest. And you can see those are concentrated animal feeding operations. And each of these little pins right here, there's at least 40 animals in each of those pins, probably more. I can't tell from the satellite image here how many are in each pin. So, do CAFOs hurt or help the environment? Well, your gut feeling might be they hurt. It's awful. They're like little nuclear waste sites, right? But here's some interesting data that says that when we produce beef by extensive means, so this is backyard, hobby, in pasture settings, you can see the range of the kilograms of carbon that's emitted. So it ranges from probably 18 or 15 clear up to 130. But when we use intensive agricultural practices, when we use intensive, and the term we use in these states is CAFOs, or concentrated animal feeding operations, you can see how much more efficient it is. On the right is a land mass use graph. What are pulses? So pulses are examples of the legumes and beans that our friends on the vegetarian side say that we need to eat to have a more a diet that has the essential amino acids, et cetera, in it, a little better protein profile. And you can see that, of course, that looks less, right? And so my argument today is not we should be vegetarian. My argument is to really evaluate when we make statements like concentrated feeding operations are bad, etc. All right. But are CAFOs all unicorns and rainbows, or rainbows and unicorns? This joke in the back, if you can't read it, says knock, knock. This is the unicorn that's saying knock, knock. What is that, a cockroach? It says, who's there? The unicorn says, unicorn. Cockroach says, unicorn who? And the unicorn says, unicorniest joke teller I've ever met. Doesn't make sense. I just thought I'd throw it in there. But they aren't all rainbows and unicorns. CAFOs have their challenges, particularly on a local level, with local runoff, air quality issues, odor issues, etc. So they still have their challenges. All right, in summary today, we've talked about a number of things, but I hope that I've made the argument that veterinary health, or animal health, veterinary medicine should be included in some of these global challenges to provide a different perspective. And together, then, we can work to help save the world. Thank you.
Thank you, Dr. Rood. Any question for the answer? Any question for the public? Yeah, there's a microphone in the front.
I just want to ask, when they sell chicken here or in the States? Yeah, that they have this chicken and they say they are antibiotic free and hormone free, if that's always be true. But what do you think?
I assume that directed towards me. So it depends. In the United States, if they have some specific labels that say that they're antibiotic free and they're hormone free, then that means the FSIS, the Food Safety Inspection Service, ensures that that's the case. So they're doing some testing, but they can't use antibiotics or hormones in the production of this chicken, I assume was your example. So that is tightly regulated in the United States. I will tell you, after the veterinary feed directive, there is a lot, the quantity of antibiotics that are fed to chickens, it's much less because we no longer can feed antibiotics for feed efficiency reasons or for production efficiency reasons. Oh, now in terms of hormone free, I don't know if you can have an animal product that's hormone free. Right? Because they naturally produce hormones, okay? And in fact, there are hormones in plant products as well. So I think what the point here is it's not added hormones or added antibiotics.
Dr. Ruth, thank you for that very interesting presentation. And I just have a question. When you talked about the different parameters of what various different animal types have an effect on the environment, both with the land use and, I guess, fossil fuels contribution to the globe. You know, I understand, yes, if you consolidate the animals in a small area, is that CAFO? That would be more beneficial on various levels. But what about on the actual humane treatment or welfare? Can it be that we have CAFO as well as not marginalizing the animals' welfare? Because, you know, you see those videos about dairy farming and, you know, caged up chickens, and you just want to make sure their lives are a little happier before they're used to consume as food. So I was just curious, can you have them both?
So as I understood your question, can you have these larger size animal production units but still maintain welfare for the animal in terms of needs, shelter, et cetera, and then not abuse, obviously? And I would argue that you can, and I would argue that, or I would state that those that are caught doing those horrible things that we see, they are condemned by the producer groups, they're condemned by the veterinarian groups, et cetera. The fact that we don't have more of those videos attests to the fact now that the commodity groups have third-party verification programs that will help them with best practices. So, for example, on the beef side, we have beef quality assurance. Surprise, surprise, on the pork side, it's called pork quality assurance. On the dairy side, it's called FARM, F-A-R-M now. And these are all standards then with third-party auditors that come in and make sure that they're using best practices, et cetera. Do we have a few rotten apples that emerge? Yes. And unfortunately, or fortunately, it's few and far between. I mean, it's not every day we see the video. They do pop up and we remember them, but fortunately, it's the exception.
Good afternoon. Thank you both for the presentation. I had a question, Mr. Nash. Has the government thought of, or is there any kind of plan in place? For example, in the U.S., I know especially in southern states, if you have cattle or livestock on your property, you get a tax deduction or perhaps even an incentive. While we don't have direct taxation, there's duties and so forth. Has the government thought of any sort of plan for agricultural usage of property or land here in the islands where you can get some sort of credit or benefit out of such an endeavor?
To answer your question, not that I'm aware of at this time. There is no facility currently to give any benefit for that sort of use currently. What I know that the ministry is looking into is to find more agricultural lands for the farmers in the island. So I know there's a policy that we're looking at. Can't speak much to it since it's in its infant stage, but the plan is afoot to have whether we're going to call it an agro park or but some families program where farmers can benefit.
Any other questions? No. So thanks everyone thanks again, Dr. Rood. I just want to make a comment. It was interesting to know about your presentation where you said not taking into account veterinary when we do these new policies and laws and regulation. It's important we have some government officials here throughout the days, and we have so acting chief officer and Ministry of Health. So it would be good to keep in mind that we have to include members of the veterinary team and also from the environment when we're doing all these different policies. I think a good example of that is you mentioned Ms. Nancy had mentioned the Communicable Disease Surveillance Committee in the Cayman Islands, where it's a multidisciplinary committee which also do have a member of the Department of Agriculture, specifically a veterinary officer who is here with us today. So I want to thank you again for that presentation. I think it was really interesting. And we do have a present for you. We'll hand it to you right now. Now Ms. Nancy gonna just give you some guidance on what is next.
Thank you very much, both Dr. Rood and my colleague from the Ministry of Agriculture. It's nice to know that these things are progressing within that ministry, as it's also multi-sectoral, all needs to come together. We're a little bit ahead of schedule, which is different to this morning. We were a little bit behind schedule. So I just want to add one thing that, just food for thought, which is one of the things that came out of the workshop we did for climate change and health, which is basically that we would like to do some sort of overlay. I don't know how the medical professionals and the lab technicians feel about this, and I know it's really, really complicated. It sounds easier than when you actually do it, but it's an overlay so that we can see where the health events, such as heart attack, stroke, heat exhaustion, cancer, and so on, where that merges is overlaid with the climate issues. So, for instance, I'm not quite sure how you're all going to do it, but it's going to be very complicated, but somehow our weather meteorological office has to mesh up with the health service providers and data people and figure out, okay, did this one heat wave cause that intake of patients? Did this one event cause these other certain things to happen? So that we can really match and see how much that's happening in Cayman. So that's quite interesting. Backyard gardening is a huge thing here in Cayman. I'm really interested in seeing that progress, and our agriculture background is super interesting too. And Dr. Rood, I appreciate that you weren't polarizing in your message, because sometimes it's like the vegetarians kind of going against everybody else or vice versa. And we have jokes in our family because my husband's South African and he's a big meat eater, and my daughter and I went vegetarian for a year. But you can find a happy medium. You can eat, live lighter on the earth, eat meat, red meat once a week, and eat the chicken and more veggies other times, and so on. So there's ways to meet in the middle with everything. So thank you. And now we're going to break for the afternoon workshops. These are interactive workshops where delegates and panel members will be interacting quite heavily with each other, which is going to be more exciting in terms of the intimacy that provides and the really direct contact. So at that point, I would ask those that are staying in this room to move up. The first one is called One Health, People, Animals, and Our Shared Environment. That will be taking place next door in the Grand Cayman Room and is sponsored by Jackson International. And when you go through there, just try and sit as close as you can to where the speakers are going to be sitting so that it can be quite intimate. The Living with Invisible Illnesses workshop, sponsored by Baptist Health of South Florida, will be taking place in this room. And if you're going to remain in this room to hear that, I would just invite you all to come more to the center and front where you're able to. These sessions will end at approximately 5:15, and somewhere in the middle there'll also be a coffee break sponsored by Hope Academy. I want to thank all of you for coming today and also yesterday. It's been an amazing day, and we have these really interactive workshops coming up after. I hope you've all thoroughly enjoyed yourself. Thank you to our Premium Plus sponsor, Ironshore Pharmaceuticals, all of our conference sponsors, so many, and all of our exhibitors for contributing everything that you have over the last day and a half. Tomorrow morning we'll get started at 8:15 a.m. with a breakfast sponsored by Marsh. And Dr. Anas Shetty will be opening with his presentation on the topic, The Digital Future of Healthcare and User Innovation at 9 a.m. sharp here. We will also hear from Dr. Jason Markle tomorrow, speaking on how Cayman innovation is redefining orthopedics. And tomorrow, our final presentation of the conference is going to look at disaster risk management through a health lens, very much on topic with what we've been talking about today. That's by Professor Virginia Murray. And then in closing, a few remarks by our very own Minister, Honourable Dwayne Seymour. Now, if you're not planning to be with us tomorrow, on that recycling question we had from over there from Ms. Lizette, we can only recycle plastics 1 and 2 in Cayman, although plastics go all the way up to number 7. These, I understand, are recyclable, so if you're not coming tomorrow and after tomorrow, you can drop them in the recycling box that's here. And also remember to fill out your evaluation form. And hopefully we'll see all of you back tomorrow, but if you can't make it, I hope you've really enjoyed today. And thank you to everyone for your speaking today as well. Thank you. It's yours? Okay. Ooh, that's so nice. You all have money.